Dr. Maria, Dr. Paljor, and all the delegates, those who have logged in. It's my great pleasure to welcome you all on behalf of CMRE, ASD, and DIPSI 9th International Conference, which we are organizing virtually this year. Yesterday, it was the day 1 on Saturday, and today is the day 2, that is 6th of November, Sunday morning. We all know that vision of CMRE has been to promote continued medical education and impart training for upgradation of knowledge and skills to all medical and healthcare professionals through various webinars, conferences, symposium, which we have been organizing over last 9 years. This is 9th in sequence. This is for the 3rd time we have joined hands and partnered with ASD and DIPSI to go internationally. And we know that we have a lot of logins. We registered close to 5,000 delegates, and we had a lot of logins yesterday also from Middle East, from UAE, from part of Egypt, as well as UK. And aim was that with ASD, we have been able to break those barriers and you may say, bridges. We have been able to make bridges across different ethnicities because there are problems related to individual ethnicity in different zones. And we try to pick up very good faculty from ASD also. Yesterday, we had a 2-hour symposium where we were able to address their issues to great extent. And from our end also, we did our deliberation. So that is how we have been sharing knowledge and inputs from various zones across the globe. And we have 2 wonderful international speakers from US. Dr. Dendona did a keynote lecture yesterday, and today also in the night at 8:15, he has a keynote lecture. We have Professor Devjit today also again doing a keynote address. And similarly, we have a lot of international faculty from UK and of course, Egypt, again doing a lot of deliberation today. We have a CMRE gold medal oration today listed at 1:30 p.m., which we are conferring upon Professor Inas Sheltout. She's an ASD president also. And along with that, we have more than 60 national KOLs from India. Every who's who in diabetes and endocrinology is part of this conference. So I'm sure all those delegates, those who have logged in on this virtual platform, I think we know that norms have changed since COVID-19. So we use this opportunity by being on a virtual platform and sharing our knowledge, inputs, and interacting with international faculties across for the benefits of a lot of delegates. With those small words, I open this conference for today, and I request Professor Panikar and Professor Paljor to take over for the proceedings. Thank you very much. We may start, sir.
At the outset, let me congratulate Rajiv and his entire team for putting up this wonderful show and having me on the show. Right. I think the first talk will be by Dr. Maria on inflammation in diabetes. He's an MD, FIMS, PG diploma, senior consultant physician. He is chairman of RSSDI Delhi chapter. He's a teaching faculty in many courses. He has got a lot of orations, published a lot of papers, and he's written chapter in the RSSDI update, emergencies in diabetes and endocrine. He's an active participant and investigator in several studies. Without much ado, I would request Dr. Maria to proceed with his talk.
Thank you, Dr. Panikar, for that short introduction. And with that, I think I'll be sharing my screen. Where is it? Yes. Is my screen shared?
Yes, Dr.
Yes.
What is this? At the outset, I'd like to thank the organizer, Dr. Rajiv Chawla and Dr. Shalini Jaggi, for having given me this opportunity to be a part of this wonderful conference. And it has been really very informative and educative. I joined the session last day. Yesterday, it was wonderful. So I congratulate them for this wonderful organization of this conference. But my today's brief is to talk about diabetes and inflammation. So let's start with this. And the diabetes, as you all know, is spreading the world over at an epidemic proportion, more so in developing countries like India. According to WHO, it was the population of diabetes was about 108 million in 1980, and by 2014 it had increased to 422 million. And according to the IDF, by 2021 we had 537 million diabetics living the world over, and the projection is that the number would increase to 643 million by 2030 and 783 million by 2045. This is a huge increase in the number of diabetics. And what really has changed? Definitely, it has not the genes of ours which have not changed over the last 100,000 years. It is we people who have changed. We have developed a very sedentary lifestyle. We are more stressed out. We have plenty to eat, and plenty to eat the very wrong kind of food, which you can see over here. So all this has led, and it took us ages to evolve to this stage, but only a few decades to evolve to this stage where we developed a pot belly and central obesity because of our wrong kind of habits and eating habits and sedentary lifestyle, not because of change in our genes. And believe me, this waste is truly hazardous. It is responsible for contributing to increased inflammation, both systemic and vascular, increasing the risk of insulin resistance, hypertension, and diabetes, as we'll be discussing in the coming slides. So, as the adipose tissue earlier was just considered to be a storage depot for the fat in the form of triglycerides, and in the fed state, and it used to release the fuel in the form of fatty acid and glycerol when there was fasting. But now the concept has changed completely. It is now considered to be a very active secretory or endocrine organ. It releases multiple bioactive substances which have a significant effect on the structure and function of several other organs. And as you can see here, this is a list of whole lot of secretory or the active factors or adipokines, as we call them, released by the adipose tissue, which contributes to increase in both systemic and vascular inflammation, increase the risk of hypertension, atherogenic dyslipidemia, insulin resistance, type 2 diabetes, thrombosis, and atherosclerosis. Let's have a look at the key adipokines. The adiponectin, which is unfortunately decreased in intra-abdominal obesity, is anti-atherogenic and anti-diabetic. It decreases foam cell formation, decreases vascular remodeling, increases insulin sensitivity, and decreases hepatic glucose output. But unfortunately, its levels are decreased. On the other hand, the inflammatory molecule, the interleukin-6, and TNF-alpha, their levels are increased. They are both pro-atherogenic and pro-diabetic. They increase the vascular inflammation, decrease insulin signaling, and decrease insulin sensitivity in the adipose side. Whereas the plasminogen activator inhibitor 1, its levels are also increased, which is again pro-atherogenic and pro-coagulant. So from this, you can make out that these adipokines, the levels change in such a way that the whole scenario is more pro-atherogenic and pro-diabetic. As you can see over here, the risk of developing diabetes in this nurses' health study carried out in USA from 1986 to 1994, it was seen that the risk of developing diabetes increases linearly with the increase in the waist circumference. A woman having a waist circumference at 90th percentile had a 5 times more risk of developing diabetes compared to female having a waist circumference of at 10th percentile. So the increasing obesity does make a difference. As you can see over here, inflammation is linked to several diseases: rheumatoid arthritis, atherosclerosis, diabetes, and even pre-diabetes. As you all know, that as far as the risk of developing microvascular complications is concerned, the clock starts clicking once you develop diabetes. But the risk, as far as the risk of macrovascular complications is concerned, the clock starts clicking much before that in the pre-diabetic stage. If you see what is happening at this level, you see the insulin levels are still high, but yes, they have started declining. The plasma glucose levels are in the non-diabetic range. They may be higher than normal, but still not in the diabetic range. It is the insulin resistance which is peaked and plateaued off at this stage, which is high. So this increase in insulin resistance is responsible for hyperinsulinemia, endothelial dysfunction, developing hypertension, hyperglycemia, atherogenic dyslipidemia, increased inflammation, impaired fibrinolysis, and hypercoagulability, all promoting atherosclerosis. So let's have a brief look at the insulin transduction pathway. In this, you see these PI3K phosphatidyl inositol 3 kinase signaling pathway is responsible for regulating the glucose metabolism at the skeletal muscle, adipose tissue, and liver level, and also promotes the release of nitric oxide, which is a vascular relaxant from the endothelial cell. Whereas the MAP kinase pathway, the other signaling pathway, is responsible for promoting growth and mitogenesis, and also release of endothelin-1, which is a vasoconstrictor from the endothelium. In diabetic, the insulin resistance is pathway selective. It is the pathway selective insulin resistance is to the phosphatidyl inositol 3 kinase signaling pathway. So it leads to impaired glucose metabolism with hyperglycemia and decreased release of nitric oxide. So there's imbalance between the vasoconstrictor and the vasorelaxation elements. So as you can see over here, the endothelial dysfunction develops in this situation. There is decreased ENOS, decrease in nitric oxide production, increased nitric oxide degradation, increased endothelin release. So nitric oxide bioavailability goes down. There is increased expression of the adhesion molecules. There is the macrophage migrate to the subendothelial tissue is enhanced. And further over there, they release the inflammatory cytokine, that is TNF-alpha, interleukin-1 beta, interleukin-6. There is smooth muscle cell proliferation. There is increased platelet aggregation, vasoconstriction, and vascular permeability, all responsible for increased risk of atherosclerotic cardiovascular disease. So we can see that diabetes is not only a metabolic disease, but also a vascular disease. As you can see over here, the balance is very much tilted in favor of vasoconstriction, growth promotion, prothrombotic state, pro-inflammatory, and pro-oxidative. So other key mechanisms which have been suggested are for regulating inflammation in diabetes are hyperglycemia. Elevated free fatty acid promote inflammation by stimulating glucose utilization along with alteration in oxidative phosphorylation. This induces a pro-inflammatory trait in the macrophages residing or invading in the adipose tissue and other tissues including islet and vasculature. There is increased the glucotoxicity and lipotoxicity might also exert oxidative and endoplasmic reticulum stress. This elicits an inflammatory response by increasing the release of active interleukin-1 beta. And then interleukin-1 beta further amplifies inflammation by inducing the expression of various cytokines and chemokines. Obesity itself is associated with alteration in the gut microbiome, along with increased gut leakiness of bacterial wall lipopolysaccharides, endotoxins, that may further promote inflammation. And the RAS or renin-angiotensin system also plays a role in inflammation, insulin resistance, and vascular damage. The angiotensin 2 has been shown to induce expression of chemokine monocyte chemotrectin protein 1, MCP1, and also increase in the IL-6, interleukin-6, leading to impaired mitochondrial function and insulin secretion, as well as increased beta cell apoptosis. So here you can see what happens in the hyperglycemic state when the glucose levels are high in the blood, in the cells which are prone, which are not able to dysregulate the entry of glucose into them. In them, there is increased mitochondrial overproduction of superoxide, which damages the DNA and activates the polymerase, which further inhibits the key glycolytic enzyme glyceraldehyde 3-phosphate dehydrogenase, leading to accumulation of the upstream molecules in the glycolytic cycle, which activate the 4 major pathways of hyperglycemia damage, namely the polyol pathway, the exosamine pathway, the protein kinase C pathway, and the ACE pathway. The activation of all these 4 pathways further leads to molecular damage, oxidative stress, increased inflammatory response, and change in the gene expression. So you can see inflammation contributes both to increase insulin resistance and decrease in the insulin secretion, thus further worsening the diabetes. So there is a strong correlation between the levels of insulin, this inflammatory markers and insulin resistance, and the level of these insulin markers are increased in the group of people who are subjects who are likely to develop diabetes in the future. Several prospective studies have studied the level of CRP, white cell count, and other inflammatory markers, and have found that the increased level of these inflammatory markers increases the risk of developing diabetes in future in certain groups, which independent of other predictors. So you can see over here that obese and overweight adults, obese or overweight children, westernized South Indians, Paima Indians, subjects without family history of type 2 diabetes, women with polycystic ovarian syndrome, and sedentary individuals are the groups at risk of diabetes characterized by elevated circulating levels of inflammatory markers. As far as evidence is concerned, there's ample of evidence available all over the world as for to suggest that type 2 diabetes is an inflammatory disease. We have obesity, diabetes link, and we have Indian evidence also presented by Dr. Ghosh et al. And he suggested that VAD, that is visceral adipose tissue, is a seat of chronic low-grade inflammation. Camerin and adipokine initiates inflammation by recruiting plasmacytoid dendritic cells into the VAD. This induces production of type 1 interferons and pro-inflammatory polarization of adipose tissue, adipose red and macrophages, leading on to adipose tissue, excuse me, adipose tissue and systemic insulin resistance. And then you get there's enough data to suggest the key role of TNF-alpha in insulin resistance of obesity and type 2 diabetes. The TNF-alpha expression has been found to be elevated in adipose tissue of multiple experimental models of obesity. And this is a potent inhibitor of insulin-stimulated tyrosine phosphorylation on the beta cell chain of insulin receptor and the IRS1, suggesting a defect at or near the tyrosine kinase activity of insulin receptor by this TNF-alpha. So neutralization of TNF-alpha may improves the insulin sensitivity. So inflammation is also a key factor for increasing the macrovascular complications. The pro-inflammatory conditions such as oxidized LDL, advanced glycosylation end products, they increase the secretion of the inflammatory markers, which influence all the process of atherogenesis, from increased monocyte adhesion to endothelial cell to increased risk of atherosclerotic plaque rupture. And suggested in this complication of diabetes adhesion by Dr. Rajiv. In this, the hyperglycemia is also linked to increased risk of CAD, and you can see over here hyperglycemia leads to increased age formation, PKC activation, and oxidative stress, as we have just discussed. Further, there is insulin resistance leads to hyperinsulinemia, increased activation of MAP kinase signaling pathway, and the PI3 kinase pathway is selectively signaling is the resistances to this signaling pathway. All this cumulatively leads to a dyslipidemia, a prothrombotic state, and endothelial dysfunction, injury, and inflammation, as we have discussed in the previous slides, leading to smooth muscle cell proliferation and eventually to increase atherosclerosis. Again, there's a strong relation of inflammation with diabetic retinopathy. Again, the same pathway you can see: hyperglycemia, age formation, and nitric oxide synthesis dysregulation, increased reactive oxygen species, activation of nuclear factor kappa, which is a transcription factor, leading to activation of increased secretion of TNF-alpha, interleukin-1 beta, interleukin-6, various chemokines, adhesion molecules, and inos, and leading on to endothelial cell activation and recruitment of inflammatory cells, eventually leading to increased vascular permeability and neovascularization. Similarly, The inflammation is linked with diabetic nephropathy is also there. So it leads to, studies have shown that relationship between pro-inflammatory cytokines and diabetic nephropathy. These are the cytokines. Cytokines are synthesized by the endothelial, mesangial, glomerular, and tubular epithelial cells. The interleukin-1 enhances the proliferation of mesangial cells and matrix synthesis, increase vascular permeability, leading to development of intraglomerular microcirculatory abnormalities. The interleukin-6 has a strong association with mesangial cell proliferation, increase in fibronectin expression, and enhanced endothelial permeability. The interleukin-18 induces the production of other inflammatory cytokines such as IL-1, interferon alpha, and TNF. Due to cytotoxic action towards glomerular, mesangial, and epithelial cells, the TNF-alpha may induce significant renal damage. The transforming growth factor beta-1 contributes to cellular hypertrophy and increased synthesis of collagen, which have a fibrogenic effect. Similarly, in diabetic neuropathy, diabetes-induced hyperglycemia, activation of all these pathways, which we have already discussed, leads to vasoconstriction, endoneural hypoxia, nerve conduction velocity impaired, leading to degradation and axonal structure. This sources from Dr. Rajiv Chawla compilation of diabetes complications. Then let's see what is the evidence that we have that targeting these inflammation in diabetes has any benefit. What are the newer therapeutic options? HCQS has anti-inflammatory action. It inhibits cytokine production, interleukin-1, 6, and TNF-alpha, reduces CRP level, inhibits prostaglandin synthesis, inhibits leukocyte activation, and inhibits leukocyte migration. In this prospective study carried out in population-based study carried out in Taiwan, it was seen that in SLE patients, the use of HCQ is associated with reduced risk of incident diabetes mellitus in a dose-dependent manner. On the other hand, in this randomized double-blind parallel arm study, again, the HCQ was shown to improve both beta cell function and insulin sensitivity in non-diabetic individuals. These metabolic effects may explain why HCQ treatment is associated with low risk of type 2 diabetes. Also, it has been shown to improve the adiponectin levels. So the HCQ has a very wide feature, and sure enough, the hydroxychloroquine 400 milligram is approved by the Drug Controller General of India and recommended by RSSDI, Clinical Practice Recommendation 2017, as an add-on therapy after metformin, sulfonylurea in type 2 diabetes mellitus patient. Well, let's see the evidence with other drugs. Now, this study was with the methotrexate was started to determine whether anti-inflammatory therapy with a low-dose methotrexate targeting 15 to 20 milligram per week as compared with placebo will reduce the rate of recurrent cardiovascular events among patients with prior MI and type 2 diabetes or metabolic syndrome. Well, this trial was reported in 2019 by Paul M. Ridker et al. And it told us that the trial was stopped after a median of follow-up of 2.3 years, as methotrexate did not result in lower interleukin-1 beta, interleukin-6 or C-reactive protein level than placebo. Among patients, and it concluded that amongst patients with stable atherosclerosis, low-dose methotrexate did not reduce level of interleukin-1 beta, interleukin-6 or C-protein, and did not result in fewer cardiovascular events than placebo. Then going to the biological anti-inflammatory therapy in type 2 diabetes, the TNF-alpha antagonists have been used to treat inflammatory conditions and have been associated with improved glycemic control and decreased incidence of diabetes, while more studies on patients with unfavorable cardiometabolic profile did not result did not demonstrate adequate result, with exception of few with a single randomized 6-month trial. On the other hand, large randomized trial with canakinumab, therapeutic monoclonal antibody targeting interleukin-1 beta, the CANTOS trial, over a median period of 3.7 years, did not reduce the incidence of diabetes in patients with prior MI and high hsCRP more than 2 milligram per liter. So to conclude, with ever-increasing prevalence of diabetes, research need to be focused on its prevention as well as its treatment. with better understanding of inflammation and the mechanism linking to it to diabetes and related complication, we need to target inflammatory pathways as a part of the strategy to prevent diabetes and control diabetes and its complication. Though there is a strong and a well-established link between inflammation and diabetes, and we need to do something to break this link. Thank you very much for a patient hearing. I think the question answer session is going to be toward the end of this symposium. Am I right?
Thank you, Dr. Maria, for a wonderful, concise, detailed presentation on inflammation and its effect on diabetes. It's very true. Inflammation is the hallmark. Diabetes is an inflammatory disease. Are there any questions in the chat box?
Sir, we may not get directly from chat box. You will have to initiate discussion in the end with the after all the speakers have done.
You can take over.
That is a different platform. Yeah.
So I unshare now, Rajiv?
No question. You please stay back.
No, I have to unshare now. Unshare the screen.
Yeah, unshare. Yeah. Dr. Paljor, she logged out. Sir, you may do. Dr. Panikar, sir, you may do.
All right. The next speaker is Dr. Pratap Jethwani, good friend of mine. He is an MD. He is also a fellow of RSSDI, associate editor of Indian Diabetes Educator Journal. He is a EC member of the RSSDI, recently elected. It is 2020 to 2022. That's wrong. He is a chair-elect of Maharashtra Gujarat chapter of RSSDI, organizing secretary for 2018 RSSDI in Ahmedabad. He has been past president of the Association of Physicians of Rajkot. He is a director and consultant specialist at Jethwani Diabetes Care Center. Over to you, Pratap.
Thank you, sir. Thank you, sir, for your kind introduction. Let me first thank Dr. Rajiv Chawla, sir, and Dr. Shalini and CMRE team for making me part of this 9th International Symposium of Diabetes. Let me share my screen. I hope my screen is visible.
It's not the full screen.
So today I will be speaking on exercise in diabetes. One size does not fit all. We all know that exercise...
Put it in slideshow mode. It's still not slideshow.
Okay, sir.
Just put it in slideshow mode.
Will do.
Can't see your slides, Pratap.
Just a minute. Is it visible now?
It is visible. Put it in slideshow from beginning.
No, I already put it in slideshow, sir.
Okay, you may do it. No issues.
Okay. So today I will be speaking on exercise in diabetes. One size does not fit all. We all know that exercise is an important part of physical activity with defined purpose, with defined health benefits, and it is necessary for all human beings, including people living with diabetes. In healthy individuals, exercise improves glycemic control by their action at the extracellular space at the level of cell membrane of skeletal muscle and also inside the skeletal myocyte. There is capillary recruitment, functional
Sorry, Pratap, your
sympatholysis.
slides are not changing. Please redo that. Slides are,
Okay.
yeah, now it is moving. Yeah. Now it is moving.
Is moving now? Okay.
Yeah, now you moved the slide. Yeah.
Okay.
You may do
It is
up
not
and
full
down
screen.
once and then may start again because.
Can Mahima just help out?
Yeah.
हेलो
Yeah, can you
सर
just help?
Yes, Mahima.
सर आप एक बार स्टॉप स्क्रीन करके वहाँ पे स्लाइड
Okay. So sorry for that technical glitch. I think there was some problem with my Zoom application. So I will be speaking on exercise, and I already highlighted that in healthy individuals, exercise works at the cellular level. There is functional sympatholysis and capillary recruitment, which contributes to increased blood flow to the exercise muscle so that enough nutrients and oxygen is supplied. So this happens through two pathways. One is insulin dependent pathway and second is insulin independent but contraction dependent pathways. Both these pathways, they work in healthy individuals and they contribute to glucose uptake by the cells, and thereby the blood glucose levels remain in the normal range. However, in type 2 diabetes, a lot of issues are there. There is capillary rarefication, there is endothelial dysfunction and reduced functional sympatholysis. Therefore, decreased blood flow, oxygen and glucose delivery to the muscle. Insulin dependent pathway is dysfunctional in these people who are having type 2 diabetes, but still the direct contraction dependent pathway is intact, and therefore it can contribute to glucose delivery to the muscle, and that may help in reducing blood glucose levels in this type 2 diabetic individuals with the help of exercise. Now, a lot of inter-individual differences in acute exercise adaptations in type 2 diabetes. particularly during exercise. I have already highlighted endothelial dysfunction, functional sympatholysis, capillary recruitment, everything is impaired. There is a lot of oxidative stress. There is mitochondrial dysfunction. Apart from that, there is alteration in brain insulin sensitivity. There is changes in prefrontal and hypothalamic cortex. There are alterations in sympathetic parasympathetic outflow, which contributes to alteration in heart rate and blood pressure response to exercise. And all this, they contribute to maladaptation to exercise in individuals who are having diabetes, particularly type 2 diabetes. Also, there are genetic variabilities and various phenotypes with either hyper respond to exercise or they are low responders to exercise. Types of exercise, we all know there are aerobic exercises, which includes walking, cycling, jogging and swimming, and there is resistance training or strength training exercises with free weights or which are being done in the gyms or which are being done with the help of elastic resistance bands. Flexibility exercises which improve range of motion around joints, particularly useful in elderly people or those who are having limited joint mobility and long-standing diabetes. And there are balance exercises which benefit gait and which help in prevention of falls, particularly in elderly people. Multi-purpose activities like Tai Chi and yoga, they combine various components of these exercises including flexibility, balance and resistance training exercises, and they provide additional benefits. As far as benefits of exercise is concerned, aerobic training is associated with improvement in insulin sensitivity, mitochondrial function improves, oxidative capacity improves, compliance and reactivity of blood vessels, lung function, immune function and cardiac output improves. In type 1 and type 2 diabetes, both it is associated with improvement in glycemic control, decrease in insulin resistance, improvement in insulin sensitivity, decrease in lipid levels and improvement in endothelial function. These are two meta-analyses which conclude that type 1 diabetes, if you do aerobic exercise, that is associated with improvement in HbA1c, BMI as well as in triglycerides. As far as resistance training is concerned, there is improvement in muscle mass, body composition, bone mineral density improves, the overall strength and physical functioning improves, insulin sensitivity, blood pressure, lipids and cardiovascular health improves. We all know that type 2 diabetes is associated with sarcopenia or low muscle strength. It is also an independent risk factor for low muscle strength as well as accelerated decline in muscle strength and functional status with aging. Therefore, resistance training plays an important role in people who are having diabetes to keep their muscles working and to keep their muscle mass intact. In type 2 diabetes, resistance training is associated with improvement in glycemic control, insulin resistance, fat mass and fat-free mass, muscle mass improves, blood pressure improves, and strength and overall physical functioning improves. However, the effect of resistance training on glycemic control in type 1 diabetes is still unclear and controversial, and mostly this is being associated with a transient rise in blood glucose levels. And therefore, in type 1 diabetes, if you want to combine resistance training exercise along with aerobic exercise, there is enough evidence to say that first you have to do a resistance training exercise that will result in marginal elevation in your blood glucose values, and then you have to do aerobic exercise which will contribute to fall in blood glucose, and that in this case the risk of post-exercise hypoglycemia in type 1 individuals will be low if you do resistance training first and then follow it with aerobic exercise. There are stretching exercises which improve range of motion around joints and flexibility, but it has got no impact on glycemic control. And balance training, it can reduce falls by improving balance and gait. Even in people who are having neuropathy, you can use this balance training exercises to decrease the risk of falls. This is the latest 2022 consensus statement from the American College of Sports Medicine for exercise physical activity in individuals with type 2 diabetes. It is like almost all organizations, they agree that minimum 150 to 300 minutes per week of moderate intensity or 75 to 150 minutes per week of vigorous activity of aerobic exercise without not more 2 consecutive days between bouts of activity. Resistance training 2 to 3 days per week but never on consecutive days. It should be 10 to 15 repetitions per set, 1 to 3 sets per type of specific exercise. Flexibility exercises should be around more than 2 to 3 days per week, and balance exercises should be more than 2 to 3 days per week or more. And whenever you are designing an exercise plan for your patient, then you have to follow the FIT principle, that is type of exercise, frequency of exercise, intensity, and timing of exercise, that you have to tell your patients whenever you are prescribing them or you are giving them an exercise prescription. Only giving an advice about physical activity will not do justice. You need to enroll them in a structured exercise training plan that will contribute to better as far as blood pressure is concerned or glycemic control is concerned. This is a meta-analysis of variety of trials which suggests that structured exercise training is better in lowering blood pressure, both systolic and diastolic, in diabetic individuals as compared to physical activity advice only. And the same is being there as far as HbA1c reduction is concerned, that structured combination exercise, both resistance and aerobic, when they are combined in a structured exercise training, and also it is more than 150 minutes per week, then it is associated with greater benefit in HbA1c to the tune of 0.9% reduction. Whether timing of exercise affects blood glucose values or not. There is now upcoming concept, and this is a small trial, randomized crossover trial in 11 men with type 2 diabetes on insulin, without any, not on insulin, without any systemic illness, where the high intensity interval training was done in the morning and in the afternoon. And to surprise, it was shown that afternoon training was more efficacious in improving blood glucose levels in this kind of people who are having type 2 diabetes, and morning exercise was associated with a deleterious effect on increasing blood glucose values. However, this is a very small trial, but it gives you a hint that if you do a short high intensity interval training in the afternoon, that will have a better effect on your 24-hour blood glucose profile as compared to when you do it in the morning. Why do we require individualization? Because exercise, like diet, like pharmacotherapy, like insulin and everything, you need to individualize exercise also. Apart from age, strength, power, speed, aerobic capacity, movement evaluation, injury history, and physical limitations which affect exercise plan for every individual. In case of a diabetic, age of a patient, sex of a patient, type of diabetes, duration of diabetes, various comorbidities which are there with diabetes, and various diabetes complications, they have an impact on the exercise plan for a given individual. And therefore, you need to individualize exercise according to the various factors of a patient who is sitting in front of you. Pre-exercise health evaluation is not mandatory for asymptomatic individuals who are receiving diabetes care consistent with guidelines, who are following a proper diabetes plan, and who wish to begin low to moderate intensity physical activity. You need not to subject them for a pre-exercise stress testing. Those who wish to start with vigorous intensity exercise or resistance training exercise, or who are having multiple risk factors or various other factors, then you need to subject them to exercise stress testing before giving them an exercise plan of vigorous intensity training. These are the various people who will require exercise training. This is as per the American College of Sports Medicine 2022 consensus statement. However, this is variable and you have to individualize. But people who are having long-standing diabetes, who are having hypertension, dyslipidemia, multiple severe risk factors in the form of cigarette smoking, who are having diabetes complications in the form of retinopathy, microalbuminuria, then you need to subject them to exercise stress testing before prescribing them an appropriate exercise plan. Apart from pre-exercise stress testing, blood glucose monitoring is must for every diabetic person who is engaged in exercise or whom you are suggesting a different kind of exercise plan. If the blood glucose is more than 250, then you should not begin exercise, or there are urinary ketones, then individual should not exercise, and that is the instruction which is to be given, particularly to type 1 individuals who are engaging in sports or other activities. You have to tell them that if blood glucose is on the higher side or urine ketones are present, then exercise is to be avoided. Same way, they should hydrate themselves properly by drinking adequate fluids. For people who are using insulin or sulfonylurea, the risk of hypoglycemia is there, and therefore when they are doing a prolonged activity, they should carry some rapid acting carbohydrate snack with them, and they should consume it during that activity or after activity to decrease the risk of hypoglycemia, which generally occur following a bout of aerobic exercise. The special conditions or complications of diabetes and their impact on exercise for people who are having diabetic retinopathy, they have to avoid high intensity activities which require breath holding like weightlifting, isometric exercises, resistance training exercises. Also, they should avoid activities that lower the head, because that will increase the pressure inside the blood vessels in the eye, like yoga and gymnastics are to be avoided in these people. And if they are not able to undergo a stress test, then they can use that rating of perceived exertion to monitor exercise intensity, and they can do a light to moderate activity with a rating of perceived exertion to the tune of 10 to 12 on a 60 to 20 scale. It is contraindicated for people who are having proliferative or unstable retinopathy or recent retinal coagulation or other recent surgical eye treatment to avoid any kind of exercise, and you have to consult an ophthalmologist for specific restrictions and limitations in case of severe retinopathy. Autonomic neuropathy, there is an increased risk of hypoglycemia, abnormal response of blood pressure as well as heart rate to exercise, as well as abnormal thermoregulation which may occur following exercise, and there is increased risk of tachycardia, and that for the exertional intolerance is there in people who are having autonomic neuropathy, and therefore rather than heart rate, the rating of perceived exertion should be used to limit the exercise intensity in these people who are having autonomic neuropathy. Same way for peripheral neuropathy, you have to avoid weight bearing exercises, particularly walking on uneven surfaces. Non-weight bearing exercises like cycling, chair exercises or swimming may be more appropriate, and you have to take proper care of your feet, particularly in people who are having moderate or severe neuropathy and if they are exercising regularly. Kidney disease, you have to avoid resistance training exercises or high intensity aerobic exercise which are associated with increase in blood pressure. Also exercises which require breath holding, they are to be avoided, and therefore in this category of patients, light to moderate intensity aerobic activity may be okay, or balance exercises or stretching exercises may be okay for these individuals, and same applies also for hypertensive individuals, particularly those who are having uncontrolled blood pressure. I will just touch upon recommendations for physical activity by Diabetes Canada. This is 2018. We all know ADA recommendations. Almost all organizations, they agree that at least 150 minutes of moderate to vigorous intensity aerobic exercise spread over at least 3 days of week is must for every type 2 diabetic individual, with no more than 2 consecutive days without exercise to improve glycemic control. Lesser amounts of exercise can be done, but it will not be having the same beneficial impact on glycemic control. Interval training can be recommended, particularly if the people they want to improve their cardiorespiratory fitness, and this is particularly in type 1 individuals to reduce the risk of hypoglycemia which can follow a period of aerobic exercise. So before doing an aerobic exercise, they may do a short period of vigorous exercise or high intensity interval training. They can do a short bout and then they can do aerobic exercise to decrease the risk of hypoglycemia which may follow aerobic exercise. Resistance exercise at least twice a week and preferably 3 times per week, and this should be individualized and it should be under the supervision by an exercise specialist. Physical activity goals are must, but at the same time sedentary lifestyle or the time spent in sedentary activities should be minimized, and people should periodically break up long periods of sitting and should stand and walk around in between the sitting. Every 20 minutes of sitting you have to walk up, you have to walk, and you have to stand and walk for a few minutes. Specific exercise goals and problem solving should be provided to all the people who are having diabetes. Step count monitoring with a pedometer or accelerometer can be a beneficial in people tracking their physical activity and motivating them to do better with physical activity. As far as hypoglycemia and type 1 diabetes is concerned, there are few suggestions by Diabetes Canada guidelines that reduce the bolus dose of insulin that is most active at the time of exercise, significantly reduce or suspend basal insulin for the exercise duration. If the activity is less than 45 minutes, then you have to suspend, and lower the basal rate overnight after exercise by around 20%. Carbohydrate consumption should be increased during and after exercise as per the activity, and if maximal intensity sprints at the start of exercise, periodically during the activity or at the end of exercise may help in reducing hypoglycemia in this type 1 diabetic children and adolescents. Perform resistance exercise before aerobic exercise, as I have already told. Older individuals, I think you have to assess them with proper history, and if required, you have to tell them to undergo exercise stress testing and then devise exercise plan. But this again requires individualization, because here the chronological age does not matter, it is the biological age which matters most. And structured exercise programs are must for type 2 diabetic, because they have got a better impact on glycemic control, on CVD risk factors, and overall physical fitness. As far as type 1 diabetes is concerned, expert recommendations are there. They say that exercise is a cornerstone. Minimum recommended 60 minutes of moderate to vigorous intensity physical activity per day for children and adolescents with both type 1 and type 2 diabetes. Increase overall risk of hypoglycemia during, shortly after, and up to 24 hours. However, I have already told that high intensity is not associated with risk of hypoglycemia, so you need not to require insulin dose adjustment, but aerobic activity, definitely you need to reduce the insulin dose to decrease the risk of hypoglycemia. If the people, they have got hypoglycemia in the preceding 24 hours or past history of hypoglycemia with exercise within 24 hours, then it is a temporary contraindication to physical activity in this kind of individuals. Same way, hyperglycemia with ketonemia, exercise should be avoided. So the key messages are: exercise is important not only for diabetics, for every human being. It improves glycemic control, body composition, cardiorespiratory wellness, physical functioning in people with type 2 diabetes, type 1 diabetes, or even pre-diabetes. Lifestyle modification, including exercise training, is a main strategy in diabetes prevention as per DPP program. Multiple benefits are there on blood glucose, lipids, body weight, body composition, blood pressure, as well as there are mental health benefits. It reduces anxiety, it improves mood, it reduces depression, improves sleep quality, and therefore combination of aerobic and resistance training is a component of any treatment plan for every individual who is having diabetes. And just to avoid prolonged sitting, step monitor may be beneficial in tracking physical activity. At least 150 minutes per week of aerobic exercise combined with 2 sessions per week of strength training is must for every type 2 diabetic individual. However, if they are not able to reach that goal, smaller amounts, still they will provide some health benefits. So whatever you do, whatever type of exercise, whatever type amount of exercise the person is able to do, they should engage in that kind of exercise. So exercise is must for every diabetic. However, one size does not fit all, and I have already highlighted various factors which affect the exercise plan for a diabetic individual, and considering all these factors, you need to individualize and make them exercise regularly so they can live longer, happier and healthier. Thank you very much.
Thank you, Mr. Pratap Jetwani, for that wonderful talk.
Yeah, Dr. Palijor, you can introduce Anjana.
Good morning. Am I audible?
Yes, yes.
Yes. Good morning and welcome to Dr. R.M. Anjana, MD and Diploma in Diabetes, PhD, Managing Director and Diabetologist at Dr. Mohan's Diabetes Specialty Center at Chennai. The main research areas are prevention of diabetes, epidemiology, translational research and technology related to diabetes. She has plenty of publications in several national and international journals, and she has been involved in a lot of national and international projects. She received several awards, including the prestigious Young Outstanding Women Achievers Award from Tamil Nadu, MGR University. She's a great person. Innovator Award from the Indo-UK Health Summit, award from the Government of Tamil Nadu, Shakuntala Amir Chand Prize from the ICMR, and she is a member of various scientific bodies such as the API, the IMA, the RSSDI, DASG, AACE. In 2020, she has been selected as a member of the WHO Salim Yusuf Emerging Leaders Program as a world-renowned leader in global cardiovascular disease research. It's a wonderful biodata, and welcome to you. You're not audible, ma'am.
Mahima, just check. She's not audible. Mahima? Please check.
So the topic that I'm going to be talking about today is the remission of type 2 diabetes, which is the new kid on the block. But the difference between earlier and this study is this is going to be done at a population level. And I'm going to be talking about the role of diet for the ICMR in diet study. This is a manuscript that has just gotten accepted in diabetes care for publication just last week. And I have no conflict of interest to declare. So let's talk about the natural history of diabetes. So we all know that people go from NGT to pre-diabetes to clinical diabetes and the stage of complications. And thus far, the goal of all diabetes treatment has been in prevention. So it could have been primary prevention or secondary prevention, depending as the case may be. But today, we're talking about a new concept, which is actually remission or going backwards in time. Thus far, there have been a lot of studies done on remission at the individual level. So what are they trying to do? For someone who's got diabetes, they can go all the way to pre-diabetes or maybe even to NGT. Now, what's the definition of reversal or remission? Let's stick with the ADA definition, which talks about remission being an A1C of less than 6.5% for a period of at least 3 months without diabetes medication. So that is the definition we'll use, and the official terminology is going to be remission of diabetes. Now, what's the evidence we have for remission? The first remission was shown by Roy Taylor's group in the Counterpoint study. So what they did here is they took 11 people with type 2 diabetes, most of them were male, and put them on a 600 kilocalorie diet. Now, just to put this into perspective, the average Indian eats anything between 3,000 calories a day, depending on type of behavior and things like that. But from there, if someone has diabetes, we generally talk about 1,400, 1,200 kilocalorie diet. Now, from there, we're talking about 600 kilocalories. This is very, very low calorie diet. And this was for a period of 8 weeks. The diet was in liquid form, so it was a liquid meal replacement with about 46% carbs. So this is what they did, and they looked at the hepatic glucose output, hepatic and peripheral insulin sensitivity, and beta cell function, along with pancreatic and liver triazole glycerol content, and this was matched with controls. So this is what happened. If you look at the fasting plasma glucose in those in the intervention group, you can see in yellow, it came zooming down even the first week. So what this says is that if you go on to this liquid meal replacement, in 7 days, your blood glucose normalizes to almost equivalent of control. These are normals. They're non-diabetic controls in the red. So you can see almost equivalent to that level. You're able to bring the glucose levels and it stays there for that period of 8 weeks. Now let's look at the liver fat and pancreatic fat. Takes a little longer, something to about 2 weeks-ish to come down. Control is again the red line. And then if you continue with this diet, the fat goes down to even lower than normal levels, both in the liver and the pancreas. Now, what about insulin sensitivity? Goes up considerably in the first week itself. As the glucose comes down, insulin sensitivity peaks and continues to peak for the 8-week period. And similarly, the phosphate C-peptide secretion also improves quite well. So this was the first study on remission showing that it was actually possible with metabolic benefits. Then the same group went on to do the counterbalance study where they took a larger number of individuals and divided them into 2 groups. So one is the diabetes with less duration, so that's less than 4 years. And then they had people with more than 8 years duration. They did the same thing. They gave them the liquid calorie diet for 8 weeks, and then they moved them on to solid diet for a period of 6 months. But please note here that even the solid diet was only at the 600 kilocalorie level. So this is what the counterbalance did, and here's what they showed. So in the first column here, so the green is all the short duration diabetes, and the pink is the long duration diabetes. Irrespective of duration, there was a fantastic weight loss as shown in the first column here. So with over the 8-week period, there was a beautiful linear decrease in weight and it stayed down. Now, what happened to fasting plasma glucose? Now, this had 2 different kind of behaviors. The first one is for those with short duration. Everyone with short duration diabetes, glucose came down, stayed down. Now, for those with longer duration diabetes, there are 3 types of people as indicated by the yellow dotted line. So the first group are those who responded. The responders, sugar came down, stayed down, just like the short duration. Then there was a group for whom the sugars came down, but gradually. You didn't see the dramatic effects of the responders. They were kind of slow responders. And then you had this group of people, irrespective of weight loss, and this was a very impressive, almost 15 kilogram weight loss. Their blood glucose did not come down, and these people were termed the non-responders. We then went on to this study, which is the direct study done in the US. They had about 200, 300 people in their study, intervention and control from all over the US, and they had 2-year follow-up for the participants. What did they show here? So in year 1 versus year 2, the first thing that they showed is the number of people achieving that 15 kilo weight loss. So in the control group, obviously hardly anybody achieved. In the intervention group, 24% of people achieved the weight loss in year 1, but then it went down to half that in year 2. So the number of people who actually attained the weight loss came down over time. What about remission? Again, here, less than 50%, control almost no one. Now, in the intervention group, almost 45.6% of people attained remission as defined by the ADA, but this went down to about 35% in year 2. But the famous point that they made here is the panel below, which talks about the degree of remission based on weight loss. With less than 5 kilo weight loss, there was hardly any remission, 5 to 10 more, and as you go more than 15 kilos, the remission becomes impressive. So here the points they made were as follows, that the remission is directly related to the weight loss, more remission, but remission is not for everybody. Some people respond, some people don't respond. So that is what the direct trial. So what is the evidence we have so far? At individual remission level, remission is possible. We do not have data beyond 2 years. However, then in a place like India, cultural factors and the diversity of the society that we have hampers our ability to give liquid diet. So all the trials I showed so far, everybody has been on a 600, 800 liquid diet for a period of 3 months. Now, if you talk to the general population of India and ask them to take liquid for 800, there's hardly going to be any takers for such a thing. So although it works, this practicality and the ethnic diversity that we have precludes the use of something like this for everybody at a large scale, whereas India has a large-scale diabetes problem. So we do need a solution that can be done in the general population. And that was the genesis of this paper, in which we asked the question, in India, can we look at population level macronutrient changes for prevention of chronic diseases like diabetes? So we first went to official surveys that were there, the NSSO, the NNMD, NFHS, and we didn't really find any answers to these. So we then went on to the ICMR India Diabetes Study, or INDIAB for short. Now, what is this? This is a study funded by the Indian Council of Medical Research and the Department of Health Research, Government of India, which looks at not only diabetes, but all of metabolic MCDs in every single state in the country. So what did the study aim to do? It aimed to provide optimal macronutrient recommendations for remission and prevention of type 2 diabetes using optimization models in the Asian Indian adult population at the population level. And this is what the study is about. So INDIAB has data from all the 30 states and union territories. So that's about 1 lakh-ish population. But in every 5th participant, we had detailed dietary data. So we had a dietary in about 20,000 individuals with a response rate about 92%. After removing those with known diabetes and outliers, dietary data of about 19,000 individuals were analyzed. If you look at this, there was a 70% rural distribution, very similar. So this sits exactly on the census data because it's been modeled on that. And then you have an equal kind of sex distribution between men and women. Now, what exactly was done? So we took all of the INDIAB dietary data. The first thing we did is we did a linear regression. The equation is shown there, where X are the non-dietary factors and Z is the dietary factors. So what did we do? We tried to first define this in 3 different categories. We used the regression to see which were the factors associated with A1C. Then we started doing stratification. So we needed 3 categories. So we have newly detected diabetes, pre-diabetes, and normal glucose tolerance. Now, what are we doing in each of these categories? For those with newly detected diabetes, we're trying to push to remission. That means less than 6.5%. For those with pre-diabetes, push to NGT, remission. That is less than 5.6%. So in 2 categories, NDD and PD, we're looking at remission as defined by the 6.5 and 5.6. Now there's 2 other categories, which is the prevention of progression. So in NGT, we're looking at prevention of progression to diabetes, and in pre-diabetes also, we're looking at prevention of progression. So these were the 4 glycemic categories were there. And we looked at remission and prevention. So this was also stratified by urban rural areas, sex, physical activity, BMI, and age. So the objective of what we call the quadratic programming problem was as follows. It asked the question, what degree of macronutrient distribution? So what they did is they took all the X's or the non-dietary factors and fixed these. And only the Z was allowed to change. So what combination of macronutrients pushed the majority of the population to less than 6.5 if it's a newly detected, or if it to less than 5.6 if it's a pre-diabetic. So this is how they did it, or what percentage of what combination of macronutrients prevented progression. So in these 4 categories, this is how we came out with the macronutrient recommendations. So what are these recommendations? So given in the first column are the current population intakes of carbohydrates, about 60 62%, urban, rural, all across. Protein is 12, fat is 25, and fiber is 3.5%. So in order to get about 78 to 80% remission in those with NDD and PD, what do we have to do to the macronutrients? The carbohydrate percentage has to be between 49 and 54. So around 50% of carbohydrate. So 62 has to go to 50. Now, this doesn't sound like a very big difference, but in real life, when you're actually asking someone to do this, this can be a huge change that you're asking of them. So move the carbohydrate down to 50% in those with NDD. Protein has to move from 12 to about 20%. Fat is okay where it is at the moment, and fiber has to increase from 3.5 to about 6%. So this is the kind of macronutrient recommendation for NDD. For those with PDD, for remission, we can allow to about 55%, so 5% higher in those with PD is allowed for carbohydrates. Protein again 20, fat little more is allowed, fiber is about the same. So this will help to push about 80% of the population into remission. Now, do we have differences by substratification in urban and rural areas? Yes, there are small differences. For example, the rural areas can consume a little bit more carbohydrate and fiber, whereas the fat intake has to be lower, protein is about the same. So again, it's about the same. There are only 1%, 2% differences here and there. Rural areas, little bit more we allow in the carb. Now, what about activity? Again, common sense tells you that if you're slightly more active, you can take more carb. And thus you'll see for those who are really physically active, up to 58% carb is allowed because you're burning it off quite easily. The rest are about the same. Protein, fat and all are about the same, and fiber. But for those who are inactive, carb comes all the way down to about 50%. Men and women, again, men are allowed a little more carbohydrate because of more metabolism in the men, whereas the rest is essentially the same. The young and the elderly, obviously elderly, everything comes down. So men, younger people are allowed slightly more carbohydrate, not by much, but a little bit more. Others are the same. So even if you look at the various categorization, you will see similar things. Similarly, for BMI, those who are not overweight or obese can take a little more carb than the rest. So if you look across, it seems that the recommendations are stable across categories of substratification, and overall small changes depending on activity and BMI and things can be made. Now, what about for pre-diabetes remission? So we talked about 55% being overall. Same rules apply here. Little more allowed in urban areas. Little more allowed in active individuals. Little more allowed in men and in younger people. Similarly, it's all very small little changes, 1% here and there. It's similar very much to the NDD. And similarly, overweight and obese have to be more careful. So this is the overall story that we are saying for remission of diabetes and pre-diabetes. Now, what about prevention of progression? So these are the plates given here. The one on the left is for pre-diabetes and the one on the right is for NGT. So in an NGT individual, actually up to 60% carbohydrate can be allowed, protein 70, fats 24, and fiber. So what have they done here is that they've taken up the protein and the fiber, leaving carb where it is, because these are NGT individuals, right? So if you can actually increase the activity, the protein and the fiber, we have some evidence to show that there's prevention of progression. Those with pre-diabetes, this comes down and the carbohydrate is at between 54, 58. They have to be more careful. Protein definitely goes up, fiber goes up, and the fat you have to be careful, especially if they're overweight or obese. So these are the recommendations that we have. I'd like to conclude by saying that for the first time, we have looked at a population-based approach for remission and prevention of progression of type 2 diabetes by reorganizing macronutrient composition. We are advising an overall carb-calorie reduction and increase in protein calorie with increase in fiber. So to prevent progression also, we're talking about protein increase and fiber increase. Those who are physically inactive, obese and older, and as well as those in urban areas require greater reduction in the carb and greater increase in their protein intake. So I would like to conclude and thank once again for giving me this opportunity to present to you today. Thank you.
think that was a very interesting presentation by Anjana on how diet can really influence reversal of diabetes. Very interesting. What really comes out from this is you increase the protein and reduce the carb, which really matters. I mean, I see in my practice sometimes a patient who is on a huge amount of insulin, when he gets admitted to the hospital for a surgery, he's NBM, he hardly needs anything. So when food intake is restricted, it does have a activity on the remission. That's what comes out of this. But doing it on a population basis is going to be a very difficult task, convincing everybody. But by and large, what we do in our practice is we encourage everybody to have increase in protein. That is the must. And in fact, vegetarians have a very low protein intake in their diet. So the pulses, milk products, and maybe even a supplement of protein is what is required for them. Any comments, Dr. Palijor?
No, all three speakers have done a wonderful job. And in the talk of Dr. Maria, he has proven to us by all the studies that diabetes is an inflammatory disease, and we've got to work more on the inflammation also, added to the rest of the treatment. And in Dr. Pratap Chetwani, he has beautifully shown us how exercise helps in diabetes. He's described the different varieties of exercise and how we should structure the exercise pattern and hand over to the patients. And in Dr. Anjana's talk, as you have already spoken, it was a very wonderful talk, very informative and very encouraging for people who are in the pre-diabetic state and how we can actually reverse the disease. So that is really wonderful.
I have a question for Dr. Maria.
Yes.
Sir, your talk was brilliant. My question is, what is the clinical implication of this? What would you really do clinically?
See, clinically, yes, as I said, there are a lot of research needs to be done, and we still, other than HCQS, we do not have any really yes, there's a lot of antioxidant diets are now being proposed, which can have an effect on the inflammatory milieu of the body. That is one thing you should do. Increase physical activity can also help to lower down the inflammation inside the body. These are the things. These are the main things which you can do. But other than HCQS, right now we do not have any other drug which is proven to be beneficial as far as the outcome or decreasing the inflammation part is concerned.
What's your opinion on pioglitazone in this scenario? Why are you laughing?
Bios and all, they have all been. They have tested in fact, all the, if you see the pleiotropic effects of most of the anti-diabetic drugs, they do say they bring about the anti-inflammatory part also there. With metformin also, you have evidence of some anti-inflammatory effect. Pioglitazone, of course, there is there. But whether they are to be used as an anti-inflammatory for that aspect clearly is, I mean, I will not be able to answer that question. That's a pleiotropic effect rather than the effect of those drugs.
Pio increases adiponectin, it reduces interleukin 6, it reduces TNF-alpha, it reduces CRP. It is definitely anti-inflammatory.
It is definitely anti-inflammatory, but whether which major effect is on the insulin sensitizing. Yes, of course. You cannot deny that it has those benefits. Definitely. I cannot deny that.
I think the root cause of entire inflammation is visceral fat and reduction in adiponectin and adipokines oversecretion. So sir is right that that way metformin and pio are also good anti-inflammatory agent because they immediately reduce insulin resistance and improve sensitivity and improve the adiponectin levels. TNF-alpha goes down. So sort of it also has a good anti-inflammatory action. But you are right that primarily when we are talking about markers of inflammation, first thing which comes to mind is hydroxychloroquine, which is proven to reduce inflammation at every level.
I think we can close this session and move on to the next one.
Because next is your session only. So I may invite, thanks Dr. Maria.
Thank you.
Wonderful,
Thank you,
Dr.
sir.
Anjana and Dr. Pratap, wonderful sessions. So we go on to the next session, and that again is to be chaired by Dr. Maria and Dr. Seema Shahe. And I'll immediately request both of them to please start the proceedings. Dr. Seema is, I think she's already there. Dr. Maria, you may start, and she's already there, I think. Yeah.
And then I'll be off.
Yeah.
Good. We welcome you all to the next session, in which we have a very eminent speaker, Dr. Vijay Panikar. He's an MD, DNB, and FCP, FRCP London, honorary consultant in the Department of Endocrinology, Diabetes and Metabolism, Leelavati Hospital, Mumbai. He's ex-professor of medicine, KG Somalia Medical College, Mumbai. He's ex-vice president, Research Society of Study of Diabetes, India, past chairman of RSSDI in Maharashtra. He's past president, College of Physician Surgeon, Mumbai. Organizing chairman, RSSDI National Conference, Mumbai. Publication in several journals, and pioneer work in triple drug therapy and diabetes for diabetes management. I'll request Dr. Vijay Panikar to initiate his talk. Thank you. Dr. Vijay Panikar.
Thank you, Dr. Maria. Let me just share my slides. Can you see my slide? Does it move?
Yes, sir. Put it in slideshow mode.
It is in slideshow.
Oh, no, not yet, sir.
No?
No, not in slideshow. On
my screen, it is in slideshow.
You may change one or two slides and see.
Thank you, Rajiv and Shalini, for having invited me to speak on this topic, NAFLD NASH, current guidelines and adoption in clinical practice. Today, NASH is becoming, NAFLD is becoming an epidemic, not only in our country, but across the world. But what is non-alcoholic fatty liver disease? It's basically an accumulation of fat in the liver in the absence of ongoing intake of significant amount of alcohol. And what is that significant amount of alcohol? A cutoff is intake of 20 grams daily. I won't go into that. Basically, NASH is a chronic progressive liver disease, and it is considered the progressive type of non-alcoholic fatty liver disease. And that is characterized by accumulation of fat in the liver, which is called steatosis, which leads to inflammation and liver damage, and can progress to fibrosis, cirrhosis, and a hepatocellular carcinoma also. NASH frequently progresses undetected because there are hardly any symptoms of the disease. And NAFLD is a diagnosis of exclusion. You knock off the alcohol-induced hepatitis, drug-induced hepatitis, viral hepatitis, hepatitis B, C, etc., autoimmune hepatitis, and metabolic diseases like Wilson and hemochromatosis, and that leaves you with NAFLD. So what is NASH? From steatosis to cirrhosis. Steatosis is more than 5% fat content in the form of triglycerides. And once you have hepatocellular injury and your enzymes begin to increase, that is what causes NASH, and that can progress to cirrhosis and hepatocellular carcinoma. How do NAFLD really occur? We aren't exactly sure. But a two-hit hypothesis is there. The first hit was that the accumulation of triglycerides in the liver leading to steatosis caused by systemic insulin resistance. The second hit was thought to be a consequence of long-term storage of triglycerides that results in hepatic oxidative stress and damage to the hepatocyte. This paradigm of perpetual chronic injury would be established, leading to eventual fibrosis, cirrhosis, or a hepatocellular carcinoma. Subsequent studies have revealed that hyperinsulinemia, that is insulin resistance, the first hit, does indeed precede the development of fatty liver in diabetics. And to the extent today that if you see a fatty liver in a non-diabetic, you could assume that he is a pre-diabetic. The general rule seems to be that fatty liver is closely associated with insulin resistance, and there seems to be very few exceptions to this. Such exceptions featuring a dissociation of insulin resistance from fatty liver is specific genetic conditions affecting lipid metabolism, especially familial heterozygous hypo-beta-lipoproteinemia or patients with HCV. So multiple insults, the second is multiple insults acting together on genetically predisposed patients is insulin resistance, metabolic syndrome, obesity, diabetes, dyslipidemia, altered gut bacteria, inflammatory cytokines, and currently this is the most accepted understanding of NAFLD. So you have the first hypothesis that insulin resistant metabolic syndrome causes steatosis. And then you have the oxidative stress, mitochondrial dysfunction, inflammatory cytokine, which leads to the progression to NASH and cirrhosis. So the basic defect in the development of hepatic steatosis is the imbalance between import and export of fat to and from the liver. Insulin resistance with and without full-blown metabolic syndrome is the central mechanism for hepatic steatosis to the patient with NAFLD. Now, this in turn develops in a setting of inappropriate diet, sedentary lifestyle, obesity, centrally special visceral obesity, and advancing age. How do we really treat NAFLD? You have lifestyle modification, you have insulin sensitizers, you have antioxidants, but as of today, there is no US FDA approved drug for the treatment of NAFLD. But there are a lot of clinical trials with different molecules. If you look at this, this is a 2018 guideline from AASL. Pioglitazone improves liver histology in patients with and without type 2 diabetes with biopsy-proven NASH. Therefore, it may be used to treat this patient, but risk and benefit should be discussed with each patient before starting therapy, because this was the time when everybody was talking about the possibility of pioglitazone and bladder cancer. So this cautionary statement there. Then you have in 2016 AASL ESD recommendation, pioglitazone most efficacious data, but off-label outside type 2 diabetes or vitamin E, better safety and tolerability, or their combination could be used in NASH. Then this was recent in the Journal of Internal Medicine, which is in August 2022, current treatment of non-alcoholic fatty liver disease. Diet, exercise, weight loss, yes, but when you talk of pharmacological treatment, pioglitazone in patients with biopsy-proven NASH, 30 to 45 milligram, vitamin E can be given in NASH in patients without cirrhosis, 800 IU per day. If you look at the randomized controlled trials in different situations of fatty liver, and all the drugs they have analyzed, if you look at resolution of NASH, you have elafibranor 120 milligram, obeticholic acid, liraglutide, vitamin E, pioglitazone 30 and 45. It shows very nice results, best results with pioglitazone. In resolution of NASH, liraglutide has also shown a decent thing. When you talk of NAFLD score, it is the pioglitazone which comes up. Steatosis, again, the pioglitazone comes up. Lobular inflammation reduction, pioglitazone comes up. Ballooning, though the effect is less across the board, but the best results are seen with the pioglitazone. And in fibrosis also. Generally, fibrosis doesn't reverse with most of these drugs, but these studies have shown that there is a slight improvement in fibrosis also. These are histological response in patients with pre-diabetes versus type 2 diabetes. Now, this we are looking at pre-diabetes and NAFLD score. In pre-diabetes, pioglitazone has done wonders. In type 2 diabetes also, it does the same. Resolution of NASH in pre-diabetes. So basically, we are talking of pre-diabetes. Diabetes comes later. And if you look at the scores of ballooning, fibrosis in patients with pre-diabetes and type 2, steatosis in both pre-diabetes and diabetes comes down, ballooning, inflammation, fibrosis, all improve. Now, in May 2022, the ACE came out with guidelines for NAFLD. And what are the key highlights of these guidelines? So screen patients at high risk for NAFLD and advanced fibrosis in the presence of certain markers, especially if the patient is obese, pre-diabetic or has type 2 diabetic or has metabolic syndrome, hepatic steatosis on imaging or elevated liver enzymes for greater than 6 months. So those need screening. And you can screen the patient using a fibrosis 4 or a FIB4 test, which is a non-invasive test wherein you just look at the patient's age, you look at the liver enzymes, the SGOT, SGPT, and do the platelet count, and you can get a FIB4 score. And in fact, in my clinic, we are just doing a study. We have just completed a study doing fibroscan in over 2,000 patients. Every patient who walked in had a fibroscan, and we have got the FIB4 and the APRI score and all, which is ingrained into my system. Automatically, it will give us the figures there. Now, if you have an individual who has very high liver enzymes, hepatic steatosis, or evidence of advanced liver disease, it should be sent for a specialist evaluation. These are the key highlights of ACE guidelines. You have to counsel lifestyle modification, including weight loss for every individual with obesity and NAFLD. The other is talking about the medications. What do they recommend? Using pioglitazone or GLP-1 receptor agonist for those with NASH and type 2 diabetes. Consider weight management. Semaglutide and liraglutide has been shown to have effect. SGLT2 also does have weight reduction there. Consider bariatric surgery for individuals with a BMI above 35 and NAFLD. Evaluate for presence and severity of NASH in patients considering bariatric surgery. Screen children and adolescents with type 2 diabetes for NAFLD using age-appropriate liver enzyme tests. So basically, timely diagnosis and management of NAFLD and its complication is essential. Studies show presence of liver fibrosis worsens morbidity and mortality with NAFLD and associated complications. This includes higher risk of hepatocellular carcinoma. Many patients with type 2 diabetes have underlying risk factors but remain undiagnosed. So there has to be a proper screening. But if you look at patients with type 2 diabetes, have an extremely high risk of NAFLD. Up to 90% of type 2 diabetics have a non-alcoholic fatty liver disease. And I think these figures are coming out in our study, which I've just completed. We have to analyze the data. But 90% have non-alcoholic fatty liver disease. Of this, 37% have NASH, and 20% of the patients have a significant fibrosis, which is corroborated by a fibroscan and a FIB4 score. So, clinical takeaway is raising the awareness of NAFLD is there. Today, nobody really looks at non-alcoholic fatty liver in that sense. Many a times, routine sonography shows us that there is a fatty liver. Most of the clinicians tend to ignore it. That awareness has to come that this is a serious matter which we have to really look at. Now, this is the ACE guidelines which came out on 1st May 2022. What medications are proven to be effective in treatment of NAFLD or NASH? It says pioglitazone and GLP-1 receptor agonists are recommended for type 2 diabetes and biopsy-proven NASH. That's a grade 1 recommendation. Clinicians must consider treating diabetes with pioglitazone and GLP-1 when there is a related probability of having NASH based on elevated plasma aminotransferase. To offer cardiometabolic benefits, type 2 diabetes must consider GLP-1, pioglitazone, or SGLT2 inhibitors. So basic play is around pioglitazone, GLP-1, and an SGLT2. The GLP-1 and SGLT2 cause a significant weight loss, which contributes to reducing insulin resistance and helps in the process of alleviating NASH. So management of NAFLD, again, this is the ACE recommendation, fibrosis risk stratification, whether low risk, intermediate risk, or high risk. Preferred diabetic pharmacotherapy, consider agents that reduce liver fat. Pioglitazone, GLP-1, SGLT2. Indeterminate, it is the same thing. High risk, again, pioglitazone, GLP-1. And as far as there is no efficacy data on cirrhosis. Now we have a drug, which is an Indian drug, saroglitazar, which has been approved, first drug to be really approved for NAFLD or NASH. So Drug Control of India has approved Zydus' saroglitazar for non-cirrhotic non-alcoholic steatohepatitis, making this the first drug approved for this indication anywhere in the world. The approval of saroglitazar was based upon the results of the evidence 1, 2, and 4 studies. And in the phase 2 evidence study, evidence 1, the drug demonstrated an improvement in liver enzymes and lipids in patients with non-alcoholic fatty liver disease, a preliminary stage of NASH. Basically, saroglitazar is a dual PPAR gamma agonist. It has, in fact, the PPAR gamma works just like pioglitazone, more or less comparable results. I have looked at the data there. And it also has an effect on PPAR alpha, thereby reducing the triglyceride content. So obviously, reducing insulin resistance, reducing the triglyceride could have a positive effect on the liver pathology. Evidence 2 was a phase 3 study where saroglitazar was compared to placebo in Indian patients, which evaluated the histological improvement of NASH during a liver biopsy after 52 weeks of treatment. Saroglitazar met both its primary and secondary endpoints since it reduced liver fat, liver enzyme, and disease activity. Now, we are looking at an evolving scenario. And today, since no US FDA approved treatment exists to date, recent guidelines recommend only lifestyle intervention, bariatric surgery if BMI is more than 35 and there is evidence of NASH, GLP-1 receptor agonist, PPAR gamma, that is a pioglitazone, and SGLT2 for its weight reduction. There is a new and novel medication for the treatment of type 2 diabetes, tirzepatide, which is a dual GIP and GLP-1 receptor agonist, which has been approved by FDA, US FDA, only 1 week after the ACE guidelines were published. And ongoing clinical trials demonstrate promising results not only for type 2 diabetes, but for body weight and steatosis. And if you look at this, the ACE guideline was published on 1st May 2022, and on 13th May, tirzepatide was approved. This is the SURPASS trials, where HbA1c comes down, significant weight reduction comes down, CV safety submit trial is on the way, but effect on NAFLD and NASH, SURPASS 3, the tirzepatide significantly reduces liver fat content and maybe reduces the progression of fibrosis. So reconsideration of the current recommendation of NAFLD treatment to include this novel agent would offer effective treatment for NAFLD among diabetic patients should be seriously contemplated in the future. In fact, this molecule may replace GLP-1 totally in the near future. What is the Indian scenario? We are thin fat Indians with more fat and less muscle. Data from India support higher prevalence of insulin resistance in patients with NAFLD, and almost 83 to 98% of the patients with NAFLD are insulin resistant. Now, different studies have shown that higher insulin resistance and higher hepatic triglycerides are there in Indians compared to other races. This is Peterson's study, who measured hepatic triglyceride content and plasma interleukin concentration in different ethnic groups. And they found that the hepatic triglyceride content and plasma interleukin 6 concentration are nearly 2-fold higher in Asian Indians as compared to the white Caucasians. The increase in hepatic triglyceride is associated with a higher prevalence of insulin resistance in Asian Indians. So Peterson also looked at the prevalence of various metabolic risk factors among different races. And in spite of lower BMI, Asian Indians have the highest level of fasting serum insulin and insulin resistance in compared with other ethnic populations. So the NAFLD seen in India, it is important to note that all the association of NAFLD, that is excess body fat, abdominal obesity, diabetes, hypertriglyceridemia and insulin resistance are highly prevalent in the urban Asian Indians and may be important for pathogenesis of NAFLD. So it is reasonable to presume that NAFLD would also have a very high prevalence in India. However, this data is scarce. So what would be our take today? See, basically, pioglitazone therapy seems to be an effective treatment for NASH. Any treatment that reduces insulin resistance is going to benefit NASH. Type 2 TZD needs to be given indefinitely. Given its propensity for weight gain, a combination with SGLT2 will neutralize that weight gain. So if you combine an SGLT2 with a pioglitazone, you have the benefits of pioglitazone minus the weight gain. And it can be considered one of the preferred agents in diabetic patients with NASH. So to conclude, Indians have the highest prevalence of insulin resistance. Diabetes and CVD start much earlier in Indians as compared to other ethnic groups. Insulin resistance plays a pivotal role in the development of NAFLD, cardiovascular disease, and stroke. Treating insulin resistance aggressively as early as possible is the surest is the key to prevention and treatment of NAFLD. Thank you very much, ladies and gentlemen.
Thanks a lot, Dr. Vijay. It was a wonderful and a very encouraging session. Very enlightening to know for certain points. Like, obviously, we all know that insulin resistance is the main key stay, but then you put it so well that we could make everything. So lifestyle, pre-diabetic, and vitamin E, pioglitazone, and obviously taking control of your insulin resistance will help us a lot. So thank you very much, sir. Thanks for this wonderful session.
Thank you.
So stay back for the discussion toward that.
Okay.
Thank you.
Moving on to our next speaker, Dr. Hitesh Punyani. He's a director at Chaitanya Cardio-Diabetes Center. He completed his MBBS from PGIMS Rohtak. He's a member of RSSDI. And some of the services provided by the doctor are type 1, type 2 diabetes management, including diet counseling, thyroid disorders, hypertension, and various other cardiovascular diseases and infections. So I welcome Dr. Hitesh for the session.
Thank you, Dr. Seema. And let me first of all congratulate Dr. Rajiv Chawla sir and Dr. Shalini for organizing this scientific feast. And it's been already a grand success, I should say. And the choice of topics are, to say the least, is very, very, thought-provoking. So let me start sharing my slides. Are the slides visible?
Yes.
Put it in slideshow.
Yeah, it's in slideshow now. Is it okay?
Yes, okay. Please proceed.
So I'll start with moving on from NASH to something very related, which is the diabetic dyslipidemia, and we'll be talking about the current recommendations in this management of this disease. So this shows us the various components that diabetes / ASCVD or dyslipidemia, they're all interrelated. So dyslipidemia being at the center, you have the complications in the form of stroke and coronary artery disease, with hypertension and obesity being surrounded, and all these, this dyslipidemia, hyperglycemia, they work as a fertilizer for this poisonous plant of coronary vascular disease that we get in a due course of time. So if we talk particularly of morbidity and mortality in diabetes, we are all very well versed about the fact that more than 50% of the morbidity, and almost to the extent of 60-65%, is being attributed to coronary heart disease or cerebrovascular accidents. In all, the vascular injuries or the vascular disease contributes to major chunk of morbidity and mortality from this disease. And that was the reason that when we were graduating from our medical college, so this was a very, very common term, that diabetes was put as a CHD risk equivalent, which meant what? That if we put the patients in these 4 categories, that the patient who has no diabetes, no MI, patient who has no diabetes but he had cardiovascular event, plus a patient with a diabetes but he has had no cardiovascular event. So what we see is that the patients, those who do not have diabetes but had one episode of myocardial infarction, they almost had similar incidence of second episode of myocardial infarction as the patients, those who have diabetes but had no previous history of ASCVD or any vascular event. So such was the scheme of things. But as we know, diabetes is again a very, very, it's a broad spectrum disease, depending on so many things, the duration of the disease, the comorbid factor. Eventually, there was and this was the paper which came out in JAMA, and they had this Canadian population studied, and what they concluded was that what was so apparent in 1994, that it is CHD equivalent, not so the case by 2014. And one of the main reasons in that being because of the better control of hyperglycemia, of course, but along with it, we are addressing this disease multifactorial approach now. We are addressing the hypertension, we are addressing dyslipidemia, which are very important components of reducing the cardiovascular morbidity in these patients. So dyslipidemia management in that sense becomes a very vital part once we are talking about reducing the morbidity and mortality from this disease called diabetes. And when we talk about diabetes and dyslipidemia, so there are few things which are a little peculiar here. So if we take type 1, what's surprising is that type 1 population is almost, the glycemic control, if their A1C is well maintained, so their lipid profile is almost as good as the normal population, as what we call as the control population. But in case of type 2 diabetes, even with a decent control, there are few peculiarities there. One is that there is increased triglycerides, increased VLDL and IDL, which are again rich in triglycerides, and a non-HDL cholesterol component also goes up. Simultaneously, there is a decrease in the protective HDL protective lipid, which is the HDL cholesterol, which comes down, and LDL cholesterol, though numerically remains normal, but we know that there is increase in the small dense LDL, which is a lot more atherogenic than the normal LDL. And if we talk about the poor control, so then again the triglycerides, they are further accentuated. VLDL, IDL again go up, and there is further drop in the protective cholesterol, which is the HDL1. But here again, where the LDL-C, which was almost normal in well-controlled diabetes, so there is a modest increase in LDL cholesterol, and there is further increase in small dense LDL particles. There are few things more which are again very interesting when we talk about the lipid abnormalities in these patients. One is that normally we know that there is postprandial upsurge in the plasma triglyceride levels. Now, this postprandial increase in serum triglyceride levels is quite accentuated in these patients who have type 2 diabetes. Second is HDL, though numerically might be little low, but actually it is not fully reflecting the overall risk of CVD in these patients. The HDL, which normally has antioxidant and anti-inflammatory properties, when this HDL is isolated from these patients, so these antioxidant and anti-inflammatory properties, they are reduced to a great extent in this population. Along with it, the ability of the HDL to efflux cholesterol is also reduced. So overall, the HDL is low and it's perturbed as well. So it's not a normal HDL that we see in these patients. So this is again the slide depicting the mechanism. So one of the key reasons being that there is increased output of VLDL from the liver, which again being because of the increased supply of free fatty acids to the liver. Free fatty acids coming again from the increased adipose tissue mass, as well as there is decreased insulin activity. So there is increased conversion of triglycerides into free fatty acids in the adipose tissue. Secondly, the free fatty acids are de facto also increased by the liver. There is increased production per se by the liver of fatty acids, and this is because though there is insulin resistance to the carbohydrate metabolism, but to the lipid synthesis, the liver remains sensitive. It's not resistant even in type 2 diabetics. So there is increased production of these fatty acids, which in turn leads on to increased production of triglycerides, and this in turn leads on to increased outpouring of the VLDL from the liver. This VLDL which is along with the chylomicrons, which are rich in triglycerides. So CETP, which is the enzyme, this gets activated, and there is increased conversion or increased transfer of triglycerides from VLDL as well as chylomicrons to HDL and LDL. And this transfer of triglycerides to HDL leads, along with the LDL, it leads to increased hydrolysis of triglycerides and leads to the production of HDL cholesterol along with the, leads to the production of small dense LDL and small HDL as well. And then this further explains the increased production of triglycerides or increased value of triglycerides along with the small dense LDL particles that we see in these patients. So how do we manage these patients? We'll come to the drugs, and first of all and foremost, as in diabetes, again lifestyle changes are the first things which need to be addressed. And there is hardly any debate regarding the exercise part. Almost every organization agrees that there has to be minimum of about 150 minutes of walk per week, which leads to increase in HDL cholesterol. However, for increase in HDL cholesterol, you need to have a vigorous exercise, and along with that, it also helps in decreasing triglycerides. And then with the diet, there's a lot of debate. There are lots of pros and cons. We have high complex carbohydrate diet. We have high monounsaturated fat diet, low carb, increased protein diet. Every diet has its pros and cons. But the bottom line is that the weight loss is very essential in almost all these patients. And one of the foremost things which needs to be kept in mind is that this diet has to be tailored according to the patient's preferences, because diet is only successful if it can be taken to a long term. So the short-term weight loss or the short-term adherence to these diets, it's not very meaningful. It only has some advantages, or it gives optimal outcomes once it's carried for a long period of time. And this only happens if we customize the diet or tailor the diet as per the patient's needs. Coming to our lipid-lowering drugs, so these are the drugs. Most of the drugs we have covered in this table. Statins stand the foremost. They are the most potent, one of the most potent drugs that are available to us. And we see that all of these have, on these three main components, LDL cholesterol, HDL cholesterol, and triglycerides, they have their own contribution. So if we talk about different classes of drugs, we'll just highlight. We'll talk a little bit about statins and just touch base the rest of the drugs that. So if we talk about statins, we have a very good evidence now, and this was cholesterol treatment trialist data, which was from about 14 RCTs, and it was done in about more than 18,000 patients. And what they found was that with every 39 milligrams per deciliter reduction in LDL, the all-cause mortality, vascular mortality, and major vascular events, they all came down. And this effect was very evident, not just in the secondary prevention patients, those who already had vascular event, but also in the patients, those who had primary disease or those who were with risk factors, but had not sustained any cardiac event till that time. So we'll just highlight these two studies, which were very big in size. So heart protection study was one. It was done on patients who already had CV events or those who were very high risk for atherosclerotic lesions. Again, 20,000 patients, 6,000 were diabetics. It was double-blind RCT, and 2:2 design was there. Simvastatin 40 milligrams versus placebo, and antioxidants versus placebo. Antioxidant arm was no beneficial effects, no harmful effects. And with simvastatin, there was a very significant reduction in terms of CV events. And in diabetics, it was further enhanced. The interesting thing was that this reduction in CV events was irrelevant of the duration of diabetes. Both short duration and long duration almost fared equally well. And again, it was also not dependent on your baseline A1C. The patients who had less than 7%, more than 7%, tended to behave in a similar manner. And almost all other subgroups, depending on age, sex, presence of comorbid conditions like hypertension and renal disease, they almost, we had this positive impact in all the subgroups. The CARDS trial was another big trial, and again, this was important because this was mainly a primary prevention study. So these patients had no evidence of clinical atherosclerosis, and they were put on atorvastatin just 10 milligrams per day. And by putting it on 10 milligram per day, there was a very significant reduction in the CV events with this as well. So these two showed us the relevance or the benefits of putting the patients on statin. And then we had this very interesting reversal trial, though the patient number of patients was not much. They studied moderate lowering versus the aggressive lipid lowering. Now, this is what the norm is. And what they did was they put the patients on 80 milligrams atorvastatin versus 40 milligrams of pravastatin. And LDL levels achieved in atova arm were 79. Obviously, they were quite less as compared to the pravastatin arm. And they studied the atheroma volume after giving these drugs after 18 months. And they did this intravascular ultrasound. And what they found was the atorva arm, where the LDL had come down to less than 80, had no change in burden of atheroma. In fact, there was slight regression, whereas in case of pravastatin, there was a progression of lesion. So this 50% reduction in LDL cholesterol levels, it led to a result in a way there was a absence of progression of lesion, though in fact there was mild regression. Asteroid and statin, they further lowered the LDL down, again with very high doses of atorvastatin and rosuvastatin, and they brought it down to even less than 70. As we can see, that asteroid had 61, that mean LDL level. And there what they found was, when you bring down the LDL cholesterol level to less than 70, then you have the regression of lesion. So once you bring it down to less than 100, you start you prevent the progression of the lesion, and once you bring it down to 70, so there is almost the evidence in form of regression of lesion. Similarly, PROVE-IT and TNT, these were not the atheroma volume studies, but they were the outcome studies, and again very aggressively treated patients in these trials. And what they found was, once you treat the patients with high doses of atorvastatin or rosuvastatin for that matter, the CV outcomes became a lot more desirable. A word about the impact of statins in glucose homeostasis. So they do have some adverse impact. And if we take the study from this was almost from more than 9,000 patients, and they found that the risk of developing diabetes is almost increased by 10% in patients who do not have diabetes, and higher doses produce more incidence. And also there is older obese category of patients, those who already have higher baseline values, they are even more prone to get diabetes with this class of drugs. But if we talk about the diabetics, what they found was there is a very minor or very modest elevation of A1C of just 0.12%, higher than the normal population, which was clinically insignificant. So once we put the patients, we have seen there's a very good clinical evidence. The efficacy of the drugs is very good. So whether we should be adding other drugs to statins to further reduce CV events, but difficulty is because the reduction with the statins has been so robust that we need very extensive, very large trials to find some additional benefit. Fibrates, a word about them. They again have been coming in and out, so not very convincing evidence till date about the fibrates. But we have some few insights when we dig in these trials. So one is that they give heterogeneous results, but in some populations, those patients who have high triglycerides and low HDL, fibrates tend to do well. So if you subgroup analysis was done, so what they found was those patients who had this category where there are increased triglycerides and decreased HDL, so they tend to fare well with this class of molecules. Though combining them with fibrates in most of the trials, and latest one I think was a cord arm where they added with a high dose of statin to the fibrates. The overall CV outcomes were not benefited much, though there was trend towards the benefit. But there are 2 or 3 things which need to be mentioned about this. One is that the fibrates again have a anti-inflammatory effect, and they have a unique effect of PPAR alpha activation, which is in the atherosclerotic lesions, and thus they seem to have a directly impacting the lesion formation and development, irrespective of their impact on the triglycerides or HDL levels. Similarly, if there was a field study, it was a very big study, and in which they found that again in the subgroup analysis, that those patients who those who were put on fenofibrate, there was a positive impact on the diabetic eye disease. The laser therapy requirement was decreased. the incidence of proliferative retinopathy and maculopathy was also decreased. Similarly, in a cord study subgroup, the progression of retinopathy was significantly lower. And not just retinopathy, nephropathy again. So it was seen in this cord study subgroup only that there was some reduction in urine albumin excretion, and mainly the progression from normal albumin to the microalbuminuria was decreased in this subgroup. So they seem to have some protection in reducing the microvascular complications. Bile acid sequestrants, again, they are challenging in sense because of their GI toxicity. The dose is somewhere close to about 3.7 grams, and because of their strong drug interactions, they have to be given even 2 hours before or 4 hours after the other drugs. And this with in a patient population with diabetes and CVD, so they're already on multiple drugs, becomes a very challenging drug to use. But and in some of the patients, another disadvantage is that it increases serum triglycerides as well. But one advantage is that there is almost 0.5% advantage of glycemic the A1C levels in patient population is already hyperglycemic. Similarly, niacin again, when initially 1966, 1974 was used, it was found to reduce CV events. It was used alone. But then when it was combined with statins, AIM-HI and HPS2 Thrive, these were the two important studies, we couldn't get much of a benefit by increasing the HDL levels. So rather, there was an increase in stroke in the niacin-treated group in the AIM-HI study. And along with it, we can see that skin flushing is a very, very famous side effect, which has led to a lot of dropouts as well in these trials. Then there is reduced insulin sensitivity, which worsens the glycemic control. It also leads to increased uric acid levels in many of the patients. So ezetimibe has made inroads for last few years after this IMPROVE-IT came. And in again, IMPROVE-IT, this was a large trial. It had almost 30% of the patients had diabetes. And what they did was they had intensively treated, treated patients on atorvastatin, and they were brought down to 70 milligram. And by adding ezetimibe, they brought it down to 53 milligram. And there was a significant decrease of about 6.4% in major CV events. So you can imagine, once you have already at 70, so bringing it to 53 is further giving you 6.4% decrease in the CV benefits. So these effects, when and subgroup analysis was done, was even more pronounced in patients those who had type 2 diabetes. The new another very potent class of molecules, which is PCSK9 inhibitors, Fourier and ODC. These were the two major landmark trials, again used along with statins, and they are extremely potent in a sense that they bring down LDL cholesterol level by almost 60-70%, in few studies even 80%. The drawback being that they are injectables, extremely expensive drugs, and only in patients where you can justify this cost, they can be brought in. But otherwise, a very, very useful addition to the armamentarium. Another class we would like to mention is adding omega-3 fatty acids. Now, this has a very unique place in a sense that those patients who have high triglyceride levels, this is even using statins, if your triglycerides are more than 145, as the guidelines mentions, 145 to 499 triglycerides, and you're using the maximum tolerated dose of statin, then instead of going to fenofibrate, the guidelines indicate that we should move to omega-3 fatty acids in very high dose though. So EPA dose is almost 1800 milligrams if it has to be effective, and GELIS and REDUCE-IT were the two trials which have corroborated its beneficial impact in terms of outcomes. And these beneficial impacts are again not just because of bringing down the triglycerides. As we can see, they're anti-inflammatory, their platelet decreasing function, decreasing lipid oxidation, and stabilization of membranes also plays a crucial role in these patients. So when we talk about statins for diabetic dyslipidemia, so we have these these categories, which is atorvastatin, rosuvastatin, Simva and Preva. We are not using India, so we'll just stick to ourselves. High intensity means 40 or 80 milligrams of atorvastatin and 20 or 40 milligrams of rosuvastatin, and moderate intensity is 10 to 20 of atorva and 5 to 10 of rosuvastatin. And if you go by the guidelines, so these are the current guidelines, and as we go, these are the ADA guidelines. So according to these guidelines, almost all patients who are in the age group of 40 to 75 years in diabetes, so moderate intensity statin therapy is indicated. In those who are more than 75, then after a reasonable discussion, and if you have longevity is still looks good, so then we can have the discussion with the patient without much of the morbid conditions. So discuss and start moderate intensity statin therapy in these patients as well. So if multiple risk factors or patients who are at very high risk, or age is 50 to 70, then they recommend using high intensity statin therapy. And if your 10-year risk, which goes by the ASCVD score, is more than 20%, then you might add ezetimibe to these group of patients to bring down the LDL cholesterol to less than 50% of their previous levels. And in secondary prevention, it's very straightforward that you have to be on high intensity statin therapy or the maximal tolerated dose. And if the risk is extremely high, then you consider adding ezetimibe or PCSK9 inhibitor if LDL levels are still more than 70 milligrams per deciliter. NLA, this is again,
Hitesh, you'll have to conclude fast.
Yeah, just 3 or 4 slides. Yeah. So LDL, National Lipid Association says that it also brings down on the non-HDL part, and says that if your patient is high risk, non-HDL has to be less than 100, LDL has to be less than 70. Similarly, low risk, so LDL has to be less than 100 and HDL has to be less than 130. Similarly, ACE guidelines, they categorize into these 3 categories: extreme risk, very high risk, and high risk, and they bring along ApoB as well. So they want 70, 80, and 90 is the limits in extreme, very high, and high risk for ApoB. Similarly, we have these dyslipidemia recommendations in our RSS-DI guidelines, where they also mention about bempedoic acid and saroglitazar in patients, especially in those who have hypertriglyceridemia. And bempedoic acid, those who cannot tolerate statins, or where we further want to bring it down to less than 55 in few of the cases. So first of all, we need to address the LDL levels to bring down to the goal. We have a very strong database now, which says that, which links this lowering of LDL with the reduction in CV outcomes. First choice, of course, in lowering LDL is statins. Then we have intensive statin therapy, where we have amazing evidence in terms of bringing down the event rates in patients who are high risk or those who have ASCVD. And when we are using the maximum dose of statin or maximum tolerated dose of statin, we are not reaching the goal LDL levels, or we desire that the patient is very high risk, that it has to be on lowest possible LDL levels. So ezetimibe along with the PCSK9 inhibitors are the drugs which are available to us for that. So as a second choice drug is ezetimibe or PCSK9. Bile acid sequestrants and bempedoic acid, again bempedoic acid, they are the alternatives, but not much used in clinical practice. Maybe bempedoic acid will be in the coming years. An interesting part is all these molecules, whether ezetimibe, PCSK9, bile acid sequestrants, and bempedoic, they act additively in lowering the LDL cholesterol concentration, because they increase the LDL receptors by very different mechanisms. So they have a very additive effect once you add. Second priority has to be non-HDL cholesterol. Again, we know that total cholesterol minus HDL is non-HDL, and it is a measure of all pro-atherogenic apolipoprotein B containing particles. And various studies have shown that non-HDL is a strong risk factor for CVD. In fact, we had one study in our own hospital as well, which was in our unit. I did with Dr. Rajiv Chawla, Dr. Ashwin did, I think, in our unit. And triglycerides, if controlling about this, so glycemic control becomes very important, because once we control blood glucose levels, triglycerides fall in place. Lifestyle changes, especially the decrease in ethanol intake, if it is there, decrease sugar levels. And once you cannot get the desirable level in spite of using statins and triglycerides high, omega-3 fatty acids are the drug of choice. But in selective patient population, we can also think about fibrates, where triglycerides on a higher side, HDL is on a lower side, whereas it has added benefit of reducing microvascular complications. And HDL, very strong data which links low HDL with CVD, but not much of a data showing that increasing HDL-C with pharmacological drugs is of any value. Thank you so much.
Thanks a lot, Dr. Hitesh. Very well spoken, wonderful session. You touched from the base till the pathophysiology and all the lipid lowering drugs. So finally, we come to the conclusion that lifestyle plays the major role in not getting into the disease. And if you got, again, lifestyle plays a major role, then there are several lipid lowering drugs, and amongst them, statins still stand at the first place. Along with that, other lipid lowering drugs. So to keep the session moving, I now will welcome Dr. Arvind Gupta for the next session, and his topic is diabetes and anemia. Sir is from Jaipur. He has several feathers in his hat. He's an MD, FRCP, Fellowship of American College of Endocrinology, Fellowship of RSSDI, Fellowship Royal College of Physicians and Surgeons, RSSDI Oration Gold Medal he's taken, and he had been the chairman of RSSDA Rajasthan chapter. He has been the joint secretary to the Indian Society of Hypertension and organizing secretary in the 31st annual conference of RSSDI, member research committee National RSSDI Delhi co-scientific chairman, member project review committee ICMR, regional faculty diabetes course in for PHFI. He's an associate editor for certain presented papers in various international conferences like ADA, IDF, EASD, and AACE. And over 90 research papers are published in national and international journals by Sir. And he's contributed several chapters in postgraduate medicine API textbook. And he's a member of AACE, API, IMA, RSSDI. I welcome you, sir, for your new session on diabetes and anemia.
Thank you, Dr. Seema, for your kind introduction. And just on a passing reference, let me first, where is my... My slides are not coming. Just a minute. Is my slides are showing?
Yes, sir. Yes.
Okay. Okay. Yeah. Thank you, Dr. Seema, for your kind introduction. And just today, I have completed 100 of my publications with the publication in Lung India of the COVID.
Congratulations, sir. Congratulations.
Thank you. So, at the outset, I also thank Dr. Rajiv Chawla, Shalini for putting me in this very prestigious scientific conference. Thank you, Dr. Rajiv and Shalini for putting me into this. I want to talk about a very, very different type of topic, very least talked in the conferences, and also a very neglected topic into day-to-day practice. When the patient comes to us anemia, we don't take it seriously. So I think let us discuss something about the relationship between anemia and diabetes. These are my disclosures. Let me put on the first at the outset. Anemia is one of the commonest and prevalent blood-related disorder occurring in patients with diabetes. We never think of that earlier, and mostly occurs especially when the patients are already having the renal impairment or renal compromised patients. Most of the evidence indicate that the existence of anemia among type 2 diabetes is especially associated when kidney is failing, and in that situation, the appropriate erythropoietin is deficient. We know this fact very well, that anemia can adversely affect the health of the patient. The quality of life of the patient is actually suffer suffering when the patient is suffering from anemia. It has a major impact on the sense of well-being, quality of life suffers a lot, as well as impairing their ability to work and affecting their social and sexual lives also. It is a common and often neglected into day-to-day practice. And it is most of the time untreated complications of diabetes, which may have a negative consequence on the development and progression of other diabetes-related micro and macrovascular complications. I'll give you a few evidences for that. The risk of occurring anemia among diabetes patients with kidney disease is known. It is high and it occurs early in those patients with the same level of renal impairment with other etiologies. Of course, there are several causes for that, but for that matter, diabetic neuropathy, chronic inflammatory activity, increased levels of advanced glycated end products, age, erythropoietin hyporesponsiveness. Not only the production of erythropoietin is reduced, but there is a hyporesponsiveness in diabetes patients. Effects of oxidative stress and anti-diabetic medications are also important players which can cause anemia in diabetes. Of course, nutritional deficiency is very common, especially in our Indian population, Indian females. They are very, very common, and especially in diabetic patients, which may or may not be caused by diabetes, but it can also result in anemia. Of course, there are some medications like ACE inhibitors, fibrates, metformin, and thiazolidine-diones. Dr. Panikar is here, but we must agree on this particular aspect that these diabetes patients, these are also the drugs may result into the anemia in diabetes patients. However, if you see what the microvascular damage can reduce rates is survival. Chronic hypoxia in diabetes may lead to hematinic deficiency. Oxidative stress leads to reduced iron availability. Local inflammation leads to systemic inflammation. Autonomic neuropathy leads to occult blood loss, which we never know earlier. Increased salt reabsorption can, in the celiac diseases. Hyperfiltration in the kidney leads to drug, maybe because of other contributors like drug therapies, urinary erythropoietin loss. There is a reduced renal production in erythropoietin, and several other contributors are there, which may lead to the anemia in diabetes. We know that if patient is having both chronic kidney disease and diabetes, of course, anemia is a very, very common feature. And if you see the third NANS survey, which found that people in general population with diabetes were nearly twice as likely to have anemia as people without diabetes. So results from several studies have shown in diabetic clinics especially, the prevalence of unrecognized anemia is nearly 2 to 3 folds greater than in the general population. And in addition, these diabetic patients tend to develop anemia at early ages. That is very important, and with greater severity than the general population. Now, what is the real pathophysiology? If we come into the molecular level, EPO, erythropoietin, released by renal cells has been shown to be modulated by kidney splanchnic innervation. Indeed, the renal denervation in animal models have led to loss of EPO production in response to hypoxic stimuli. So this may be one of the mechanisms by which not only the production of EPO is reduced, but hyporesponsiveness is also there. Furthermore, EPO deficiency has recently been observed in anemic type 1 diabetes patients with severely symptomatic diabetic autonomic neuropathy. Of course, in one of the study, Bosman's study, which involves a small cohort of patients, of course, the serum EPO levels in anemic diabetic patients were found to be inappropriately low compared to the values observed in a control group. So there is a reduced number of erythropoietin synthesizing interstitial cells and impairment of the regular process, enabling the oxygen sensing through the hypoxic inducible transcription factor HIF-1 alpha, which is secondary to interstitial fibrosis or vascular lesions, are the main factors involved in the anemia. So these are the two important mechanisms by which the EPO reduces, and not only the cells which produces the EPO also actually are involved through the HIF-1 alpha. Of course, there are several other mechanisms involving cytokine-induced EPO synthesis inhibition, hyporeninемia, urinary loss of EPO has also been seen in some of the nephritic patients, and glycation of the EPO receptors by the or secondary to hyperglycemia. Dear friends, I need not to, give all the details. What are the consequences of anemia? And if you have diabetes and anemia, particularly these consequences increases to a greater level. They like reduce oxygen delivery to tissues, decrease HbA1c compensated by increased cardiac output. Progressive cardiac damage and progressive renal damage may occur. Increased mortality risk. Of course, the quality of life of the patient suffers a lot. They almost on a daily basis, they have fatigue, diminished exercise capacity, and reduced cognitive function. And of course, left ventricular atrophy is also implicated when the patient is having anemia. So there are several complications when the anemia and diabetes patients, and anemia is actually a very strong and independent indicator, where the Thomas study which published in Diabetologia in 2006. And this anemia may also be significant in determining the outcome of the heart failure and hypoxia-induced organ damage. Dear friends, please do not neglect anemia at any cost in your diabetes patients, because not only this quality of life, but also several micro and macrovascular complications, including heart failure, may aggravate. Of course, there are several complications. Anemia, diabetic patients have shorter half-life, shorter lifespan when they are suffering from anemia. It may lead to mitogenic and fibrogenic effects on the kidney and the heart, associated with the expression of growth factors, hormones, and vasoactive reagents. Anemia is also correlated with oxidative stress, because erythrocytes represent a major antioxidant component of the blood. So let me say what is the target hemoglobin. Most of the guidelines actually have shown that the hemoglobin of a person should be definitely more than 12 gram%. That is the one of the thing, but actually there is no recommendation as on now, but revised European best practice guidelines for the management of anemia says that the hemoglobin level should be more than 12 grams in any case. Of course, if you define anemia by WHO criteria, the hemoglobin should always be more than 12.5 gram%. So how we treat this anemia? Of course, there is no conclusive evidence of correcting anemia significantly anomalous clinical outcomes, but there are several studies I'll quote later. International guidelines allow the use of erythropoietin in the patients with CKD and anemia. Of course, now this is a topic whereby iron replacement therapy decreases HbA1c in both diabetic and non-diabetic individuals. So, iron replacement therapy patient is having iron deficiency anemia. This is the pivotal, the treatment part. Of course, this implies that the iron states must be considered during the interpretation of HbA1c concentration. Always when we see the anemia and diabetes, HbA1c is always, low in that case. Early diagnosis and treatment of ID in diabetic patients can improve their glycemic control also. So there are a few small studies demonstrated that correction of anemia is associated with reduction in retinal exudates and macular edema. So whenever we see the retinopathy, I think iron replacement or hemoglobin concentration should be more than 12 gram%. Treatment with erythropoietin in diabetic patient with heart failure may also reduce the length of hospitalization. And not only that, it improves the the New York Heart Association functional class also. So in experimental models of diabetes, treatment with erythropoietin has been shown to protect against the development of diabetic neuropathy also. So dear friends, now my talk will not be completed when I'll not talk about the little bit of the erythropoiesis in the last. Erythropoietin ensures the maturation of progen. It's very, very important thing. Erythropoietin rescues the neocytes from the apoptosis. And of course, erythropoietin helps in sustaining RBC proliferation and differentiation. Just see here, the erythroid marrow actually produces RBC, circulating RBC, carrying the oxygen through the kidney. Erythropoietin again aggravates the erythroid marrow to produce more RBCs. And if you see here, these are the stem cell or progenitor cells, and this is how the maturation of erythropoietin takes place. So if you see only these two things, the non-anemic patients and the erythropoietin, if you see, whenever the patients get the low hemoglobin, oxygen carrying capacity reduces, peripheral hypoxia is there, the kidney comes to the rescue, increases the erythropoietin, increases precursor cells, erythroblasts and reticulocytes, ultimately erythrocytes increases, hemoglobin increases, and oxygen transport. This is how in the non-anemic patients. But what happens in the patients which has a CKD? Now, because kidney doesn't produce the most of the erythropoietin or reduces, hence, if you see in the case when the hemoglobin is reduced in the patients, all the similar kind which we have seen earlier in non-anemic patients, now if you see the damage, the reduced erythropoietin, ultimately when it is insufficient, reduces the erythrocyte, anemia is still there. So the patient is continuously having anemia when the patient is having CKD. So the important thing about whenever we are actually treating the patients with erythropoietin, please replace the iron. That is very important. If erythropoietin is the vehicle that drives the erythropoiesis, iron is the fuel needed for production of new red blood cells. So this is my take-home message, that whenever we treat the patients with erythropoietin, iron should be there to, complete the RBC cycle. So to conclude my talk, dear friends, anemia is very common in diabetes patients, especially in Indian population. I see on an almost daily basis, not more than 10 or 11 gram% of the hemoglobin, not only in the males, but very common in females, with decreased renal functions and frequently complications of diabetic nephropathy, especially when the patient is having compromised renal pathology. The anemia is very, very common. Early diagnosis is the clue. Regular monitoring is required. Proper management with iron replacement, and if it is needed, erythropoietin therapy is very, very essential for a diabetic patient to prevent the micro and macrovascular complications, to increase the quality of life of the patient, and in due course of time, even it actually reduces the heart failure chances, or at least improves that thing. So thank you very much. The accurate measurement of blood sugar monitoring, glycated hemoglobin progress, and the progressive of the progression of the complication of diabetes are highly influenced by the severity of anemia. Please treat or manage anemia in your diabetic patients. Therefore, routine screening and proper treatment of anemia and diabetic patients will improve their quality of life. Thank you very much for this opportunity. Thank you.
Thanks a lot, Dr. Arvind, for enlightening us for the most neglected, I would say, complication, the comorbidity which is associated with the diabetes, because hardly this anemia part is seen. And we do not even know that before this anemia sets in, the kidneys are already on the toss. And we are going on to several micro as well as macrovascular complications. So thank you, sir. Thank you very much for the wonderful talk. And
we have 7 minutes. 1:30 we need to start the oration, so we can have one interaction with all the speakers. One question each to every speaker. Dr. Panikkar talked about NAFLD and NASH. I think a topic. Dr. Panikkar, sir, you are there?
Yes, I am there.
Yeah. I think this topic is so close to your heart. So, moment we were planning this scientific program, first this was that I must have you on this topic only, because I remember during RSSDA guideline also, you were very, very particular that in this new update 2022 RSSDA, we should have maybe little addition on NAFLD and NASH. So do you think that time is out that we include NAFLD and NASH now in our current guidelines?
Yes, it should be.
Because by then, ACE guidelines were already available on NASH and NAFLD.
True.
And you made a huge presentation on this topic. So you think
Rajiv, recently, from 1st September till 30th of October, every patient walking into my clinic has a fibroscan done. So we have done about 2,000 patients.
My God, okay.
In these 2 months.
Okay.
And we'll be collating the data. But I'm telling you, 90% have different grades of fatty liver. And to my surprise, I found some people with fibrosis, grade 4. When it's asymptomatic.
Agreed. Absolutely
so
agreed.
That is the kind of problem that we are looking at. And it is driven by insulin resistance. So like I've always been saying, start PIO as early as possible and you'll save all this.
Agreed. Totally agreed. I think earlier
can
days,
I have one comment
Arvind, I think
Arvind.
after this
from the Panikkar's point of view, diabetes is a fatty liver equivalent. That's it.
Yes, in fact,
yesterday,
there are studies which show that if you have a non-diabetic who has a fatty liver, you should consider him as a pre-diabetic.
Yes.
I think yesterday only we had a wonderful session by Professor Anup Mishra, Mohan and Dr. Das. And Dr. Das spoke on that diabetes originates from liver. And I put that question to Professor Anup Mishra because his lot of work is there on insulin resistance and metabolic syndrome. I said earlier days we were saying that it originates from liver. Today we are saying it is diabetic hepatopathy. So it is something like what we talk about kidney, whether it is a victim or a liar, but liver in any case cannot be ignored. And he and Mohan also agreed that these days, if you have a palpable liver, if it is an obese patient, overweight patient, earlier days we were just passing it off that it's a fatty liver on ultrasound. These days it is time that we must get a fibroscan in our own center. I have seen many patients whom we were just ignoring with 60, 70 OTPTs and we were doing only ultrasounds. Now we have started doing their fibroscans and we have found them, they are already at a fibrotic state. So I think this is very, very important. Well, doing a bedside examination followed by an ultrasound, moment there is a fatty liver or grade 1 or 2, we must subject them to fibroscan before we just say that it is simply NAFLD, because many of them might have significant fibrosis, especially if they are long-standing diabetic patients for about 8-10 years. What is your opinion, Hitesh? You are a top-grade internist. I always said, even in my oration at Chennai, said that if I have to learn anything and medicine, I have to go back to Hitesh again.
Listen, again, I'm stunned by the data by Dr. Panikkar's clinic.
Yeah.
If his clinic has this data where PIO is used like anything, then imagine what will be, the data collecting from the other clinics like we without PIO. So yes, totally agree. I mean, I think there's no doubt about this. We are totally underestimating, and there has been we don't know whether we have better investigating tools now, but otherwise as well we feel that there is upsurge. There's a big upsurge in the incidence of this disease. No doubt about this.
I think ever since we are now sensitized to this fact, in our own clinical practice, we have picked up many patients at almost fibrotic stage whom we were earlier ignoring. So I think it is very, very important that clinically on bedside, we should not ignore these patients, those who have a fatty liver disease. We welcome Professor Ina Sheltout. She has already joined. I think it is high time because 1:30 we have to confer upon the oration. This is very, very prestigious. We already have Professor Mohammed with us. I'll request all of you to stay back. Professor Panikkar, Dr. Hitesh, Dr. Seema, Dr. Arvind, if you can still continue being with us. I'm sure you were saying that you had to leave little early. So I think we are going to have a great oration, and after that, another few very interesting sessions. So I think we will close this session here only with a lot of applause for all the three speakers. You have done wonderful job. Arvind, Hitesh, and of course, Professor Panikar, as always, has been a wonderful teacher to all of us. Thank you very much, and
thank you
over
so much,
to
sir.
Dr. Shalini. Thank you, Dr. Seema.
Thank you, sir. Thank you, sir. Thank you.
Thank you.
So good afternoon, everyone. This is a very privileged moment for all of us to welcome our partner in this event. She's been with us, our guiding force for the last few years, ever since we've associated with the Arabic Association for Study in Diabetes, Professor Inaz Shaltout, the president of AASD, joining us from Cairo, Egypt. We're very happy to have her for this gold medal oration, which we confer every year to one of our luminaries who has been instrumental in the success of this program. Thank you for joining us, ma'am. And I'll request Dr. Chawla to read out a citation in her honor.
Thank you. It's great privilege to welcome you all to CMRE ASD 9th International Symposium in Diabetes, which is sequentially the third one ever since we have partnered with ASD. And Mohammed and Professor Inaz have been kind enough in making that partnership grow popular and popular. And as Mohammed always says, a very close friend, that we must pick up the best or the positive outs of this post-COVID, where there are different norms. So this is what we did, that we tried to go internationally through ASD and through Professor Mohammed to reach out to Middle East, to Egypt, to a lot of part of UK, US and UAE. And I once again proudly announce that we have registered about 5,000 delegates this year also, like last year. And we had a lot of logins. Even in the last session yesterday, we had close to 930 or 939 delegates glued to the screen till 9 p.m. when Dr. Dandona was delivering his key lecture. So it's our privilege, proud privilege actually, to confer upon this prestigious CMRE gold medal oration on Professor Inaz Shaltout, who is President ASD. She has done her MSc Internal Medicine from Cairo University. She has been a university president for Arabic Association for Study of Diabetes and Metabolism, ASD, Cairo University. She has been Professor of Internal Medicine and Diabetes, Faculty of Medicine, Cairo University from 2004 till now. And she has done number of international conferences under her presidentship. And 30 of her students, they have already completed thesis over last 25 years. She has been a supervisor and a guide for MSc as well as MD thesis. Her present work involves being her focus on internal medicine and diabetes in Cairo University. She has also been simultaneously consultant at Islam International Hospital and Newcastle LNE Teaching Hospital. She worked as a chairman, internal medicine, Faculty of Medicine, Cairo University since 2017 to 19. She worked as honorary lecturer, diabetes diploma, Cardiff University program, United Kingdom for 5 years, where we have been associated with Mohammed also. And she is a peer reviewer for many national and international journals, including Diabetes Research and Clinical Practice and International Journal of Clinical Practice. Her scientific activities, I told you, she has been president of annual conferences of Arabic Association for Study of Diabetes and Metabolism since 2006 till 20, almost 14, 15 conferences were organized under her presidentship. She is the president of Arabic Association for Study of Diabetes and Metabolism and held international conferences in collaboration with many other Arabic societies. She has organized several doctors, diabetes nurses, and patient educational activities and programs under her presidentship. It is a great honor for us to confer upon this prestigious CMRE Gold Medal oration for Professor Inaz Shaltout. So a big applause for her, and we give her a standing ovation. I wish we could host her this year, but again, because of prevailing circumstances, that was not possible. So again, we are doing this virtually, but I'm sure once we go back to our physical mode next year, last year we awarded Professor Mohammed and earlier Professor Shashank. So we will like to have them together here once we organize our 10th conference, which will be a sort of benchmark for us, maybe in month of September. We are yet to finalize the date, but that may be 24th of September 2023, where we'd like to host them along with Professor Colin in a physical meeting. Over to you, Professor Ina Sheltout, for delivering your oration.
Thank you very much. It's an honor and pleasure to be with you in this excellent cooperation, and I hope for future cooperation to be physically soon. Thank you very much.
You may start your presentation.
Thank you again for the kind invitation and for the honor you gave me. And I'm going to talk about women and diabetes. There is an estimated 204 million women living with diabetes, and this number is projected to increase by 2045 to be 308 million persons, so 50% at least increase. 1 in 3 women with diabetes is in the reproductive age, and diabetes is the 9th cause of death in women globally, causing 2.1 million deaths yearly, and 1 in 7 births is affected by gestational diabetes. This is according to the IDF Atlas. So this is the statement of IDF. Diabetes is the 9th leading cause of death in women globally, and our right to a healthy future. And for those lovely women celebrating the WDD, people with diabetes can live healthy and fulfilling lives with providing them with an interrupted supply of insulin, blood glucose testing equipment when combined with a healthy life. These are the known diabetes complications, and for pregnant women with diabetes or at high risk for gestational diabetes, they should manage their glycemic control throughout their pregnancy to avoid long-term complications on themselves and on the children. There is a transgenerational effect, higher risk of obesity, higher risk of diabetes, hypertension, and kidney disease to the offspring. 1 in 6 live births is affected by hyperglycemia during pregnancy. Diabetes with pregnancy is either a preconception diabetes or gestational diabetes. And these are the 2 categories of diabetes during pregnancy, either pre-gestational diabetes, which is pregnancy in pre-existing diabetic woman, either type 1 diabetes or type 2 diabetes, and gestational diabetes, which is diabetes diagnosed for the first time during pregnancy. Let me start with the preconception diabetes. And the pre-existing diabetes or preconception diabetes, this is the natural history. 60 years ago, 2% of females with diabetes died during pregnancy, and 10% of babies were born as stillborn, and 10% of babies died during the first months of life. This is actually horrible consequences. But during 1980s, evidence of good preconception diabetes control improved the outcome. Studies in 1990s, if the conception hemoglobin A1C is above 10%, the congenital malformation rate is 10%. And if the conception hemoglobin A1C less than 7%, the congenital malformation rate is that of the general population. This is the hemoglobin A1C pre-conception or at conception, and the incidence of congenital malformation, fetal malformation. And as we see, if the preconception hemoglobin A1C is high, then the congenital malformation percentage is high. So glycemic control preconception is essential. How to manage pregnancy in diabetes? There should be a preconception clinic, and at the preconception clinic, we should insist of preconception hemoglobin A1C less than 7% and to stop all teratogenic medications, especially ACE inhibitors, to stop smoking, to start folic acid 5 milligram at 3 months preconception, to check rubella status, and to switch to insulin if on oral agents. Again, we should do a retinal screening and to discuss the potential deterioration in retinopathy and nephropathy during pregnancy with the patient, if the patient is having enough children or not, to discuss the schedule of care in pregnancy, and to do albumin creatinine ratio. To encourage ladies to do, this is the prenatal care or during conception, to encourage the mother to do SMBG regularly, to adjust the insulin dose in order to maintain normal blood glucose levels, and we are going to see how strict blood glucose control during pregnancy should be. This is the Canadian Diabetes Association. There is need for optimal glycemic control in pregnancy for pre-existing diabetes, and insulin therapy should be individualized. Bolus insulin, we may use aspart, insulin aspart or Lispro instead of regular insulin, but using regular insulin is actually okay without complications. And for basal insulin, we may use Ditimer or Glargine as alternative to NPH, and to encourage patients to do SMBG pre and post-prandially. And these are the targets for glucose values, which are very tight. For fasting plasma glucose, less than 95 milligram, 1 hour postprandial, less than 140 milligram, and 2 hours postprandial, less than 120 milligram. These are really very tight and difficult to achieve, especially our patients are not using the insulin pumps usually during pregnancy. And for AGA and American Association for Clinical Endocrinology, these are the glycemic targets during pregnancy. And there is a little bit difference between patients with gestational diabetes and patients with pre-existing type 1 and type 2 diabetes. And for the pre-meal, prandial insulin in patients with gestational diabetes, less than 95, while in patients with pre-existing type 1 or type 2, the pre-meal, bedtime, and overnight glucose should be between 60 and 99, which again is very tight and difficult to achieve. For postprandial blood glucose level or plasma glucose level in patients with gestational diabetes, 1 hour post-meal less than 140 milligram, and 2 hours post-meal less than 120 milligram. And for patients with pre-existing diabetes, the peak postprandial should be between 100 and 129 milligram per deciliter, and for hemoglobin A1C to be equal or less than 6%. These targets are very difficult to achieve, especially in absence of use of insulin pump. Hypoglycemia should be discussed and glucagon to be made available, which again, difficult to achieve, with clear instructions on its use, and a full retinal assessment should be taken in all women with pre-existing diabetes during the first trimester. This is the hypoglycemia during pregnancy, and the pathophysiology may be due to absorption by the baby via the placenta, especially during periods of maternal fasting. And the risk factors include history of severe hypoglycemia before pregnancy, impaired hypoglycemia awareness, longer duration of diabetes, hemoglobin A1C less than 6.5, and high daily insulin usage, and iatrogenic hypoglycemia, either administration of larger doses or skipping a meal or exercising more than usual. And the clinical consequences of hypoglycemia are known, with risk of coma, a traffic accident, and death. Severe hypoglycemia can lead to maternal seizures or hypoxia, and management is to inform the patient about the risk of severe hypoglycemia during early pregnancy, and to educate the patient how to prevent and how to do SMBG regularly, and regular meal timing and accurate insulin dosage, and careful management of exercise programs. How to handle hypoglycemia according to whether severe hypoglycemia and the patient cannot swallow, or mild to moderate hypoglycemia, and what to do for each type of hypoglycemia, and to repeat checking the SMBG, and to detect if less than 60, then we repeat measures to manage hypoglycemia. Retinal screening, if there is no retinopathy in the first trimester, then to repeat the retinal screening every trimester, and if retinopathy, refer to ophthalmologist. And deteriorating retinopathy may happen due to vasoactive and angiogenic factors. To do creatinine and albumin-creatinine ratio early in pregnancy, and if abnormal, to repeat each trimester. And most deterioration in nephropathy is reversible, and microalbuminuria will double the risk for preeclampsia. This is the prenatal care. All women with diabetes should be referred to first trimester ultrasound, and should be offered detailed anomaly ultrasound during the second trimester, and of course a supervision with the obstetrician, and to do serial ultrasound during the third trimester, and to monitor fetal growth. If delivery is indicated before 34 weeks, then we administer glucocorticoid to prevent neonatal respiratory distress syndrome. During labor, the timing of labor should be assessed by the obstetrician, but no longer than 40 weeks, and usually before 38 weeks of pregnancy. To give intravenous dextrose and insulin during labor and delivery, and care of the baby, to do blood glucose tests every 4 to 6 hours before a feed, and to diagnose hypoglycemia, and should be we should be accompanied with the care of a neonatologist. What are the problems during pregnancy? There's difficulty in conceiving with very poor control of pre-existing diabetes and increased incidence of miscarriage, macrosomia, and polyhydramnios, obstructed labor, shoulder dystocia, placental insufficiency, preterm delivery, preeclampsia, increased risk of infections, diabetic ketoacidosis, which is maybe fatal to the fetus, and neonatal hypoglycemia, raised incidence of intrauterine deaths, maybe due to chronic hypoxia, hyperglycemia, or lactic acidosis. Most aim to deliver before 38 to 39 weeks of pregnancy. A few slides about gestational diabetes and gestational diabetes. Does it matter or not? These are the fetal complications of gestational diabetes: high birth weight or small for gestational age, macrosomia, hypoglycemia, dysmature baby, sometimes respiratory distress syndrome, birth defects, preeclampsia. Mothers will be diabetic, having type 2 diabetes 50% later on, and babies may have childhood obesity and type 2 diabetes later on. When to screen for gestational diabetes? In those with previous gestational diabetes, in those with resistant glycosuria, previous large baby more than 4 kilograms birth weight, current large baby more than 95th percentile, polyhydramnios, first degree relative with diabetes, previous unexplained stillbirths, polycystic ovary syndrome, and in those ladies with BMI more than 35 and certain ethnic groups. The postpartum evaluation for gestational diabetes: to do 6-week oral glucose tolerance test to exclude an ongoing diabetes or impaired glucose tolerance, and there is an opportunity to reduce the risk of type 2 diabetes in the future, and also to screen for the presence of type 2 diabetes in those ladies. Angelina Jolie, a famous celebrity, got gestational diabetes, and she was receiving insulin, this lovely lady, and thank you very much.
Thank you so much, ma'am. I think that was an excellent overview and excellent oration on women's health. And you so aptly touched upon the need, the specifications that are required, especially when it comes to preconception, how to manage pregnancy. You've actually covered the entire topic in such a small time. And I'm sure when it comes to women with diabetes, I think we need to keep a lot of factors in mind. And, just to share with you, we did meet the ADA president a few months back at one of the meetings that he had attended in person in India. And we happened to get talking because nowadays you hear a lot of discussion on the need for gender-specific guidelines, or at least gender-sensitive guidelines when it comes to managing type 2 diabetes. We did send him a pathway of care, a suggestion, which was accepted by the ADA guideline committee. And the current revision just adds that one line, to be aware and ask her if she's planning a pregnancy and discontinue certain drugs if she is in that preconception period. And we're also happy that the ADA guidelines have actually addressed preconception as a separate topic. And probably the next revision of the guidelines will have a little more gender sensitive and a gender specific approach, which is definitely the need of the hour in countries like ours. Dr. Chawla, your comment.
I think in continuation of what Dr. Shalini said and what Professor Inas said, even at RSSDI, Research Society for Study of Diabetes in India, we currently revise our guidelines and release last month only. But we have a, huge women lobbying. I'll not say lobbying is a wrong term, but those who are bringing it to absolutely to notice of all practicing diabetologists and endocrinologists that we must have something gender specific.
We already have a national task force. We have a national task force on diabetes and women, of which, I happen to be a part. And there are a lot of projects that we are initiating. And in the last year, we have initiated right from sensitizing young women and young girls on diabetes prevention. And then for the ones with diabetes, the way ahead, the steps forward. So I think it's time that women and diabetes, we start giving it ample importance. Dr. Hasnan, yes, sir.
Yes. Let me ask Professor Ines, and maybe you can take that question as well, Shalini. Where I work, the vast majority of ladies do not use a contraceptive measure. To them, a pregnancy happens whenever it happens. It's not a big issue. Now, when it comes to diabetes and all the other therapies such as antihypertensive, lipid lowering, even some of the anti-glycemic medication, it becomes a bit difficult of how long can you maybe not prescribe a statin or an ACE inhibitor and use antihypertensives, or is the consensus to use them and then once pregnancy is confirmed to change? What are the group with interest in gender specific guidelines advising regarding this? Because I'm not talking here about a year or few months of conception. I'm talking about possibly 5 to 10 years or 15 years.
A conception should be predetermined.
It shouldn't be left to chance. They are happy for it to happen whenever it happens.
We are trying to push education in our communities. Conception should be planned. It's not just a matter of chance. And those ladies who seek proper medical care with a consultant knowing how to deal with these patients is trying to educate all the time. So conception should be planned. And I want to take the Indian experience in this matter to try to apply to increase patients' awareness in our country. We need to increase awareness.
The question slightly. You have a lady who is well controlled from glycemic point of view. So she's aware of the importance of glycemic control. But my question is regarding, one, would you change the glycemic agents to be pregnancy safe or not? Second, would you not prescribe a lipid lowering or antihypertensives that are not recommended during pregnancy? Or would you just carry on as normal and once they are pregnant, change therapy?
If this lady is a young type 1 diabetes, coming for control, usually before marriage, they come for control. Then we start to tell the patients what to do before conception. And also, if the patient is taking oral anti-diabetic medication, we start to advise to change to insulin. But if pregnancy happens without any alarm, then we will have to shift to safer medications at once. So it's according to the patient's care, if the patient is going for regular doctor visit or not. It's actually the patient, we can check all the patients if they are going to get pregnant or not. But if the patient is educated enough and she's going to have planned conception, then she goes to the doctor, she starts to change medications and so. And this happens in many circumstances in educated persons, because now all educated persons are planning conception at a certain time or seeking sometimes for conception if there's difficulty on conception. But if the patient is not well taken care of, like in very poor population or so, you can judge. Then the patient is going to come with already taking complication. Then these patients most probably are not taking statins or not even taking antihypertensive of good quality. So it's according to the status of the patient, if well educated and seeking good medical advice or not.
Shalini, what's your take on that?
This is exactly what I am going to discuss in the symposium on diabetes in women at around 1:30 p.m. your time, preconception counseling and care. So to put things in brief, yes, we want everyone to plan a pregnancy, especially when it comes to somebody who's already got type 1 or type 2 diabetes. But unfortunately, pregnancies most of the times are accidental, unplanned pregnancies. And this is where the role of education, as Professor Inas said, stands very important. Because these are
both talking about a different culture. What I'm asking about here,
Mohammed, you're right.
Statin needs to be completely discontinued in a woman of reproductive age group because of the teratogenicity that is associated with statin use even in early pregnancy. So if you have a woman in the reproductive age group, I think you have to sensitize her very clearly not to get pregnant on a statin. And if you think the compliance is going to be poor, it is better to put her on an intensive diet rather than continuing a statin and take the risk of statin in early pregnancy. And same, I think, applies to the ACE inhibitors and the ARBs.
I think this makes sense, because what Professor Inas said is absolutely correct, that we have to educate them.
Yes.
But depending on the different ethnicities and the cultures, Mohammed, you are very right that many of these females, even in our country, they have an accidental pregnancy. So that boils out to the point, or that means that anyone who is in a reproductive age group, so there we will have to be very, very cautious while choosing the drugs. May be that we may not start them ACE and ARBs. It may be simple amlodipine-like drugs which are still safe, or nifedipine-like drugs which are safe. Let them not be on statin if they are not sure when they are going to conceive. And when it comes to choosing anti-diabetic drug also, we'll have to be very, very cautious while prescribing them drugs like DPP-4 and SGLT2, because metformin and glimepiride may be still to some extent safe, because sulfonylurea and metformin still have the highest evidence that these are found to be safe. So let them be minus statins.
Sorry?
Let them be minus statins and minus ACE.
Because we're not really here talking about accidental pregnancy.
Planned pregnancy.
About a lady who is happy to be pregnant at any time. She welcomes the pregnancy at any time over the next 10 to 15 years.
Then there is no role of statin, ACE inhibitor, or an ARB in such a woman.
We will have to deprive them of the benefits of statin and ARBs in the reproductive age, because this may be detrimental if they are already on statin or on ACE ARB, because then the risk of
any woman who is planning a pregnancy, I think the message has to be loud and clear. An A1C target of 6.5 if possible, as tight control as possible preconception, screening for the complications if she's already a type 1 for a longer duration, screening for retinopathy because we know there's going to be a retinopathy worsening, review of all the medications she is on, which includes statin, antihypertensives, putting her on the safer options, taking off the statin immediately, and then starting her on a folic acid. That is also another very important thing to prevent the neural tube effects.
Yes,
so I think preconception counseling is important. Dr. Inas wants to say something.
Yeah. I have a suggestion. Like we are doing activity for diabetes in Ramadan, Muhammad, we should do Diabetes in Women Day.
Absolutely.
For public awareness and also for doctor awareness.
I think Dr. Inas, you should be on an international level take a pledge the way Muhammad is carrying that banner of Dar.
I think we should work on this. Definitely,
Then
ma'am.
maybe Egypt and India, we have two ladies and we can start the issue.
Absolutely, ma'am. We should definitely take this up very intensively because I think both of us belong to ethnicities where this is a very, very common challenge.
Yes.
I think
I've been running the diabetes centinator clinic when I was in UK as well as here.
Sir.
But the difference in cultures is strong.
Yes, absolutely.
In Western society, pregnancy 99% of the time is planned. But in different cultures where the woman is very well supported financially and with support, social support at home as well, they welcome any number of children and at any time. Obviously, when diabetes interferes with this, the situation becomes a bit more complex from the medical management of how can I give the right medication to protect for the lipid management, for antihypertensives. For short term, it's okay. But for long term, it needs a bit of investigation on the benefits of prevention of these drugs versus the harm of prescribing these drugs until maybe week 6 or week 5 of pregnancy. And I don't know the scientific answer for this.
Absolutely, because, now we have data which shows that, the major morphological abnormalities that we want to actually prevent, by the time she's 6 to 8 weeks pregnant, the organogenesis has already proceeded. So I think this is exactly the time when you have to stress upon the importance of preconception control and safety of medications at this time. So I think education all the way for anybody, any young woman who's got type 1, type 2, or any of the other forms of diabetes is very, very important.
I think we'll have to stop short here only because chair for the next session are already there. So this was an
Thank you so much, ma'am. It was a great oration.
Inas, once again, we are grateful that you accepted this oration and delivered a beautiful, awesome lecture on that.
Yes,
Thank you
and I'm
very much.
sure there is a need to spread awareness on this.
Thank you. Over to
Thank you
Dr.
so much, madam.
Panikar
Thank
and
you.
Dr. Kedia to carry out the proceeding for next session. Professor Panikar and Dr. Arun Kedia.
Dr. Arun Kedia.
Thank you.
Thank you, Rajiv.
So we now have Dr. Arun Kedia, consultant physician and head of ICU Lifebirth Hospital, Raipur, and Dr. Panikar, our very, very senior, our very own senior member of RSSDI, Professor Leelavati Hospital, to do the honors.
I think I'll come straight to the topic. We have Professor Yagnik, who has done yeoman work. I won't go through all this. He's done wonderful work. And, his thesis about evolution of diabetes, right from preconception and onwards. He's done excellent work, published a lot of work, and he's going to talk about the thin fat story. In fact, the thin fat Indian is identified by Professor Yagnik. There is a nice slide which shows that Indians have more fat compared to the Caucasians, and that is again Professor Yagnik's work. Over to Professor Yagnik, the thin fat story.
Everybody, bringing compliments from the USA. I am in Michigan, attended the Obesity Week meeting and gave a keynote address on like mother, like daughter. Very much related to what we are going to discuss, which is this story of the thin fat phenotype. And as part of this presentation, I would like to reiterate that Diabetes Unit KEM Pune is the only department in the world of diabetes where mother and baby is the logo. And our new logo visualizes modern Ganesh, who instead of traveling on the back of this mouse, clicks the mice and moves fast. So whatever we are going to discuss is about intrauterine programming and rapid transition that has happened in India over the last few decades. And we have a number of collaborators from India and abroad who actually have helped us. So I always like to quote Paulo Coelho's statement in Alchemist that the world conspires to help you, or the universe conspires to help you when you want to do something. I wrote my confessions as a thin fat Indian in 2017 in European Journal of Clinical Nutrition. And it was to tell the postdocs that you can do good research even though you are not a specialist. So I'm not an epidemiologist, nutritionist, pediatrician, obstetrician, body compositionist, but you will see that all of these have contributed to our findings. And therefore I say it's really the magic, not the logic, which gives you interesting stories, though it's not the classic ideas in the science. So what is the thin fat phenotype? It's a comparative body composition of Indians with respect to Europeans. So that for a given weight or for a given BMI, Indians have lower lean mass and higher fat mass expressed as percentage, and therefore higher risk of diabetes, and I dare say other non-communicable diseases which are linked with adiposity. And it's very important to remember that it's a comparative body composition. And the story started when I was training at the BJ Medical College, Pune, and the Sassoon General Hospitals, and working as the registrar of the professor and conducting the diabetes unit between 1977 and 1981. I made some observations based on very basic measurements, which was measuring the height, measuring the weight, calculating BMI with a log table, that the textbook descriptions of what was then called adult onset or obesity-associated diabetes was actually very different in Indians. Our patients in Sassoon Hospital were all thin, lower socioeconomic class, but were type 2 diabetes patients. And then I went to Oxford to train in diabetes and was part of many studies as a collaborator, including Sigma study, which is the one version of HOMA study. And what I realized was, compared to the Englishman, though I was only 55 kg compared to my registrar 85 kg, and I had a body mass index of 20 instead of 26 in him, my glucose and insulin concentrations were higher. And that is the idea came to me that despite being thin, we are likely to have higher risk of diabetes, and it was soon confirmed in the Southall survey. And that is when the idea came to me that we need to really discuss this, why we have increased risk at a lower BMI. Came back to India, set up the Welcome Diabetes study. Dr. Shergikar was my right hand, and we constructed actually figures. This was what we constructed that time, that 2-hour glucose during an OGTT in our population was the highest in those who had the lowest BMI, but highest waist-hip ratio as a measure of central obesity. Incidentally, we were the first one to measure central obesity in Indians in 1980s. So I had added this tape to my armamentarium, and we had this skin fold calipers, which also told us that the subscapular to tricep skin fold ratio in our patients was much higher compared to the English patients, though our patients were younger, had a lower BMI, had a lower mid-arm circumference. So if you have very simple instruments, still you can make very interesting findings. So this was the beginning of the thin fat Indian, and that fatness was that time measured as a waist to hip ratio or subscapular to tricep skin fold ratio. I started measuring body fat much later when I learned about it and when I had enough grants to measure it. And very soon people picked this up, so that Mary Ann Banerjee published a report on 22 of our Asian colleagues in the Brooklyn State University of New York, SUNY New York, compared to African Americans, that for each BMI, Indians had higher body fat percent. And a very noted sort of specialist in body composition, Paul Durenberg and Mabel Yap Durenberg in Singapore, showed that Indians have higher body fat percentage and other South Asians have higher body fat percentage compared to the white Caucasians. So WHO invited a panel, expert panel. I was one of the invitees along with Dr. Reddy who's now in PHFI, and Anurag Kurpad, a very noted nutritionist from Bangalore. And what we decided was that the public health action points for BMI are different for different populations. For Southeast Asians, it was 23, and for Pacific Islanders, it was 37.5, which means that we had similar risk of diabetes at 23 compared to 37 in Pacific Islanders and 27.5 in white Caucasians. But we never said to change the definition of obesity. That would cause a lot of confusion. And for that article, I thought I had a picture which would give that message very clearly, and therefore I sort of worked on publishing this paper in the same issue of Lancet where the expert committee report was also published. And that's the famous YY paradox, Yajnik-Yurkin paradox. Yajnik and Yurkin, two principal investigators in the crisis study, which measured body composition in Indians by 5 different techniques, by just pure chance had same BMI, 22.3. Very surprising that we had same BMI. But on the DEXA, John's body fat percent was 9%, I was 21%, and that is how the YY paradox came. As you know, this is a very frequently shown picture, and I said now instead of the basics, I have used a 40,000 pound machine. So this picture was worth actually 40,000 pounds, which today would mean many millions of rupees. Everyone said it must be genetic. And we have actually a lot of now information on polygenic inheritance of obesity and adiposity. And the latest very comprehensive review by Ruth Luce in 2021 in Nature says combined these genome-wide significant loci explain 6% of the variation in BMI. That means large part of variation and so-called heritability remain unexplained. And a very interesting thing happened around between like say 1975 and 1995. 3 seminal papers which actually gave us a lead into what is the reason for that unexplained heritability. First report was in Dutch winter hunger study. So this is a period in the history of Dutch people towards the end of the Second World War, when Germans cut off the food supply so that everyone was on 600 calories per day diet for 6 months. So women who were pregnant at that time also were severely undernourished. If the women were undernourished in the 3rd trimester, their offspring at army conscription age, that's 18 years, were less obese, the red line. If the women were exposed in the first 2 trimesters, their babies were more obese. So very interesting finding that depending on the window in pregnancy, when the malnutrition happens, you can end up either more or less obese compared to the population which is not exposed to undernutrition. Around same time, studies in Pima Indian showed that exposure to overnutrition in diabetic pregnancies meant that their children were more obese as early as 5 to 9 years and certainly around pubertal and young adult age. And that was the gestational overnutrition story which Pedersen and Frenkel summarized as nutrient-mediated teratogenesis. Then came the famous David Barker's paper where he showed low birth weight is a risk factor for future diabetes. And all these things combine to actually tell me that something is happening during intrauterine life, either undernutrition or overnutrition, which both seem to drive the epidemics of obesity, adiposity, and diabetes in different populations. So thin fat phenotype actually is an example of thrifty phenotype of David Barker. It's a case of structural teratogenesis as per the Norbert-Frankel terminology. And this information was obtained a little bit later by our research in Pune birth cohorts. That is the Pune maternal nutrition study, where you know now, I am not going to go into details, time is short today. We have followed up women from before they became pregnant, during pregnancy, and then the women, their husband and the children for now 25 years. And we have extensive information on child's growth collected every 6 months for 18 years. And extensive metabolic, cardiovascular, neurocognitive information on the whole family every 6 years. And now we are completing the backlog, which was left by the COVID. And we have a very impressive biobank, which allows us to do various molecular studies in this life course data collection. And the mothers were quite thin, 18.1 kg at the beginning of pregnancy in 1993. Babies were born only 2.7 kg. I mean, today Indian average birth weight is 2.8 kg. And many of them, depending on which reference you use, was SGA, small for gestational age. These mothers were predominantly vegetarian. They ate less calories and proteins than recommended, large carbohydrate component of the diet, less micronutrient intake rich foods, substantial physical activity, a typical Indian village scenario. And we found gestational diabetes very rare at that time in that population, but micronutrient deficiency, especially B12, quite rampant, not folate. Iron was also deficient, and vitamin D borderline. And when I compared these babies born in Pune with babies born in Southampton, we had very stunning findings. I asked David Barker, what do you think? Indian baby, which is very small, will it have more fat or less fat? So he said, it's obvious they will have less fat. I knew he was going to be wrong, which he was. So we showed it very clearly when we compared the anthropometry of Indian babies with English babies and showed that though Indian babies were smaller in all the measurements, there was a hierarchy such that the fat measurements were the best preserved. So this zero line is an average English baby, and each bar is the standard deviation deficit in Indian babies. Deficit was least for subscapular skin fold, then less for triceps skin fold. And when we did what is called pair matching, equal birth weight comparison, Indian babies had smaller birth length, then they had smaller mean arm circumference, but substantially more subscapular skin fold, even larger. And they had higher leptin and insulin concentrations in the cord blood. So we knew that what we had observed in adults was present from birth, and therefore it must originate during intrauterine growth and development. So this is the thin fat Indian baby. And of course, people don't believe you when you come from Pune, India. They said, how can you measure such complex anthropometry? Who are you? You are not a nutritionist, etc. So we went to the black box of MRI. 30 babies born in Pune, 30 babies born in Imperial College London, collaboration with Nina Modi. And what we showed to our own amazement, that these small babies had larger subcutaneous compartment fat and larger visceral compartment fat compared to English babies, which is not obvious to the eye. So very amazing, striking finding, and this is what again convinced the people. Then a whole lot of papers have been published. I've just shown you here from UK, from Canada, from Suriname, from Southeast Asia, number of places that Indian babies are infant. So I'm going to ask you now an interesting question. Some of you who are as fond of Winnie the Pooh as I am will know that this is the 100-wood acre. There is Christopher Robin, there is Owl, there is Kangaroo, there is Tiger, there is Piglet, Winnie the Pooh, Rabbit, and Eeyore. And Christopher is conducting a spelling competition, and he has asked them to spell adiposity. So Eeyore has spelled it as adiposity. He thinks it's a city. So I am going to ask you a question. Of all the animals which are in this picture, which animal was the most adipose at birth? So think about it and see whether you get it right. This is something very dramatic finding in comparative body composition. If a small human baby has the highest fat content % at birth compared to all other mammals, including pig, which is just 2%, human is 15%. So there must be some importance of this fat for survival, and that I think is a very dramatic observation. Is this only an Indian phenomenon? I was getting stumped because some of my papers were coming back. They said, this is for India. What is this used for the rest of the world? So I decided to look for cohorts and found a cohort of twins and singletons in Guinea-Bissau. This is collaboration with Morten from Copenhagen, Denmark, who did a PhD on this cohort. And he had anthropometric data and glucose data. And what we showed was that twins are thinner and fatter compared to the singletons. So as you know, twins have to occupy that same space. They are smaller. They are relatively undernourished compared to singletons, and they are thinner and fatter. That to me tells that it's intrauterine nutrition rather than being Indian, which actually drives this. Indians have an extreme form. Is there any genetics? Yes, there must be genetics. Ultimately, everything is driven by genetics. So Anup Mishra's group published about myostatin gene as a determinant of body composition, which it is of course true. Then there are all other sort of studies. We did a gene risk study for birth weight in number of cohorts from India, Bangladesh, and migrant Indians and Bangladeshis in London, compared them with babies born in the UK, and we have also done FTO gene studies. And this is the paper of the GIFS consortium, where we compared birth weight in Indian Bangladeshi babies with English babies. So birth weight for each gene risk score, as you can see on the x-axis, birth weight is on the y-axis. So for each gene risk score, Indian babies have lower birth weight. In other words, they have the genetic potential which is equivalent at each gene risk score, but their phenotype is smaller. This to me tells a classic genotype-phenotype development phenomenon, and tells me that a number of environmental factors which are either missing or present in excess are interfering with achieving the genetic potential of growth in utero for the Indian babies. Very classic paper. Last year we published it. There is a historical background. Over last, like 150 years from 1830 to 1980, where data is available, Europeans put on 15 centimeters in height. Indians and Southeast Asians put either 0 or some of them had actually lost it for the time. So these are the occupied countries which face severe political, financial, nutritional deficits. They did not put on any height. And this cartoon says here, I forgot to grow in height and therefore I am fat. That's very true for the Indian and Southeast Asian populations. And Jonathan Wales and I wrote this paper about the capacity load model, where capacity is built up by the lean mass and load by the fat mass. This imbalance between the Europeans and the Indians explains the higher risk of diabetes. Barry Popkin is also one of our co-authors. Now, new things have come up in last few years, and I have to thank basically Sandeep Mathur from Jaideep. He has pursued this thin fat phenotype molecular biology like nobody else. And he has explained various, like say, genetic associations by doing transcriptome in the adipose tissue, in the central fat as well as peripheral fat. And he has now highlighted the gene sort of structures or the networks, which are associated with this phenomenon. And now recently he's talking about partial lipodystrophy related phenotype, which of course we had described first in our original paper where triceps and subscapular were differentially affected, but he is now doing more work. So there is an element of loss of fat in the legs and the arms and more fat in the center, a typical lime on the stick phenotype, which actually originally was described in Cushing's disease. And we have interesting information on that. But Sandeep has contributed quite a lot to this. New information about brown adipose tissue, which now is attracting attention all over. And to cut the story short, despite having higher waist-hip ratio, higher fat mass percent, Indians have lower brown fat compared to the Caucasian patients. Very nice study published from Holland with advanced techniques of measuring the brown adipose tissue. So the thin fat thing is now becoming more complex. And we are now into very exciting research by measuring adipocyte-derived exosomes, the small vesicles, in the mother and the baby, and trying to see whether the miRNA content of these exosomes is in any way related to the adiposity of the baby. This paper is uploaded on medRxiv just last week. And what is interesting is that mother and cord blood have differentially expressed miRNAs in adipose compared to the fat baby pregnancies. But the pathways are so remarkably similar between mother and baby that they concentrate or they target various signaling pathways in the adipose tissue, which are associated with either increased adipogenesis, adipocyte dysfunction, or other adipocyte abnormalities sort of metabolism. And this is a very exciting new field which we will follow up, and already we have additional exciting results. Finally, a few weeks ago, someone sent me this paper, and that someone is going to speak next in this meeting. That is Shashank from Mumbai, a dear friend, prolific reader, very intelligent person. And he greets me one day morning at 5:30 by sending this paper that early life vitamin B12 orchestrates lipid peroxidation to ensure reproductive success in C. elegans, which is a very useful nematode which is used in research and has won many Nobel Prizes for different people. And very interesting that even in this early evolution, B12 drives lipid peroxidation to ensure reproductive success. So that is how our B12 relation with this, which I have not discussed today, seems to be actually pervasive along the evolutionary pathways. And Arnav Mukhopadhyay from National Institute of Immunology in Delhi has published again amazing results about B12 function in C. elegans. So I think this area is picking up. We are getting into molecular biology with exosomes, then various pathways which are involved in different aspects. Finally, if you think you have made some original discovery, then I think you have to ask your wife, okay, do you think actually I am an original sort of person? And my wife actually pointed out this to me. She is a very ardent sort of follower of Vishnu Sahasranam and other things. And in Vishnu Sahasranam, Shloka 19 says, Vishnu was like Anur Bruhat. Anu is like small atom, but Bruhat like big, Vishal. And he was also Krusha Sthulo. Krusha is thin and Sthulo is fat. So I have been pipped in this by many thousand years because of this finding, and I think my wife put me in right place. Finally, I will say all this journey has not been easy. When you want to say something provocative, new, disruptive, and you are living in India, it's not very easy to publish it. So Voltaire said this a couple of hundred years ago. He said when he said something new, they said it's not true. But when they realized it is true, they said now it is no more new. So I have faced that again and again, but I was very rewarded in giving a full keynote lecture in Obesity Week just 2 days ago. And that was a great recognition from the Obesity Society. Thank you very much. I'm going to stop there. Thank you for patiently listening.
I think that was a wonderful presentation by Professor Yagmik. Let's go to the next topic. Arun, you can introduce Shashank.
So good afternoon, sir. Yeah. And it's always a privilege to
Today we are going to discuss insulin signaling and mitochondria.
The Shashank sir would be talking about the role of mitochondria and the dysfunction in diabetes and what's new, probably what's new in the sense that what we are looking forward for in the next decade with regard to the research on mitochondrial dysfunction. So over to you, Shashank sir, to start your deliberation, sir.
Today we are going to discuss insulin signaling and mitochondria, a new cellular target. We all know that the receptor signaling is the key in glucose gate opening. And there is a new class of molecules called glimins, which are likely to be launched soon, which fundamentally work through insulin signaling and mitochondria. We all know that people living in India have a very rapid early macro and microvascular complications, and they have an early progression of the disease. And therefore, there's a call for early action. We have early onset of type 2 diabetes. They are coming around 2 decades earlier, and they present often with complications. The biggest clinical challenge in management of diabetes is the impact, how the current treatment approach impacts the macrovascular disease, not the microvascular disease. And therefore, in long-term follow-up, which we have of 30 years of UKPDS, we clearly recognize that. We know that diabetes-related complications appear early. They accumulate rapidly within microvascular group in more than 2/3 despite of background metformin therapy. And that is a very well-documented thing. So why is the mitochondria becoming the focus or the heart of type 2 diabetes mellitus? We know that if you look at the beta cell dysfunction, if you look at the hepatic or the muscular glucose reuptake or the hepatic neoglucogenesis, the typical triad, what is at the focus or the heart of the matter is mitochondrial dysfunction and mitophagy. So clearly we know that type 2 diabetes is a chronic metabolic disorder with metabolic dysfunctions. There are genomic issues in mitochondrial DNA, there are DNA mutations, there are polygenic variants. We have environmental factors like intrauterine malnutrition, environmental pollutants, and obesogenic environment and obesity. All of them stun the mitochondria and cause mitochondrial dysfunction, which in turn will result in beta cell dysfunction, where there is abnormal fusion, fission, autophagy of the beta cells, apart from impaired insulin secretion. But more importantly, mitochondria halts and makes the insulin signaling inappropriate. And that is the core defect of insulin resistance, where there is a downregulation of mitochondrial DNA, downregulation of oxidative phosphorylations, and upregulation of the bad products, end products like DAGs, the ceramides, the LCACs, and ultimately the end result is type 2 diabetes mellitus. So in the metabolic dysfunction triad of beta cell dysfunction, hepatic lipo and gluconeogenesis, and insulin resistance, clearly we see that mitochondria is at the heart of the matter. Because we know that mitochondria catalyzes an energy gradient across the respiratory transport chain, complex 1, 2, 3, 4, and 5, which mediate insulin secretion and mediate insulin sensitivity. So if you see the complex 5 here illustrated in this diagram, you can see the beta cell secretion and insulin secretion and smooth muscle insulin sensitivity. Fundamentally, there is inflexibility. So what is mitochondrial inflexibility? It is a dysregulated energy substrate metabolism of the mitochondria. Healthy mitochondria allows efficient functioning of the liver and the skeletal muscle, the pancreas, and the cardiac tissues. And there is an alternative switching between glucose substrates or pyruvate. This alternative metabolic fuels is lost when we accumulate a lot of ectopic fat and become obese, or we eat too much of carbohydrates. And eventually, when there is diabetes, obesity, or type 2 diabetes, this ability of mitochondria to switch the metabolic fuels is lost. That is the crux of the matter. That is the heart of the matter. And that is called as mitochondrial induced metabolic inflexibility. So obviously, when you have a fast state or a fed state, there is a ability of the substrate like free fatty acid or glucose to switch oxidation and acetyl-CoA. And that acetyl-CoA creates an energy gradient with NADH, which is responsible for cellular energetics, which mediate insulin sensitivity and insulin secretion with an increased ATP-ADP ratio. But what happens in type 2 diabetes or adiposopathy or adiposity-based chronic metabolism and DBCD is the glucose substrates are downregulated. There is excess glycolysis and gluconeogenesis. There is a diarrhea of free fatty acids. And all that allows the fuel substrates to go in excess to cause an oxidative environment of stress that will upregulate acetyl-CoA and reactive oxygen species, which will lead to acetylation, and the signaling at cellular energetic level is impaired because of downregulation of ATP to ADP ratio, and both insulin secretion and insulin sensitivity is impaired. So therefore, now why are we talking about this? We are talking about this because we have a molecule which is similar to metformin. You can see the metformin structure here, which has a dimethyl group, the fenformin structure, which has a phenyl group. And now we have a trizene compound which has a bigunite substructure similarity with metformin. A trizene compound with bigunite substructures with similarity of metformin is imigliptin. And this imigliptin possesses 2 carbon atoms with cyclopentane ring. This imigliptin possesses 2 carbon atoms with cyclopentane rings, and structural similarities and differences suggest that there are complementary effects of mitochondrial respiratory chain as well as C1 and C3 with improved cellular energetics. So clearly we recognize that. So remember, imigliptin is a first-in-class molecule. It has been terminologically named by WHO as an indication for type 2 diabetes management. It is a very well-researched molecule in Japan and China, approved in Japan in 2007, approved in China in 2021. It fundamentally works through 3 pathways: impaired glucose uptake by muscle tissue, excessive hepatic gluconeogenesis, increased beta cell apoptosis. And therefore, in various clinical trial programs like ×1, ×2, ×3 in type 2 diabetes mellitus, both naive and uncontrolled, you can do that. So where does imigliptin work? It fundamentally works through NAMPT, NAM and NAT. So basically the nicotinamide is moved to nicotine and NAD, which is a salvage pathway in insulin signaling pathway. Also, it works on the ATP to ADP ratio and the amplification pathways inside the insulin signaling apparatus. Thereby, the CD38 will get into a pathway where the lysosomal and calcium upregulation will make the beta cells more efficient to secrete insulin, as well as it will open up close the potassium channel and cause membrane depolarization. So imigliptin modulates the mitochondrial chain complexes C1 and C3. They improve insulin secretion and sensitivity in the pancreas and smooth muscle at the C1, the C2, the C3 pathway. Clearly, we know that at each level, at number 1 ATP to ADP ratio, number 2 the NAD, number 3 the potassium ATP channel, number 4 the calcium flux, and number 5 the insulin release. The NAD synthesis complements C3 activation for calcium flux mediated insulin release. So the NAD metabolism is now the new target for cardiovascular death associated with sudden cardiac death. We are seeing suddenly a spurt of cases where people are just dropping dead. And we know and we recognize that NAD synthesis and metabolism re-energize the cardiac mitochondrial respiratory chain complexes 1 to 5, demonstrating moderate clinical effectivity on mortality reduction in coronary artery disease cases. So clearly, imigliptin amplifies cellular energy pathways in insulin sensitivity by upregulating the insulin-resistant-like substrate activity or the ATP to ADP ratio. They downstream signal the PA13 kinase and AKT with improvement of nitric oxide. They correct the endothelial dysfunction, improve cellular energetics and blood force sensitivity, and glucose transport and insulin sensitivity. So clearly you can see imigliptin is a mitochondrial re-energizer. It downregulates the C1 and reduces reactive oxygen species and oxidative environment. It can clearly cause the modulation of cardiac energetics and re-establishes the equilibrium of NAD by improving the insulin secretion. And it upregulates the C3 RTC, where the insulin sensitivity and secretion has been improved. So whether it is the mitochondrial bioenergetics, whether it is the liver fat oxidation upregulation and downregulation of hepatic glucose production, whether it is the modification of making physiological secretion of insulin from the beta cells, or whether it is a glucose uptake by the muscle, at each step, imigliptin has a cellular energetic mechanism. And when you compare it with other agents, it drops the A1C by around 1% through this unique mitochondrial pathway. And clearly, head-to-head with metformin versus sulfonylureas, imigliptin impacts the electron chain pathway, the NAD salvage pathway, the potassium ATP channel closure which sulfonylureas do. It causes insulin secretion by improving the beta cell dysfunction. It inhibits hepatic gluconeogenesis and improves insulin sensitivity. So it actually is a perfect mixture of metformin sulfonylurea with complementary actions of both and more. Times 1, times 2, times 3 are trials as add-on which have been done for its approval way back, almost 4 years back, which have been published in journals like Diabetes Care, where clearly it has shown that it's a perfect add-on to metformin when added and can cause a very unique ratio. It's also been studied for safety and efficacy as an add-on therapy of people not controlled well with sitagliptin monotherapy. And here you can again see that with imigliptin, clearly there is a very good documented data published in good credible journals that it has a very low treatment adverse effects and it's quite safe. So whether it is times 1, whether it is times 2, whether it's times 3, 1000 milligram of imigliptin twice a day has been having the trials done in Japan. And it has met all the endpoints in a double-blind randomized controlled fashion, which has been anticipated and expected. Clearly, they also improve the proinsulin to insulin ratio, the proinsulin to C-peptide ratio, and they also upregulate the various insulin resistance markers like HOMA-IR, HOMA-beta, and QT1. Clearly, this novel gliptin oral antidiabetics has very good efficacy and safety profile in type 2 diabetic patients. And when you see the long-term studies also, the intensity of GI adverse events are virtually negligible compared to metformin. And it has a year data also, where it has shown that the A1C can drop up to almost a 1% as add-on therapy and has been consistent in double-blind randomized control studies over a period of time. And the Japanese data also shows versus insulin also, it can be very well combined and a significant drop of both lipids and fasting blood glucose can be seen. Also, it is insulin sparing. The times 3 RCT from Japan showed that a decrease of insulin dose can occur with imigliptin treated patients. And when you look at the glycemic profile with CGM, and this paper has been published just this year, if you add this imigliptin, the time in range will improve from 65% to almost 80%. And that's a substantial improvement. And you can see that the various CGM parameters like time in range, time above range, time below range are favorably affected by imigliptin. Also, the systematic review and meta-analysis of all the RCTs from Prisma identifiers in a very methodical way has been done of hemoglobin. And clearly you can see that it addresses A1C and fasting, both in treatment naive and uncontrolled cases, addresses A1C and fasting, both in treatment naive and uncontrolled cases, and has an extraordinary safety profile, apart from maybe hypoglycemia, headaches, upper abdominal pain, vomiting, and diarrhea. It's a first-in-class agent. It's a dual-acting oral anti-diabetic agent. It has a novel mechanism of acting on insulin sensitivity and secretion, modulates cellular respiration or oxidative phosphorylation at mitochondrial complexes C1 and C3, improves insulin secretion and sensitivity in pancreas and smooth muscle, amplifies NAD salvage, and has a very strong insulotropic action, 24/7, documented by CGM, and reduces the harmful pro-insulin to insulin ratio, improves beta cell function, protects from beta cell apoptosis, modulates blood glucose effects by improving beta cell function, liver gluconeogenesis, and muscle. 8 RCTs have been done over a large population in treatment naive and uncontrolled populations, where it has been documented to be safe, well tolerated, and will be a perfect add-on to the currently available agents. Thank you very much for a patient hearing.
That was a good talk on hemoglobin by Shashank. Let's go to the next topic. The next speaker is Dr. Krishna Sheshadri. He is American board certified endocrinology, diabetes, metabolism, internal medicine. He is consultant at the Chennai Diabetes and Endocrine Clinic. He is the professor of endocrinology, medical education board, Sri Balaji Vidyapeeth and MGM Health. He is a recipient of the P.N. Shah Oration of the Endocrine Society and Sam G.P. Mozo Oration of RSSDI, Sindhu Pandit Oration in Medical Education. Associate Editor of Journal of Diabetes in Developing Countries, Editor-in-Chief, Thyroid Research in Practice, Editorial Board of Indian Journal of Endocrinology and Metabolism, member of the Curriculum Expert Group, National Medical Council. Take interest in clinical decision support device, EMR, connecting machine learning. Krishna is a prolific speaker, very knowledgeable, and a good person. Krishna, over to you.
Sir, you are muted.
Yes, Krishna, you are muted.
Thank you, Dr. Panikkar. Thanks for those kind words. Thank you, Dr. Rajiv Chawla and Shalini. It's
You again got muted, sir. You muted. Dr. Krishna, you're muted.
okay. So did you hear any of what I said? Okay.
No.
Okay, so let me do this. Okay. Dr. Panikkar, thank you so much for the introduction. Dr. Chawla and Shalini, thank you for having me here. It's indeed a pleasure to be with all of you. And let me start this talk, a little bit of hypothesis, some amount of science, a large amount of interest, I think, in this particular topic. No conflicts of interest for me in this. Shalini, I'm audible, right?
Yes, you are, sir. You are.
Thank you. So I'm going to talk a little about human evolution, a little about sleep and light. Shashank already introduced you to this topic of metabolic switches, and finally, very brief clinical correlates. Very interestingly, let me start actually about human evolution, and the important thing to remember is that over 5 million years of evolution, you will realize that what we have is a conserved set of genes that have been constant throughout history of human evolution. These are about 5 or 6 genes that are called the clock genes. And these set up our rhythms, and we have found a way of coordinating these rhythms with nature. And the gist of my talk is to say that when you have moved away from this relationship or created desynchrony with nature, you have set yourself up for a disease. Just to give you an example, cardiovascular acute myocardial infarction or asthmatic attacks or pulmonary edema, they all peak at certain times of the day. So clearly, if we choose to ignore what nature is telling us, we ignore our own relationship with it. It's also important to understand our own evolution. We humans have the highest amount of fat. Why is that we have a highest amount of fat? Because we chose two modes of having evolutionary advantage. One is that we have smaller number of progeny. From proficiency in reproduction, we thought we will have efficiency in reproduction. That is why we have less number of children. That is why we have puberty, and that is why we have a matriarchal behavior which only elephants have, and that is why our kids grow up to be smarter than us. The second is we have chosen to have a larger brain. And the larger brain requires, like the fetus, a large amount of glucose. It's a very, very important obligatory glucose consumer. There are some alternate fuels that we have now learned that the brain has, and it can even create pathways for taking alternate.
Excuse me, I think your slides are not moving, Krishna.
I'm in the same slide.
Okay.
And that's the reason. Because we need glucose, we need fat. Why? During times of stress, the brain continues to consume glucose, and the other organs need other fuels for it to survive. And that's really why we have fat. And why we have insulin resistance is actually to allow the brain to take glucose when the others use fat. So when there is inflammation, when there is infection, what happens is that the brain continues to take glucose, insulin resistance occurs in other organs, and therefore diverts the glucose to the brain. Therefore, initially, inflammation is a protective phenomenon, and it got linked with insulin resistance, and together they were the first line of response to any external or internal threat. But we started threatening our bodies too much simply because the last 100 years we started playing with nature. We eat more food, more frequent food. Our quality of food has changed. We eat more processed food. We have more light, less sleep, disturbed sleep, and a change in our circadian rhythms. We have less physical work. We have more sedentary time, more screen time, greater amount of stress, no downtime, and of course, less sunlight, more indoor time, and controlled temperatures. So what has happened is we are constantly in an inflammatory state. Instead of what was a mechanism for infection starvation, what has become is that there is a constant state of inflammation, and this inflammation is creating insulin resistance. Very interestingly, what the body does is any amount of extra nourishment, it stores for a rainy day. Given an example of this is, I don't know how many of you remember, but there are such redundant SGLT2 mechanisms in the kidney that allows not a drop of glucose to come in the urine, right? Similarly, the body stores as much fat as it can. And that's why women who are more important than men from an evolutionary perspective have greater difficulty in losing weight. So if you look at this, one of the things that we know is that the insulin resistance is a key factor in MCP1 transcription. And just like inflammation produces insulin resistance, the earliest thing that happens in a fat cell is that obesity bypasses the mTOR pathway that keeps the insulin resistance in check. The moment the insulin resistance is present, or if there is oxidative species by the JNK pathway, there is transcription of MCP1, not the male chauvinist that you know of, but monocyte chemoattractant protein 1. Sends a message to the macrophages in the bone and they come into the abdomen. And this beautiful slide by Suganami et al. Tells you what happens then. These T cells that come into the abdomen, they come as helper cells, but there's a phenotypic shift that occurs in the abdomen. These become killer cells, and along with the fat cells, which are undergoing apoptosis, producing adipokines, and they start producing cytokines. At some point of time, the fat cell, which is supposed to protect the body from the effects of fat, undergoes lipolysis. The fat becomes ectopic, and overall inflammation and fat infiltration, including the pancreas, occurs. There's a slide from Mark Donat from 2008, which I still use in my slides, showing the first instance of human islet cell inflammation. Later, and I've spoken this in many places, what happens is when islet cell inflammation occurs, the islet decides that the beta cell, which is a very high energy maintenance cell with humongous amount of mitochondria, decides that if I continue to churn out insulin, it's quite possible that I may be marked for destruction. So it changes its behavior, and from an insulin producing cell, it starts producing no insulin, or it becomes a glucagon producing cell or a ghrelin producing cell and loses its identity. More of that in another talk, but let's move on to what we are doing. There are two things that we've interfered the most. One is the eating, wake, sleeping, not eating cycle. Meaning, for most animals, activity is linked to food, and inactivity is linked to catabolism, to detoxification, and autophagy. This is a very old cycle. It is preserved and is probably the fundamental nature of any cell. So when we disturb the fundamental nature of cells, they respond with inflammation. So just to tell you how important sleep is, I'm quoting Charaka, Nidhradyatham sukham dukkham, prishtikarsham bhalavalam, vrishata klabita jnanam, ajnanam jivitam nacha, which means good sleep. I always say sleep is underrated and sex is overrated. So happiness, misery, nourishment, emaciation, strength, weakness, virility, sterility, knowledge, ignorance, life and death, all of these occur depending on the proper or improper sleep. Right? And this is the Rigveda, the Ratri Suktam, that's saying, Sano adhyayasya vayam yavannad vikshamahi vrikshena vasatim vayaha, which means that sleep is like a tree that provides its branches for the birds to rest. And that rest is very important. It's not just a sleep, it is the lack of light. We didn't know why sleep was necessary for many years. Until 2013, this beautiful experiment that was done by a very dedicated PhD scholar who was able to get a rat under a confocal microscope to sleep. You know how difficult that is. What she and others demonstrated in this beautiful publication was that when you sleep, the brain shrinks, the parenchyma shrinks, reducing the interstitial space by about a third. Almost a 60% decrease in the interstitial space occurs. Therefore, what happens is, during sleep, these endolimbs open up, these channels open up, and the toxins get removed. That's the purpose of sleep. It's a detoxification process. As is darkness. This is the Aruna Prashanam from the Taittiriya Aranyakam. And you will see what it says. Sarvasvad bhuvananadi tasyaha paka visheshanaha smritam kala visheshanam. When I first read it, I thought, what are these guys talking about? The heat of the rays of the sun isn't just the light that entrains us. But what we now know is that the suprachiasmatic nucleus is not just entrained by light, but actually by heat, by temperature changes also. So these guys got it right. The time is understood through the changes brought about by the heat and the rays of the sun. Indeed, in diabetes, one of the first things that occurs, and Ken Polanski showed this way back in 1988, is a loss of rhythmicity that occurs in diabetes. There are rhythms in every single cell, and the loss of rhythmicity is the earliest that you see in diabetes. There's circadian misalignment. Once, let's say, you're traveling on across time intervals, the first thing that changes is to our postprandial glucose and insulin. When you restrict sleep and do a look at the human transcriptome, you will find out that many of the cells, many of the transcriptomes that are increased have to do either with cell cycle regulation or with inflammation. I particularly love this particular trial by Kian et al. Since it actually encouraged me to do my own work. And what they showed was in rats, just reversing the cycle from LD to DL, which is light day, darkness to darkness light, caused a reversal in the insulin secretion, but also in a rat prone to diabetes, it caused beta cell dysfunction. Our own work showing the relationship between the quality of sleep and A1C elevation. In fact, I remember reading a study from the VADT, from the Veterans Affairs, showing that even using hypnotic, allowing people to sleep, improved their A1Cs. We did another trial, and this is funded by our own organization, PAMS, and we are looking at a further funding from the RSSDI for a different kind of trial. What we did was we put a bunch of rats through a reversal cycle, but also had a prolonged photo period like nurses do, an additional 8-hour on alternate days for some of these rats. Very interesting. You will notice that the glucose is higher in those that have an extended photo period. An increased amount of triglycerides, increased amount of change in the cholesterol. But what was interesting is this, and I want to show this to you, and this was presented in the ADA in 2020. It's still undergoing multiple revisions with the current publication. But let's look at this. This is at the end of 3 weeks. This is a beta cell. This is the pancreatic beta cell mass in somebody who's got a normal circadian period. Remember, rats are night feeders. When you reverse the light period, you see what happens with obesity. You see that the pancreatic beta cell mass is expanded. There's a greater mass, as if it's a reactive phenomenon that's occurring. But what bothered us was this, that if in every other day you had an additional 8 hours of light, the pancreatic cell mass was actually starting to degenerate with enzymatic degradation seen. We didn't see much in terms of PER and other molecular biology clock genes, but that we will also do in our subsequent study. That brings us to this particular important part, which is the energy sleep cycle, that this is hardwired. Remember, glucose is the fundamental output of photosynthesis. Therefore, in plants, fungi, cyanobacteria, this dark light cycle is very important, that during light, energy is available, there's anabolism, and there's restoration in the dark. Similarly, in metazoa and all the others, there's a relationship between feeding, eating, and sleep. Feeding is anabolic time, sleep is restoration time. And remember that there have been others who have looked at, for example, the moon. Lunar cycles are important in feeding too. Menstrual cycles coordinate very well with the lunar cycle. But to go back, we have central molecular clocks that are present in the SCN, which is a suprachiasmatic nucleus. The predominant input is the rods of the eye, but there are others like food that entrain it, and these in turn entrain the peripheral clocks which are present in every single cell. Cues such as food, behavior, all the others train the clock. So if you change your food habit, you change the way you eat, you're eating late, you're resetting the SCN clock and affecting multiple rhythms. And each of these have effects in the peripheral clocks. Importantly, this behavior changes as Shashank was talking to you about the mitochondria. This is exactly what is happening in the mitochondria as a part of diabetes. There is a partitioning of fuels that is there in the mitochondria. Glucose propagates its own metabolism, right? And lipid oxidation also propagates its own metabolism. Glucose enters the tricyclic acid cycle at the pyruvate, and while there is a small amount of ROS production, there is a smooth flow of the hydrogen ion chain, and by 4, there's a small leak that allows other things to happen. The lipids enter at the peroxidase pathway. They undergo peroxidation and they enter the acetoacetate, which is a little less efficient of a fuel. But what is important to understand is glucose inhibits insulin and therefore inhibits fatty acids. On the other hand, fatty acids inhibit pyruvate dehydrogenate kinase that prevents glucose from entering the pyruvate cycle. It takes about 14 hours for the glycogen stores in the body to reach an amount of depletion and switch to a fatty acid cycle. But what happens when glucose is abundant and is present all the time, and fatty acids are also active, is that they don't know what, which means the body doesn't switch from glucose oxidation to fatty acid oxidation. This is called metabolic flexibility, and in diabetes, this is one of the first things to be lost. And when this happens, the effectiveness of the respiratory chain is reduced. There is a greater amount of respiratory uncoupling, greater amount of UCP2 that is present, therefore greater amount of ROS that is produced. This is one of the reasons why there is progression of damage in diabetes. So the metabolic inflexibility, what does it do? It is mediated, and you will see these genes, these are called the MODI genes, you will see the HNF4, HNF1. These try to prevent fatty acid oxidation and allow only glucose to be present. This is mediated by my favorite protein, which is FOXO. FOXO is a beacon that goes into the nucleus and tries to recruit these genes and promote glucose oxidation. But at some point of time, FOXO also goes away. And what happens is that there is simultaneous glucose and fatty acid oxidation. And that happens, the partitioning of fuel, as we talk about, goes away. What does that mean? Besides the other implications, one of the things that we know is that when glucose is absent, right, what really happens is there is some amount of cellular protection that occurs that activates both the RIM15 and the SIRT1 pathway and confirming longevity. When you keep eating all the time, that goes away. While we don't know, and fasting has been shown to improve longevity in almost all species except humans. And that includes some primates also. So should we fast? At least we should not eat so much. I think a hypocaloric diet is very good. Should there be time-restricted eating? Possibly. Our ancients had time-restricted eating. Remember, they had only 2 meals. Right? Even the mantras that you use to offer God, there are only 2 mantras available, one for the morning and the evening. But clearly, food was considered as a means to live, and not as entertainment that we think about it. Forget alcohol as an entertainment. I think we glorify alcohol so much. But food and foodies glorify everything. So does time-restricted eating help us? So in mice, lower cholesterol, lower fasting glucose, lower weight, lower body fat, lower inflammation, lower dysbiosis. And clearly increase energy expenditure, endurance, sleep, cardiac function. The human studies are very contrasting and with different outcomes, simply because the methodology is questionable. But it does reduce weight in the short term. But if you look at it carefully, you won't see lots of benefits, simply because anyone who reads those trials can see that the methodology is faulty. We really need good studies, and also studies that are more in tune with the diet here to see if these make a distinction. But the sort of, as I said, a lot of hypothesis, a little bit of evidence, some amount of animal work. But this is my message to you as I close. One is, I think there's nothing wrong in respecting ancient cycles. I always believe that our ancients were not fools. It's just that we think that that they were, simply because we only respect the Xerox god. Second, there may be a role for time-restricted eating and intermittent fasting. Certainly, there's a role for exercise that helps us to bring the glucose to take care of this. Alternate fuels like ketones have a role. For example, this is an anecdote that Sundar Mudaliar told me that Oxford has actually patented a ketone drink, and for the first time it was used in Tour de France, and the team had an advantage. Interestingly, medium chain fatty acids, especially C8 to 13, the one that all the international oil companies like to debunk and Western literature likes to debunk, is coconut oil actually improves mitochondrial function. I think what Shashank talked today is the first of many mitochondrial modulators that will make it to the market. But till then, here is this full thing. So Langanam, Param Aushadam is what ancient wisdom said. So with that, let me stop. Thank you for allowing me to speak on this, which is an area that is evolving and has caught my interest for many, many years now. And I'm happy to share this information with you. Thank you, and I hope useful for all of you. Thank you.
Good talk, Krishna.
Thank you, sir.
Yeah. So thank you, sir. So I wish we could give you a standing ovation for this talk. It was marvelous, fabulous, very interesting. Reminded me of the childhood days. Early to bed, early to rise makes a man healthy, wealthy, and wise. So you have actually proven it through science. Wonderful, sir.
Krishna, every time we hear you, we find that we know nothing. We have to go back to basics to learn from you. I heard you in Ahmedabad, and I remember even there also we realize the same thing. And every time you keep hearing you again and again, you realize that you have no basics at all. We don't have any basics at all. And we need to have physiology classes from you. It was a great oration from you.
Yeah, hearing Krishna, we all get confused as to what are we doing.
What are we good for?
Sir, my room is already very cold.
I think wonderful.
Thank you. I think, see, I feel that, one, that at least for youngsters who are part of this, that the future, tomorrow's medicine is today's basic science and translational science. Second, I think we dismiss a body of science that does exist in ancient cultures. What we really need is not to take it blindly, but to take it and start putting the science. If it's okay, I'll give you a small example. A few years ago, so I've always been fascinated. I don't know the history of toothpaste. For example, in Western toothpaste, like Unilever's, triclosan was used for many years. It is a carcinogen. Today, Colgate has come out with Ved Shakti and others because they realize the value of traditional. We did a study in 2014 that is published in DRCP. What we did was everyone talks about neem sticks, and there are 6 kinds of sticks that were used in Ayurveda for teeth. I was doing a lot of work on gut microbiota. Then we were the first to publish on Indian diabetes and what happens to gut microbiota. So what we did was we did oral microbiota, and then as an add-on, so we did RT-PCRs and expressed this thing. And what we did was we also measured oral MCP1s. We found that the diabetic people with oral MCP had very altered microbiota, and oral MCP1s were very high. So we got toothsticks made from neem, and then gave it to patients and said, and had an enamel protection added to it. And then we had them use it for 3 months. And this article is published in DRCP, you can look at it. At the end of 3 months, there was a change in the oral streptococcal microaerophilus to a more benign looking one. And also the MCP1 levels were almost zero, right? So clearly there is so the way I look at it is, before cardiac coherence breathing becomes a Western concept, we should start publishing data on whether these are good or bad. So be a scientist, but don't ignore it.
Thank you.
Absolutely. I think that was a great message, sir. The ancient text, the ancient wisdom needs to be respected, restricted eating. So these were something which were part of our culture and heritage. And we're actually going back. It's only that the West has shown us the way that this is important. Once the West approves, I think we start aping. We're not realizing that this is what our culture and our heritage always talked about. So thank you so much, sir. It was great hearing you. And closing words from Dr. Panikar, sir, before we move on.
Wonderful session. All three speakers were good. And Krishna took the cake. And I think good job by Rajiv and Shalini. Excellent. Thank you for having me here.
Excellent.
Pleasure and honor, sir. Thank you so much. So thank you, our chairpersons, Dr. Panikar and Dr. Arun. Thank you, Dr. Krishna, Dr. Shashank, and Dr. Yajnik, sir, for those excellent deliberations. I'm sure we've had a great time. So now it's time for our keynote lecture, and we have none other than Professor Devjit Tripathi for this keynote lecture, and I'll request my co-chair and my co-host, Dr. Chawla, to introduce Dr. Devjit Tripathi.
You may introduce. I'll come. I'm another hall. Dr. Shalini, you may introduce him.
Okay. So Professor Tripathi is a very well-known name in these circles, and we've all heard him and seen him. He's an endocrinologist presently practicing in San Antonio, Texas. He's the professor of medicine in University of Texas Health at San Antonio and has been in practice for almost more than 2 decades. He's a staff physician at ALM VA Hospital, San Antonio, and his research focuses on pathogenesis of diabetes and mechanisms of action of novel medications for treatment of diabetes. Welcome, sir. Honored to have you. And he's going to again shed light on something which is very, very novel and new, the emerging role of twin cretins in the management of diabetes and obesity. Welcome, sir.
Hi, thank you. Can you guys hear me?
Yes, we can.
Okay, so thanks again, Dr. Chawla and Dr. Jackie for the invitation. And before I heard the excellent session just before me, and I completely agree with Dr. Seshadri that we need to go back to basics to understand really physiology of medicine. And so today I'm going to talk about twin cretins, which is a very exciting new class of medications which will be frequently used for treatment of type 2 diabetes. Again, we know this drug works, but we don't know exactly how it works. So I gave the talk on incretins before last year, so I tried to focus more on mechanism of action, how this class of drugs work. Okay, so let me share my screen. Yeah, okay. Okay, I'm having some problem. Okay, so I usually start with a case. So this is a patient we had seen in my own clinic. So he's like a 53 middle-aged man who has a long-standing history of type 2 diabetes. He's on high dose of insulin, total about 120 units per day. He's also on empagliflozin and metformin. And he has a history of heart disease and hypertension, hyperlipidemia. He had multiple stents, and he wants to achieve better glycemic control, but he's concerned that he's gaining too much weight. So these are his labs. A1C was 8%. He has CKD. And so what are the treatment options? So what can we do for him so that he achieves better control without gaining weight? So one option is to increase insulin, but again, you will gain weight. DPP-4 inhibitors, these are very modest effect on glycemic control, lowers A1C by 0.3 to 0.4%. And pioglitazone, he has heart disease and questionable history of heart failure, so may not be a good idea. So GLP-1 agonist will definitely be a better choice for him. So he participated in a clinical trial in which he was started on a GLP-1 agonist. About a year later, when I follow him every 3 months, his A1C has gone down from 8.1% to 5.9%, and is no longer on insulin, and he has lost about 50 pounds, so about 20 kilograms. His GFR is stable. What do you think? Which GLP-1 agonist was A1C or weight in any other class of medication, which lost about normalized A1C and no longer insulin, and lost about 50 pounds? So these are the guidelines. Basically, patient with pre-existing heart disease, those with atherosclerotic heart disease, GLP-1 agonist is preferred. Those with heart failure, SGLT2 inhibitor is preferred. So even in US, this is data based on an analysis of insurance claim-based data from 2018 to 19, although now it will be different. Which analyzed the data on patients with type 2 diabetes and heart disease, how many of them are getting guideline-based recommended treatment. And it was surprising to see that even in a country like US, about 38% were not on any guideline-based therapy like statin, ACE inhibitor, ARB, and SGLT2 or GLP-1 agonist. Only 40% were on one evidence-based therapy, and only 20% were on two evidence-based therapy. So even though we create these guidelines in the real world, we do not follow through, and not every patient is, ideally, everybody should be on a guideline-based treatment regimen, but they do not. It does not happen in the real world. So we all know the physiology of GLP-1 agonists. I think I should skip. They all increase insulin secretion in a glucose-dependent manner, and they work on satiety. They increase satiety and reduce A1C by 1 to 1.5%. However, this new class of GLP-1 agonists actually decrease it more than by 2%. And they lead to significant weight loss. And several GLP-1 agonists have shown additional cardiovascular renal outcome improvement benefits in cardiovascular renal outcomes too. So, but the potential limit is, we know that GLP-1 agonists work, but there's significant GI side effect like nausea and vomiting, which limit the therapeutic potential. If you can increase the dose and give them higher or more sustained effect of GLP-1, we'll see a better effect on glycemic control as well as weight loss. So one strategy is to combine or use the GLP-1 as a foundation, and on top of that, you add another compound which has target other pathways like on adipocytes, like you just heard about Dr. Seshadri about adipocyte inflammation. So if you combine this with another drug which works on the adipocyte or improves adipocyte sensitivity or decreases adipocyte inflammation, that will helpful or increase the therapeutic, and also increase the efficacy of this class of medications. So that's the goal, to combine GLP-1 receptor with another class of agent which works on lipid metabolism and may also affect in improving weight loss and insulin sensitivity. So one obvious choice is GIP, but GIP was kind of like a stepchild. Not many people work on GIP because we know that GIP is secreted from K cells and in response to mostly fat in the meal, fat and carbohydrates. And in healthy subjects, GLP also, GIP like GLP causes glucose-dependent insulin secretion, but it is GIP, the endogenous GIP actually accounts for about 70% of the endogenous incretins. So it was the first incretin which was discovered. And GIP receptors are also present in adipose tissue, unlike GLP-1, which is not, there are no GLP-1 receptors in the adipose tissue. And the other difference is effect on glucagon. I'll come to it in a bit. Just to give an historical perspective, as I told, GIP was the first incretin discovered in 1970s. And then in 1980s, it was shown that when you infuse GIP to type 2 diabetics, it did not do anything. There was no effect on glycemic control. That's why everybody almost kind of gave up on working on GIP agonist. And then subsequently, DP4 was discovered in 1990s. In 2000, it was shown that if you infuse GIP along with GLP-1 in animal models, it improves glycemic control. Then 2010s onwards, it was shown that combined GLP-1 GIP led to weight loss, and there was improvement in glycemic control, combined GLP GIP in type 2 diabetic patients. Now, why there was no GIP agonist study in the past? Because it was shown that GIP levels are normal in type 2 diabetes. In fact, in obesity, it can be high. So there is basically resistance to GIP, unlike GLP-1. GLP levels may be low or slightly normal, maybe normal in type 2 diabetes, but if you infuse GLP-1, it causes insulin secretion and lowers glucose level. However, if you infuse GIP, you do not see such an effect. And so there is a theory that probably GIP resistance is due to the glucotoxicity. If somehow you can ameliorate the glucotoxicity by intensive treatment with insulin, you can restore the sensitivity to GIP. And in animal models, the data, earlier studies were contradictory. It's not sure whether one should target for GIP agonist or GIP antagonist, because the data in either way, that's showing GIP agonist is good or GIP antagonist is also good. So therefore, there's GIP receptor agonists were not being pursued earlier till a few years back. Our recent studies showed that overexpression of GIP led to weight loss and improved glycemic control. And if you delete the somehow which is deletion GIP receptor, led to type 2 diabetes phenotype, and combined GLP GIP infusion seem effective. But in real world, it's not practical to give 2 separate injections of GIP and GLP-1. So therefore, the goal was to develop a molecule which has both GLP and GIP together, and see if it is effective, can be used for type 2 diabetes. And it showed to compare and contrast the effect of GLP and GIP. They both work on central nervous system, both increase satiety, cause weight loss, and decrease caloric intake. And the main difference that GLP-1 agonist GLP causes increased nausea, whereas GIP actually attenuates the GLP-1 induced nausea. So if you combine GLP and GIP, you'll see that you can increase the dose of GLP-1 without significant GI side effects. The other main difference is glucagon, right? GLP-1 inhibits glucagon secretion, particularly in hyperglycemic and euglycemic condition, whereas GIP actually increases glucagon concentration, particularly in hypoglycemic. Even some studies shown even in hyperglycemic condition, GIP may increase glucose. Other major difference between GLP and GIP is that there is no GLP-1 receptor in adipose tissue. GLP-1 does not have any effect on adipose tissue directly. It does not have insulin sensitivity directly, whereas GIP was initially discovered as major effect on adipose tissue. It increases storage of dietary lipids in the adipose tissue or expansion of healthy adipose tissue. It resembles that with thiazolidine or a PPR gamma agonist. Increases adipose tissue insulin sensitivity, glucose uptake, and improves lipid buffering capacity. So that's a major difference between GLP and GIP. So what are the new therapeutic approach for treating metabolic diseases? So we know that there's redundancy on physiology in normal healthy human beings for control of, like, for example, for satiety. There are several hormones which regulate satiety. So if you try to block one particular pathway, there's compensatory increase in other pathways, so that effect is negated. So goal is to try to approach with multiple targets at the same time. And we can use multiple hormones at the same time, which is not practical, or you can try single molecule, which acts on several receptors. The benefits of this hybrid molecules, which is like GLP, GIP, or GLP and glucagon, is that they offer key metabolic benefits of each constituent hormone, like, for example, GLP and GIP. While offsetting negative side effects, you can design the molecule in such a way that you offset the side effects of each individual separately. The other advantage, they have single pharmacokinetic profile. It's not like a poly pill, you combine 3 different medications in one pill, but this will have a single pharmacokinetic profile. And they have the potential of multiple targets and multiple effects of single target organ. To show in schematic different examples, like one is GLP and glucagon co-agonist, they can combine both, act on both GLP and GIP glucagon receptor. The GIP and GLP-1 agonist, that's the tirzepatide, and GLP, GIP, and glucagon agonist. So you can combine all three and see a synergistic effect on body weight, glycemic control, and body weight and glycemic control. So now the structure, the GLP-1 and glucagon and oxyntomodulin, these are 3 derived from the same pre-pro-glucagon. So there's significant structural similarity between these 3 compounds, whereas GIP is totally different. This is 30 amino acids, this is 42 amino acids. This is the first polyagonist, not twin kitten, this polyagonist, GLP-1 glucagon, the first one to be described. And this is the GLP and GIP, and this is the first twin protein discovered by Matthias Schaub's group in 2013. And there's I'll show the data soon. And this is the pegylated version of the same first GLP and GIP agonist. And here's the structure of native GLP-1, native GIP-1, which is 40 dominant, and exenatide, the first GLP-1 approved for it, first incretin approved for use in type 2 diabetes. This is tirzepatide. It's about 39 amino acids. It has 4 amino acids which resembles GLP-1, 9 resembling GIP, and 10 has common to both GLP and GIP, and 10 common to both like exendin. So, and actually, tirzepatide is basically based on the GIP structure. The first animal data using a GLP twin creatine in animal models, the first set of slides showing data showing compared to exendin, GLP-1 agonist. There's the bottom set of figures showing effect combining with effect of liraglutide. So compared to liraglutide, if you use this GLP-GIP coagonist in animal models, showing there is much greater weight loss compared to liraglutide. The one in red is liraglutide, one blue is the GLP-GIP coagonist. And there's decreased food intake, the fat mass goes down, and the blood glucose. So there's these combined, the twin protein was more effective than GLP-1 agonist alone in animal models. And the same study, the same compound, when used in humans for the first time, showed that the study in which what they did, they gave the injection of polyagonist or the GLP-GIP agonist, and then after how much glucose you need to maintain euglycemia. The less glucose you need, that means the more effective the drug is. As you can see, the higher doses of this compound is more effective than placebo, and it's because this compound causes marked increasing insulin secretion. So, however, this compound never saw the light of the day because when compared in type 2 diabetes, this particular compound, GLP-GIP coagonist, was not found to be very effective, superior to liraglutide in terms of weight loss and A1C control, particularly in patients who have high A1C. In those who are lower A1C, this compound works. So some of this compound didn't work very well, although this was the first GLP-GIP coagonist. Tirzepatide, however, on the other hand, is a newer GLP-GIP agonist. It has more like a native GIP, half-life of 5 days. And so in terms of basic science, in the studies have shown that both GLP, GIP, they act on the pancreatic beta cells by increasing cyclic AMP production. So you can measure the cyclic AMP response by examining the effect of this drug in cells engineered to have GLP and GIP receptor. Then you measure how much cyclic AMP is produced, and shown that tirzepatide is equivalent to native GIP production of cyclic AMP, whereas it is 5-fold lower binding affinity, 20-fold lower cyclic AMP production compared to native GLP-1. So it resembles more like a GIP. And this is the first human phase 2B studies with using tirzepatide. And based on this study, there's so much excitement because of you can see the degree of improvement in glycemic control. The red is the dulaglutide, and these are tirzepatide, this 5 milligram, 10 milligram, 15 milligram. It's a 2.4% lower in A1C and about 11.3 kilograms weight loss, compared even much higher than that. Another GLP-1 agonist, that's dulaglutide. So I think I should skip the individual trial. There have been so many trials showing that essentially they're showing that A1C loss the mean A1C becomes 5.8% with higher doses of tirzepatide. That's almost like a normal glucose tolerance. And the fasting glucose level, there's marked decline in fasting glucose levels. There's also improvement in lipid profile. And as you can see, the weight loss, 15% weight loss with tirzepatide 50 milligram, and which was much higher than almost double that of the semaglutide 1 milligram. They did not compare with semaglutide 2.4 milligram, but compared to semaglutide 1 milligram, this is superior. And it was equally effective in both patients who were low A1C, less than 8.5%, and those were more than 8. And almost completely normalized that 24-hour glucose profile. And the adverse events is much higher in the initial phases of treatment. That's the goal, is to start low and go slow, to titrate 2.5 milligram every 4 weeks. And that way you can see the over a period of time, the side effects decline. So this compound is definitely effective than semaglutide, and has also additional effect on beneficial effect on triglyceride and HDL cholesterol. I think I should just skip this. There are several studies, so it was 2, 3, and 4. One compared to semaglutide, then they compared with the insulin degludec, then one compared with the insulin glargine. And this is on patient with type 2 diabetes cardiovascular risk factor to show that it does not improve, but there is no increased risk of cardiovascular events with tirzepatide. Again, the same study, they show that when the 15 milligram dose had a slightly lower MACE cardiac 4-point MACE event, but again, the event rates are so low that one cannot conclude any effect on cardiovascular endpoints based on this study. And this is for non-diabetic obese subjects. Again, it shows that this is the first drug in its class showing 20% weight loss. I don't think any other drug has this much weight loss in non-diabetic obese subjects. And most of the patients reach their target. Everybody reached more than 4%, 5% weight loss. So this drug also has a potential for use in NASH and non-alcoholic fatty liver disease, showing all the markers of NASH, also significant improvement, ALT, AST. Okay, now cardiovascular risk factors also decline significantly. For example, CRP, ICAM1, and leptin. Okay, this is the summary of all SURPASS trials, again, consistently showing that A1C improvement about 2%, and varies from 2 to 2.5%, higher dose of tirzepatide. And this is regardless of the duration of diabetes, age of the patient, the younger versus age, or long or short duration of diabetes, and consistently showing more than 2% weight loss and 2% improvement in A1C. And body weight decline is about 10 to 15%, and in non-diabetic obese patient, the weight loss can reach up to 20%. And although we expect that there will be no side effect or decrease, but it's kind of with side effects as compared to other GLP-1 agonists, it's not higher. So about 10 to 15%, 10% patient may discontinue study medication because of the adverse event. Now, the thing is that how these drugs work, we don't know. We have to still do a lot of basic science, basic studies to see exactly how, whether this is just because of pure GIP agonism through GIP receptor, or is GIP enhanced the effect of GLP-1, or whether GLP-1 sensitizes the GIP receptor, we don't know. So one theory is that improved glycemic control GLP-1 receptor restores the sensitivity to GIP, because we know that improved glycemic control, once the glucose levels come down, so GIP can work better. And other theory is that GIP enhances the lipid buffering capacity, or it works primarily on adipose tissue. So there's a synergistic effect with GLP-1. It works like a thiazolidine in that. And then there's a synergistic because both GLP-1 and GIP act on the centrally, leading to weight loss. And the other thing is that the GIP attenuates the GLP-1 mediated adverse events like nausea. That's improved. So it could be that this is just a very strong GLP-1 agonist, act like strong GLP-1 agonist, or it is the GIP which is more important. So right now, there are several studies going on, which what people are trying to do is you block the effect of GIP, then you block the effect of GLP-1, see which one plays a more important role in mediating the effect of tirzepatide. So, and one theory is also there is that is whether it's purely everything can be explained because of weight loss, but there's some weight independent effects. And I'll skip this one. There's a study in animal models so that tirzepatide actually has a weight independent insulin sensitized animal models. Now, this is the first human study which looked at a mechanistic effect on beta cell function and insulin sensitivity. This was done in Germany. It's a small study, about 45 patients assigned to semaglutide and 45 to tirzepatide, which was recently published. They had an A1C of 8%. They all participated in euglycemic hyperinsulinic clamp, followed by this is the study design. So first they had 80 milliliter per meter square euglycemic insulin clamp. This followed by, after 2 hours, the same day they had a hyperglycemic insulin. This was to determine the muscle insulin sensitivity, this one for the beta cell function. So here the disposition index, which is the product of insulin sensitivity, insulin secretion. At baseline, all groups are comparable disposition, but after about 6 months, this is the semaglutide. There's also improved, but there's much greater improvement in beta cell function with tirzepatide. And showing the first phase, this is the first 10 minutes, the first phase insulin response was better with tirzepatide. The second phase, and this is the arginine stimulated insulin secretion, which is also higher with tirzepatide. And again, showing this is the first phase insulin response was higher, second phase was higher. And the glucose infusion required, the higher, glucose, or the greater the glucose amount of glucose you need to maintain euglycemia, the more insulin sensitive you are. So the tirzepatide group required much more glucose, they're more sensitive. So the M value, which is the glucose infusion rate, again was showing that is much higher. So this is the first study to show that semaglutide, tirzepatide is superior to semaglutide in skeletal muscle insulin sensitivity. There's a greater improvement in beta cell function. And also, I can show you the data, they also led to greater suppression of plasma glucagon, even though despite GIP being there, there's a greater suppression of plasma glucagon with tirzepatide. And the adverse events are comparable to that of semaglutide. So GLP and GIP, they act with synergistic effect. They both work on insulin sensitivity and insulin secretion, and particularly GIP improves triglyceride clearance. They both work on satiety. GIP inhibits lipolysis, and ventricular contaminated residue do not have the effect of GIP, but GLP-1 slightly acts on these effects. And the decreased glucagon secretion, the decreased gastric emptying, and appetite, they both combined work on this. Ectopic fat deposits, most likely GIP works for this, and hepatic glucose production, most likely GIP works on this. So what are the other polyagonists? These are not doing creatine again. There's other polyagonists. I'll show you some data on GLP and glucagon, and GLP, GIP, and glucagon. And these both are compounds, GLP, glucagon, GLP, and GIP glucagon being pursued by Lilly. And GLP-1 amylase, actually, we are just starting a trial on semaglutide plus something called cardio-centric, which is amylin analog. And there are other other compound proposed for GLP-1 estrogen, GLP dexamethasone. You'll be surprised that we can think about using dexamethasone for treatment of obesity. In fact, what they do use it, the GLP-1s as a vehicle to enter into hypothalamus, then dexamethasone acts centrally to reduce appetite, so it can, in fact, inhibits hypothalamic inflammation without having an effect on bones or insulin resistance. So these are just animal models, but not been no human trials yet. So glucagon, now we know that glucagon is very counterintuitive when you think about glucagon as a treatment for type 2 diabetes. We all know that it increases hepatic glucose production and primarily used for hypoglycemia. So how can we use it for treatment of diabetes? Glucagon has another unique effect, particularly in patients with hyperglycemia. It can important insulin secretagogue and insulin secretion. It has a central effect, decreases appetite, decreases energy expenditure, and it particularly in the liver increases free fatty acid oxidation and decreases liver fat, and also has effect on gastric motility, and increases amino acid uptake, which also contributes to systemic insulin resistance. So combined GLP-1 GIP with glucagon with another novel metabolic effect in addition to GLP effect on adipose tissue itself. So it's strange, both glucagon agonist and antagonist are being developed for type 2 diabetes. Type 2. We are in fact doing a trial with glucagon antagonist, but the problem with glucagon antagonist is that although they improve glycemic control, they increase liver fat, but they inhibit fatty acid oxidation, so they may never be approved. There's one being tried earlier, which is the company stopped pursuing any further because of the same side effect, the effect on hepatic toxicity. Okay, so this is the triple agonist being tried by started treatment and going to trial phase with Eli Lilly compound, which acts on both GLP, GIP, and glucagon, because theory is that the GIP works on the adipose tissue, works in adipose tissue insulin sensitivity. It also works on the central nervous system, and islets, improve insulin secretion. GLP-1 again works on the CNS, decreasing appetite, and glucagon, as I just mentioned, increases energy expenditure, increases insulin secretion, and the effect of GLP and GIP-1 upsets this hyperglycemic effect of glucagon. So you see upset the hyperglycemic effect, but you see the energy expenditure or the weight loss or the decreased caloric intake induced by glucagon. So this is the first trial with the triple agonist just been published in Lancet, and for the combined prior this compound triple GLP, GIP, and glucagon in patient type 2 diabetes, phase 1b study, and showing that this is the small study, but it's showing that here the decline in the hemoglobin A1C, change in hemoglobin A1C about 1.5%. The body weight decreased by about 9%. And here, but the most important effect was on lipid profile. You should see that dulaglutide actually increases LDL, whereas you see such 30% decline in plasma LDL. And the triglyceride, you see almost 40% decline in plasma triglyceride, and also decreases systolic blood pressure. So the triple agonists, we do not have big trials in type 2 diabetes patient yet. So you know that we will find out what is the metabolic effect of this drug, but it does improve glycemic control and body weight for over 3 months, and clearly it improves lipid profiles. So we feel that this drug will have a potential utility in treatment of particularly in NAFLD or NASH. So to summarize, GLP-1 agonists improve glycemic control and reduce body weight without hypoglycemia. And so phase 3 studies already shown that this agonist shows promising results in glycemic control and weight loss. And so far, I believe, is the most potent agent still available moment, which lowers the A1C by 2.4% and weight loss by about 20%. I think only the bariatric surgery will be the metabolic effect of this particular compound. And although we expected that the adverse event would be less than GLP-1 agonist, but it's similar, but you see much greater weight loss and glycemic control. And however, the long-term data, there's a study going on, cardiovascular outcome called Surpass CVOT. The results will come out in about 2 years, but preliminary data has shown that it's kind of neutral and has favorable effect on cardiovascular risk factors. So you expect at least to be neutral or better, superior in terms of cardiovascular outcome compared to other GLP-1 agonists. So I think this class of medication in the future, several multi-agonist, polyagonist, single molecule polyagonist, we will see a lot of them in future, and they will have a role in for treatment of diabetes, obesity, and several other diseases too. I think that's the last slide. I'll stop for any questions. Thank you.
Thank you, Dr. Devjit. It was wonderful listening to you. And I'm sure you have been part of most of these trials. So it is coming from horse's mouth, the data of phase 2 and phase 3. Are we somewhere near to a launch of triagonist, which you discussed? And what is going to be the way? How long it is going to take? It will have,
we are just starting the trial, so it will take at least a year or 2 years now.
Okay, 2-3 years. So, and the way these GLP agonists are evolving, GIP and triagonists, do you think there will be a place for conventional GLP-1 receptor agonist after 5 years?
Yeah, I mean, so far the semaglutide has clearly shown improved cardiovascular renal outcomes.
Yeah.
If this agent does not show any cardiovascular renal outcomes, then
that is what exactly I wanted to learn from you. Yeah, yes. Because with CV outcome trials, both Sustained and Pioneer, which have been very, very encouraging in terms of CV 3-point MACE and some renal composite endpoints and reduction in albuminuria, I think SEMA will still have a long way to go till we have outcome trials with the triagonist and tirzepatide or other things.
Yeah, I think this will definitely have a role regardless of the cardiovascular outcome for treatment of medical management of obesity. We still did not have any other drug other than semaglutide, which is really effective for treatment of obesity. Yeah.
So these may be actually wonderful option as anti-obesity drug, but you feel that as long as it is management of type 2 diabetes with obesity or diabetes, still SEMA will have a long way.
Yes, so because everybody is obese in US, and I don't see any lean diabetics. I know there's some lean diabetes in India, but we don't see them in US. Yeah.
But the HbA1c reduction was also 1.5%, which is pretty significant when it comes to anti-diabetes therapies. So efficacy also 1.5% is a pretty good reduction if you give it to any of these agents.
GLP-1 agonist. Yes, it is definitely. But this one can go up to 2.5%. And I'm telling you, because I had a couple of so many patients who come off insulin. They were on like 50, 60 units of insulin. This patient was on more than 100 units. Is off insulin and lost 50, 60 pounds. So we don't see that any other drug other than bariatric surgery. Yeah.
So maybe a lot of things coming out in the future, which we just need to wait and see.
So it's exciting times. Yes.
Absolutely. Absolutely.
It was wonderful listening you, Dr. Devjit, after a long time. And
great. Awesome.
Hopefully we'll catch you next time for a physical meeting in Delhi. Great.
Sure.
And,
okay.
Thanks a lot.
Thank you again, Dr. Chawla.
Thank you so much, sir.
Wonderful.
Thank you.
Wonderful oration. Thank you. Obliged. Over to you, Dr. Shalini, to take the session to Dr. Benny and Dr. Lily.
Thank you so much, sir. That was an excellent keynote, and I'm sure exciting times to come, especially when it comes to diabetes management. With that, we move on to another very, very significant aspect, the type 1 diabetes and beyond. Some very interesting lineups here again. I'm sure we're having a good time listening to all our excellent speakers. And I now welcome my two chairpersons, my very senior colleagues, my very good friends, mentors, guides, Dr. Benny Negalur, ma'am, Director of Dr. Negalur's Diabetes and Thyroid Specialty Center and a consulting diabetologist, Jupiter Hospital, Thane. Somebody who's very, very active into the field of women and diabetes health, as well as Dr. Lily Rodriguez, again, one of my very, very close friends and seniors. Dr. Lily Rodriguez is a consultant physician and diabetologist, currently director at Stride Hospitals, Hyderabad, chairman-elect for Hyderabad, Telangana chapter, if I'm not wrong. So welcome, Dr. Benny and Dr. Lily, and it's all yours for the next symposium.
Thank you so much, Dr. Shalini, and let me congratulate Dr. Rajiv and you for a really good academic piece, which I've been listening to most of the talks since yesterday.
Thank you so much, ma'am.
And Dr. Lily Rodriguez joined me in welcoming all delegates to this very, very good, important session of type 1 diabetes and beyond. And we have three eminent speakers in this session. We know that type 1 diabetes is most common chronic autoimmune disease in children, and the pathogenesis is totally complex and really not well understood. It's like finding a needle in a haystack. And also this type 1 diabetes research and is a path that is actually less tread. Recent studies have focused on several genes, both the HLA genes and the non-HLA genes, and there have been environmental and metabolic biomarkers for prediction of development and progression of type 1 diabetes. But once the child becomes diabetic, I think most of the beta cells are gone, and therefore we need to have asymptomatic phase prediction biomarkers, which I think is a big puzzle. And to solve this puzzle, we have Professor Colin Dyan. He is from USA, trained in medicine at University College Oxford and Guy's and Charing Hospitals in London, UK, before obtaining his PhD in immunology of Graves' disease in the laboratory of Mark Filman. He spent a year as an endocrine fellow at the Massachusetts General Hospital in Boston, USA, before completing his specialized training in diabetes and endocrinology as a lecturer in Bristol. He's a consultant senior lecturer in medicine at the University of Bristol in 1995 and head of clinical research at the Henry Wellcome Laboratories for Integrative Neuroscience and Endocrinology in 2002. And in 2010, he was appointed to the chair of clinical diabetes and metabolism and head of the section at the Cardiff University School of Medicine and became the director of the Institute of Molecular and Experimental Medicine in 2011. He has a long established interest in translational research in immunopathology of type 1 diabetes and thyroid disease. And I think he will give us a lot of insights on this very important topic of prediction and prevention of type 1 diabetes. May I invite Professor Colin Dye? Sir, are you here?
Yes.
Yes.
My name is Colin Dye from Cardiff University, and thank you very much for this opportunity to talk to you about predicting and preventing type 1 diabetes. I have talked about this at a previous meeting, so today I'm going to talk about what's new in this field, and quite a lot is changing over the last year. First of all, here are my disclosures. So I'm just going to recap on some things that I said at a previous talk a year or so ago, just so that everybody is on the same page. So autoantibodies can be present for many years before the diagnosis of type 1 diabetes, and they allow us to identify the early stages. So here's some of the data that shows that, and it's showing you children who are screened for autoantibodies, and those in green or in purple with 2 or 3 autoantibodies, if they were followed up for 15 years, 80% or more, in fact, closer to 90% of them later, develop type 1 diabetes. That's not true if you have only one autoantibody. And these are the kind of autoantibodies that we're looking at, shown on the right-hand side. If you go through a stage where you're dysglycemic, similar to impaired glucose tolerance in type 2 diabetes, then you're progressing much more rapidly. So here are autoantibody positive children who are dysglycemic, and you can see that within 5 years, 90% of them had already developed, not 15, but 5 years. So that's more quick progress as compared to those who are normal, in normal glucose tolerance. And this gave rise to the idea that there are 3 stages of type 1 diabetes. Stage 3 is what we tend to think of as type 1, which is when you become symptomatic and need insulin. But prior to that, there is stage 2, when you have the autoantibodies and you're dysglycemic, and here you have more endogenous beta cell function, usually measured by C-peptide levels. And prior to that, you have stage 1, where you have autoimmunity but normal glucose tolerance. And last time, we also talked about this study, which was reported in 2019, using the drug teplizumab, which is an anti-CD3 antibody, in stage 2, so pre-diabetes with dysglycemia. And as a landmark trial, it demonstrated a delay of around 2 years. Here's those treated for just 14 days with teplizumab, a delay in developing diabetes compared to the red line, which is those who received placebo. And when followed out to 5 years, as predicted, over 80% of the placebo group had developed type 1 diabetes, had gone to stage 3. We mentioned that drug had been taken to an FDA advisory panel in 2021, and the panel had voted in favor of that drug being supported, and that had gone back to the FDA. So at that time, I described that if you want to compare the development of prevention of diabetes with the development of powered flight, there was the first move in powered flight, but I think we are more effective than that. We've probably gone as far as here, this landmark in powered flight, where they managed to cross the Atlantic about 24 years after the first plane had actually flown just 120 feet. I don't think we've got the whole field as far as this, for example, supersonic flight, but we're certainly making progress. So with that background, what's new? Well, we mentioned this study, which was the first prevention study with the drug teplizumab. That's been reanalyzed following the participants for longer, and it's now realized that not just a 24-month, but actually closer to a 32-month delay on average can be calculated. So here they've followed the participants out to 6 years now, and you can see that 22% of the placebo group are diabetes-free, whereas 50% of the teplizumab group, and it looks like some of them might have a very long period of time when they don't develop diabetes, or maybe don't develop diabetes at all. Important to remember with that drug that they were only treated once at the beginning for 14 days with the immunotherapy. Secondly, the American Diabetes Association has now taken on that staging of diabetes. So it's, if you like, official, this idea of stage 1, stage 2 with dysglycemia and autoantibodies, and stage 3. We've floated the idea of considering that stage 3 might be divided into a very early stage 3, when you have early type 1 diabetes and not requiring insulin, as opposed to a later honeymoon phase, if you like, where you do require insulin, but you have a pretty good C-peptide level and a low risk of ketosis. And then finally, stage 3, which is a level that we're used to, with very little remaining C-peptide and a high risk of ketosis. And we're beginning to see cases now, certainly referred to our service, which might be considered to be stage 3A, such as the first one here, a 28-year-old man with a BMI of 25, who had an insurance medical, and they measured his HbA1c and found it to be 51, or closer to around 6.8%. He had quite a high level of C-peptide, but was strongly positive for anti-GAD antibodies. And this looks like it is truly stage type 1 diabetes, but again, not at a stage where he needs insulin. And below is a case of a 9-year-old girl in a similar position, but tested because her brother and mother had type 1 diabetes. So it's likely that as more testing happens, and certainly as teplizumab is introduced, we'll pick up more and more individuals at this early stage of type 1 diabetes. Another development over the last year is addressing the question of whether tight control at diagnosis preserves C-peptide, preserves beta cell function. And this was a study comparing closed loop therapy with a control group of intensive therapy from diagnosis, within 10 days of diagnosis of type 1 diabetes, from Roman Havorka's group in Cambridge. As you can see on the right-hand side, they did get very good levels of HbA1c control, and it was better in the closed loop pump therapy group. However, overall, over the 24-month period, there was no advantage in terms of C-peptide level. In fact, if anything, the closed loop group had a slightly lower C-peptide level. So it's a bit disappointing, but it does emphasize that glycemic control alone is not sufficient to preserve beta cell function. We're now extending the number of agents that have shown some evidence of preservation of beta cell function. When I talked last time, we mentioned the first 6 here, which have shown evidence. Anti-CD3 or teplizumab is the top one over here. But I'm going to mention 2 for which we have evidence now, imatinib and verapamil. And then there's reports coming out in the next 6 months or so on all of these other agents. So we may be able to extend our collection. So imatinib is a tyrosine kinase inhibitor, and it has effects on the immune system. It actually also has effects on insulin resistance. So this was trialed in new onset type 1 diabetes. So this is not prevention. This is new onset type 1 diabetes, but that's where we begin to test the drugs. On the left is the C-peptide, and the drug was given for just 6 months. And then the patients were followed for 12 months. And during that period of time, there was a significant improvement in the blue line here in the imatinib group, although it declined over the 24 months after stopping the therapy. On the right-hand side, you can see the adiponectin levels, and the adiponectin levels on imatinib were much higher than they were in placebo, and then declined after stopping the therapy. And this triggered greater insulin sensitivity. And that can be seen by the fact that the insulin doses were substantially lower in the imatinib group compared to the placebo group. So this is another form of, it's immune therapy, but it also has an effect on insulin sensitivity. And that allows the beta cells to be effective for longer in terms of controlling glucose, or you need less insulin. A second new agent, well, it's not new, it's been around for 50 years, is the calcium channel blocker verapamil. And over the last couple of years, this has been trialed in new onset type 1 diabetes. Why has it been trialed? Well, the evidence suggests that by blocking the calcium channels, the L-calcium channels, these calcium channels are important for the adverse effects of high glucose and also of cytokines or inflammation by the TLR4 receptor. And this operates by the TXNIT pathway, which is a pathway that's designed to protect against high redox potential or oxidative stress, and eventually resulting in apoptosis. So the evidence suggests that although verapamil is not immunomodulatory, it does protect the beta cells from inflammation and also ultimately from hyperglycemia as well. And the first study was presented in a couple of years now back, when they presented the first year of data, which is shown here, the red line, and this is C-peptide levels, suggesting that those taking verapamil, this is just a standard tablet once a day, up to about 360 milligrams, had a better C-peptide level compared in black with placebo. And here I'm showing you the follow-up data, which has been published this year, showing that if you stop the therapy, things get worse. But if you continue the therapy, you continue to get benefit. And here it's showing that they needed less insulin, so a lower insulin dose. And on the next slide, this was the original paper in 2018, showing less insulin dose, but also a lower HbA1c, less hypoglycemia, and bottom right, more time in range. So this seems to be a useful agent as well. We've conducted an analysis of bringing together almost all of the recent new onset studies, as shown here, listed here, in the TOMI-T1D collaboration along with the CPATH Institute in Arizona. What that's allowed us to do is get the largest number of people, subjects in this analysis, nearly 2,000 subjects. On the right-hand side, you can see the intervention group in blue in the positive studies, and there were 8 positive studies here, compared to the control group. And what you can see is the preservation of C-peptide over that period of time, although it's still declining. What we were able to illustrate, and that was hard in the individual trials, is in the green line, you can see the HbA1c in the placebo groups of the positive trials. And here in red is the intervention group in the positive trials. And now beginning to show you that the HbA1c actually improves within 6 months, perhaps even more earlier than that, in the positive compared to the negative trials. In other words, immunotherapy does have an effect on HbA1c and not just C-peptide, certainly in the new onset patients. And this is showing you, if you model the effect from all that data, depending on how much you preserve the beta cell function, in the red line, if you preserve more than 86% of the beta cell function out to 2 years, the HbA1c is in an excellent place 2 years later. If you don't do that and you preserve less than 36%, like in this purple line, the HbA1c will begin to rise over that period of time. So that's evidence of metabolic benefit. But of course, if we go back now to talking about prevention, meaning getting at the early stages, stage 1 and stage 2, that does mean that you have to do screening for the autoantibodies. And just to reemphasize this part, that only 10% of cases come from families. So if you want to find everybody, you have to screen the whole population, because 90% of cases are sporadic. However, there is a benefit in screening, particularly in the prevention of diabetic ketoacidosis, because the young people know that they're at risk of type 1 diabetes, and that reduces the prevalence of type 1 diabetes, of diabetic ketoacidosis, and admission to hospital. This year was published the first review of efforts to look at general population screening. Up until now, it's just been screening of relatives, and more of this is happening. I think you'll hear more in the coming years of these efforts at screening the whole population. But here's analyses looking at that effect on DKA and hospitalization rates. On the right, showing a dramatic reduction in the DAISY study from 44% to 3% admitted to hospital at diagnosis. And this is DKA rates across 3 different studies here, showing a drop of up to 10-fold in the DKA rate, because the patients know that they know what to expect. We've had a couple of new studies published in the last year looking at better ways of screening. And this was a large analysis of almost all the prospective trials, following 6,722 children at genetic risk, either because of familial risk or because they've then been screened with HLA markers to show that they've got the highest genetic risk. And that usually identifies around 10% of the population who's going to develop diabetes. And that's exactly what they saw. 672 of them developed type 1 diabetes. And they looked to see when the autoantibodies appeared. And it seemed that the best way to pick the people up who were going to develop the diabetes, or 1 in 10 who were going to develop diabetes, was to do a screen at 2 years and 6 years. An alternative is to screen just once at 4 years, but you would miss more of them. By screening at 2 and 6 years, they estimated that you would pick up 80% of the children who were going to develop diabetes by the age of 15 years. There's still, of course, a group that are going to be missed. But those are a group that could be put into therapy. Annette Ziegler's group have also explored algorithms to work out in that early stage who's going to progress. And they identified that early rises in the sugar levels in an oral glucose tolerance test, the HbA1c, and positivity for particularly the IA2 antibody were important. And they developed this slightly complicated formula. But using this formula, they were able to predict in blue much more accurately those in stage 1 who were going to progress over the next 2 or 3 years compared to those who weren't going to progress. And that's quite important in being able to know who to intervene in. There are quite a lot of risk indices out there now. We're just showing you these two on the bottom line. There's the Diabetes Prevention Trial Risk Score and Index 60 that are used. People have used AUC glucose, CGM-based metrics. But I just wanted to mention more work that we've been doing in this area to try and develop this further. There's been a recent publication on Index 60, also showing an ability to predict. So the higher levels of Index 60 in red predict more effectively than the green or the black. But really, all of these are just using area under the curve C-peptide, when, as we know, insulin is secreted in 2 phases, and it's not a kind of linear rise in C-peptide over the 2 hours of an oral glucose tolerance test. So with colleagues, Claudia Cobelli's group, we've been looking at what they had developed as the oral minimal model, modeling this 2 phases of secretion and actually insulin sensitivity as well, and being able to replicate that by the data from the oral glucose tolerance test. This is just showing you the phases of secretion, those where the granules are ready to go, and those where new synthesis of granules is required. And then obviously the effects of insulin, its clearance and its insulin action. So they've modeled this together in quite a complicated mathematical model called the oral minimal model. And this now gets out of an oral glucose tolerance test 2 measures of secretion, a dynamic or early phase secretion and a static or late phase secretion, and insulin sensitivity. And then you can combine the 2 with what's called the disposition index. So we look forward to beginning to do this kind of analysis, perhaps, and getting even better predictors of people whose beta cell function is declining. So I want to say a little bit about what you do now if we screen people that are autoantibody positive. How do you look after them? Because they're not going to develop diabetes for some time. And there's a lot of work in this area, but there's still more to be done in managing stage 1 diabetes. So here's a proposal that we've made that when you have 2 antibodies or more, double antibody positive, those are the people who are going to progress, that we might then have a consultation at that point and measure HbA1c and random blood glucose and do those at 3 monthly intervals, as shown here. And if they begin to rise to being more than 41, or there's a 10% rise in HbA1c, or the random blood glucose is more than 6.0 millimoles per liter, then that's a moment when we go back to the nurse or the doctor, and they should be referred to the specialist team and begin to prepare for insulin or an insulin start. And that way we can gradually identify the people progressing and begin them on insulin without the risk of being admitted to hospital or developing ketoacidosis. New designs are beginning to develop in clinical trial designs, and this is a paper we published with colleagues recently, thinking about innovative designs. And in many areas, such as oncology, people are talking about adaptive trials. We're beginning to do trials in that way. You have a master protocol, and then you have several arms using shared controls. So here's one in which we're now looking at verapamil, and then looking at verapamil in combination with other drugs, such as teplizumab that we mentioned, a drug ATG, which has shown effect, and a abatacept, which has shown effect. And this is a clinical trial in planning. And then after 9 to 12 months, you can analyze the interim data and drop arms that are really not showing benefit. In fact, you can then combine trials. So here is a rather complicated slide, but above is the trial we just described. But in parallel, we've begun already comparing verapamil with placebo to replicate the earlier data. And then those on verapamil alone can be used as controls for the larger study. So these are ways by which trials can share controls and be more efficient in terms of testing new immunotherapies. Finally, the question, of course, is teplizumab going to be licensed? We mentioned that it went to the FDA last year, and we should be hearing on the 17th of November whether it has got a license in the United States. And this was a press release recently showing that Sanofi had entered a deal to launch teplizumab if it actually is licensed. So suggesting there's going to be a lot of support for this drug if the FDA approve it very shortly. So in conclusion, the ADA has now accepted the staging of pre-T1D, stage 1, 2, 3. 14 days of treatment with teplizumab in stage 2 has been shown to delay the onset of type 1 diabetes by more than we thought, now 32, nearly 3 years of delay. And this is the first drug that may be licensed soon by the FDA. Imatinib and verapamil have shown some promise as agents that can preserve beta cell function and add to the collection that we have. Combined analysis provides evidence that retaining C-peptide reduces HbA1c up to 2 years. Population screening, not just relative screening, is being planned. And we're seeing soon adaptive platform trials, which allow us to test the immunotherapy drugs and the prevention drugs much more rapidly. Thank you very much.
Thank you, Dr. Colin. It was such a wonderful insight into a newer drug that is yet not available for us, but it has been a real eye opener for us to hear you. It was such a beautiful experience, and we'll all look forward to such a drug to come to India as well. Now we move on to the next speaker, who would be talking to us on endocrinopathies and other types of diabetes. Dr. Anshul Kumar Singh, who's an MD internal medicine and DM endocrinology, consultant endocrinologist at Agra Sen Hospital, Punjabi Bagh. Dr. Anshul has attended and participated in various national and international conferences and workshops. He is a member of the Endocrine Society of India, the Research Society, that is RSSDI, and other such organizations. He is very well updated with the latest advancements in the field and has undergone several certificate courses. Third position in National Endocrinology Quiz at ASICON 2019 in Nagpur. He has also received several prestigious awards in the field of medical sciences and has published over 10 papers in several national and international journals. Over to you, Dr. Anshul Kumar. We're all waiting to hear you.
Thank you so much. Thank you so much, ma'am, for that generous introduction. So I'll just share my screen.
Yeah.
And I hope everyone is able to see.
Yes.
All right. Thank you, ma'am. So I'll straight away begin with my topic. So the topic for today is endocrinopathies and diabetes. So this is the other diabetes. As we all know, type 1, type 2, and gestational diabetes, these continue to be the most common forms of diabetes. However, there are certain rarer forms of diabetes which may occur as a consequence or in fact as a part of other endocrinopathies. It has been estimated that 1 to 2% of all the cases might be due to a secondary cause. So when should we suspect that it might be an endocrine cause? So first, if there is a type 2 diabetes who doesn't fit the bill, for example, somebody who is a young age at onset, who is non-obese, or somebody with the type 2 diabetes which is rapidly progressing, for maybe over a period of 2 to 3 years, somebody has gone from being well controlled on one OAD to 2 to 3 OADs, and then now maybe on insulin the patient is not controlled, or has suddenly and unexpectedly progressed to diabetic ketoacidosis. Then in case of certain incidentalomas, so like an adrenal tumor, pituitary, or a pancreatic tumor, needs to be investigated, of course, for the presence of hyperglycemia. There might be other pointers, some syndromic features, like in MEN1, we might have neuromas, or the classical features of hormonal excess, like Cushingoid features or acromegaloid features. These might point towards a possible endocrinopathy which might be associated. So these are the endocrinopathies that we'll be discussing. And I'll be discussing them through cases just to make it a little less boring. So the first case here, we have a Mr. X, 39-year-old male, who presented with complaints of increased sweating and acne, coarsening of facial features, shortness of breath, which he developed last 3 years, and frequent change in shoe size and tightening of rings of their own fingers. He had a history of hypertension as well as CHF. He was being treated with antihypertensives and was also on oral anti-diabetic agents. So as we can see, the patient has coarse facial features. There is a fleshy nose. There is frontal prominence, prognathism. The palms were very fleshy. These are this is comparing his hand with his father's hand, which is clearly bigger and larger. So on investigation, the head there was macrocephaly. The nose was large, fleshy. The oral examination showed malaligned jaws. All in all, there were a myriad of acromegaloid features which were present. We went for a growth hormone analysis. The basal was raised, and then we subsequently subjected the patient to a glucose suppression test for growth hormone. The suppression, which ideally the nadir should have been below 1, came out to be 11, and thus a diagnosis of acromegaly was made. We went ahead with an MRI, and we were able to diagnose and pinpoint a pituitary microadenoma. So these were the patient's preoperative glycemic levels. The patient was taking gliclazide 30 mg, sitagliptin, as well as metformin. His fasting blood glucose levels were around 160, and postprandial after breakfast were 300. So the dominant mechanism for this hyperglycemia is, of course, IGF-1-induced insulin resistance, along with certain other minor contributors, which we will be discussing. The post-operative glycemic control at around on the 3rd or the 4th post-op days, if I'm remembering correctly, the patient started experiencing hypoglycemic episodes, and this was off medications. So this was because of the fact that post-surgery, the patient developed iatrogenic hypopituitarism. There was hypocortisolism, and along with the decline in the growth hormone levels led to this situation where the patient was developing recurrent hypoglycemic episodes. So acromegaly, like we've already discussed, slowly progressive disease with the chronic excess of growth hormones. It is highly debilitating with severe comorbidities, which include cardiovascular, respiratory, even increased neoplastic risks. The prevalence of diabetes in patients with acromegaly, there have been a very few studies. This was one study which I was able to find, where in comparison to normal people, there was an increased risk of around 52.5% patients with acromegaly were diagnosed with diabetes. So the pathophysiology of hyperglycemia, when we talk in acromegaly, so growth hormone in adipose tissue leads to increased lipolysis, which leads to increased free fatty acid, increasing the insulin resistance. Similarly, at the level of the liver, the kidney, there is increased gluconeogenesis. At liver, there is increased glycogenolysis. IGF-1 is, of course, also increased in the liver, by the liver. Pancreas, it acts on all of this, acts on the pancreas, leading to increased insulin secretion. All of this contributes towards producing a state where there is hyperglycemia, increased insulin resistance, and thus type 2 diabetes. So the effect of treatment. So we went for this patient, we went for a transsphenoidal surgery, like I've already mentioned, but the patient became hypoglycemic. Talking generally about acromegaly patients, both radiotherapy and transsphenoidal surgeries are associated with decrease in growth hormone levels, and so with associated decrease in blood glucose levels as well. There is also medical management. So, and the first line are the somatostatin analogs. There are first generation somatostatin analogs, which include octreotide, lanreotide. These have minimal effect on the glycemic levels. However, the newer somatostatin analog, which is pasireotide, which has greater affinity towards somatostatin receptor 1, 3, and 5, is notorious for causing hyperglycemia. Pegvisomant again decreases IGF-1 and therefore has been proven and been shown to decrease the fasting insulin level as well as fasting glucose and HbA1c. Moving on, so this is case 2. This was a 16-year-old boy with weakness of proximal muscles, purplish stria, increased abdominal fat. He also was diagnosed with diabetes and hypertension. He was being controlled with insulin and was on antihypertensives. This is the classical presentation. In the patient, there was moon facies, facial plethora, dorsocervical fat pad, neck acanthosis. The classical Cushingoid features were present. This is the purplish stria that I was mentioning. We went for the basal cortisol, which was raised, the overnight dexamethasone, the low dose dexamethasone, all showed and pointed towards possibly a pituitary adenoma secreting ACTH. Therefore, we went for a dynamic contrast of the pituitary, and pituitary microadenoma was diagnosed. We subjected the patient to transsphenoidal surgery. Again, going back to the pre-operative glycemic profile, the fasting blood glucose was very high. Despite being on insulin, it was 240, post-breakfast was 320. And the mechanism involved, as we all know, it was the decreased insulin post-receptor activity, inhibition of GLUT4 activity, increased gluconeogenesis by stimulation of PepCK, and increased glucagon production. The post-operative glycemic profile improved a lot, and this was at 1 month. As of now, I can say that the patient is controlled without any medications. He is not euglycemic. So Cushing syndrome, it can be due to both autonomous cortisol production by the adrenals or secondary to raised ACTH production. Even exogenous cortisol administration, glucocorticoid administration can lead to exogenous Cushing's. When we talk about the incidence of diabetes in patients with Cushing syndrome, it can vary, but most studies usually put it around 35 to 47%, and IGT is equally high. The pathophysiology, like we've discussed, so there is increased visceral obesity, decreased growth hormone secretion, muscle mass decreases, glycogen synthesis decreases, the beta cell function is decreased, incretin secretion is decreased. All of this cumulatively leads to a situation where, due to the increased glucocorticoids, there is hyperglycemia. Effect of treatment. So same as acromegaly, the first line is, of course, transsphenoidal surgery. Radiotherapy is also features right up there. Along with the decrease in the cortisol level, the glycemic profile also improves. Medical management, barring pasireotide, which we've already discussed, which worsens hyperglycemia and has been proven to do so. All the other medications, be it ketoconazole, metiropone, oscillodrostat, which is a recent addition to this armamentarium, mitotane, all lead to decreased cortisol level and thus improvement in glycemic profile. Moving on to the third case. So this was a case of 76-year-old female, known case of diabetes for the last 3 years. She had an HbA1c of around 6.9. She was on metformin. She had weight loss, increased forgetfulness. She denied any complaints of increased sweating since we were suspecting hyperthyroidism, but there was no increased sweating, heat intolerance, or change in bowel habits. She had a thin build, listlessness, apathy, there was tachycardia, as well as hypertension. So I've already mentioned the drug she was on. So on the routine examination, the fasting blood sugars were 140, postprandial blood glucose was 160. We prescribed her thyroid profile because the patient, keeping in mind the thin build and the history of recent weight loss, it came out that she had hyperthyroidism. It was probably apathetic hyperthyroidism considering her increased age. We went for a technetium scan, which confirmed the diagnosis. We started her on methimazole, and about 3 months after starting, once the thyroid profile had normalized, she became euglycemic, and we were able to take her off medications. So hyperthyroidism, we all know what hyperthyroidism is. Prevalence of hyperthyroidism in diabetes. So it's the other way around. In diabetic population, roughly 4.4% people have been diagnosed to have thyroid dysfunction towards hyperthyroidism. Several mechanisms have been attributed to the cause of hyperglycemia in hyperthyroidism. Most common is the increased glucose production, leading to impaired glucose control. Similarly, there is increased glucose absorption by the GI tract, increased appetite. There are hyperproinsulinemia, increased free fatty acids, increased insulin resistance. So this is just to summarize what all effects hyperthyroidism has on the glucose profile. All of these factors in combination lead to increased glucose levels, and therefore it becomes imperative to check and treat in case if there is hyperthyroidism. Case 4. So this was a patient. He was a 31-year-old male. He presented to us with recurrent episodes of paroxysmal episodes of headache, sweating, palpitations. These episodes lasted for about 5 to 10 minutes. There were no aggravating or relieving factors. The episodes resolved spontaneously. But we went for, the patient was classically presenting as a pheochromocytoma episodes. We went for the metanephrine, urinary metanephrines. The non-metanephrine was very highly raised. We went for radiological imaging. This was the CT scan, which was done according to the adrenal protocol of the patient. And as it is clearly shown, there were bilateral adrenal masses. We also went for an MRI of the chest because the HRCT initially had shown some mass. We weren't able to discern what it was. And the MRI showed a parasternal mass, which could possibly would have been paraganglioma. So we went for a sestamibi, which showed 2 paragangliomas in the chest and 2 pheochromocytomas. So coming back to our topic for the day, glycemic profile of the patient in the fasting blood glucose was not in the diabetic range. However, the 2 hours post breakfast, it was high. The mechanism is, of course, we know that alpha adrenergic effect, it reduces insulin secretion. Beta adrenergic, it increases hepatic glycogenolysis. And the increased circulating fatty acids, it leads to increased insulin resistance. Post-operatively, the patient's blood glucose levels came down. Patient became a non-diabetic post-surgery. So we all know what pheochromocytoma is. It's a catecholamine secreting tumors, rare neoplasm. It is estimated that annual incidence is very low of pheochromocytoma, but the patients who present with such classical symptoms of paroxysmal episodes of hypertension must be evaluated for a possible cause, which might be pheochromocytoma. The physiology of hyperglycemia is that alpha-1 receptors, like we've already mentioned, there is decreased GLP-1 secretion, increased glucagon secretion, increased free fatty acids, decreased insulin, decreased GLP-1, and all of this cumulatively leads to hyperglycemia. So yeah, pancreatic neuroendocrine tumor, I'm so sorry, I haven't encountered any cases of glucagonoma or somatostatinoma. So I'll just recapitulate just the theory. So the neuroendocrine tumors, they constitute a heterogeneous group of neoplasms. Pancreatic neuroendocrine tumors, which include both glucagonoma as well as somatostatinoma. These are frequently associated with dysglycemia. Again, there is a high chance that the patient with pancreatic neuroendocrine tumors will have dysglycemia or diabetes. Glucagonoma, of course, is one of the sine qua non of one of the 4 Ds of the classical symptomology of glucagonoma. Somatostatinoma, on the other hand, it is extremely rare. It presents with diabetes, diarrhea, gallbladder. However, diabetes is not very severe. The diabetes is because that is probably a part of because the somatostatin inhibits both insulin and glucagon, and this differential inhibition is probably the explanation for the mild degree of hyperglycemia which is seen. Effect of treatment. So the treatment is pancreatectomy, and we all know pancreatectomy, especially where the head or the tail is being excised, can itself lead to pancreatogenic diabetes. And in a large study group, it was shown that 4.8 to 39% of such patients developed pancreatogenic diabetes post-operatively. Treatment by somatostatin analogs we've already discussed. Now, there are certain factors that we need to consider here. Although there are no set guidelines for the treatment of diabetes in pancreatic neuroendocrine tumors, however, metformin has been shown that it has anti-proliferative properties. DPP-4 inhibitors are also being tried for treatment of insulinoma in animal experimental studies. DPP-4 inhibitors and GLP-1 RAs, the incretin therapy, has an effect on the regenerative effect on the pancreatic islet cells. Additionally, GLP-1 RAs it's a contraindication with patients with medullary carcinoma thyroid, which in itself is a neuroendocrine tumor. So all of these factors should be kept in mind. However, as far the guidelines are concerned, there is no specific treatment approach to patients with pancreatic neuroendocrine tumors. Yeah, finally, primary hyperaldosteronism or the aldosteronoma. Primary aldosteronism, it's a group of disorders in which aldosterone production is high. This leads to increased sodium and low potassium concentration. This causes hypertension. It can cause cardiovascular damage, sodium retention, suppression of plasma renin. It is most commonly caused by an adrenal adenoma. The prevalence, it has been widely accepted now that it is underreported because we also tend to associate hyperaldosteronism with hypokalemia. However, in recent studies, incidence as high as 10% has been reported in hypertensive patients who have been normokalemic. So the mechanism of hyperglycemia, it's predominantly, so pancreas, there is hypokalemia. We know hypokalemia leads to reduced insulin secretion, and in addition to adipocytes where there is inhibition of insulin receptor mRNA leading to insulin resistance, and all of this leads to increased blood glucose levels in patients with primary hyperaldosteronism. Yeah. So finally, to summarize, postparental hyperglycemia, like we've seen, is a common occurrence in diabetes due to endocrine causes. Reversal or at least improvement is usually seen as a natural phenomena or as a post-therapy adjunct. Every time these tumors are treated, hyperglycemia at least improves. If it doesn't completely is not cured, it does improve. Spontaneous hypoglycemia, like we've mentioned, sometimes might be seen, especially with pituitary tumors where hypopituitarism is common. And also a high degree of suspicion should be maintained for these secondary causes, especially where the presentation is very unusual. Thank you.
Thank you.
Thank you, Doctor. It was a wonderful walkthrough to the other types of diabetes. It was really good. You've made it more interesting by presenting your cases. It's wonderful. I think we do not have much time to ask questions, but please wait, Doctor. At the end of the session, we'll be probably having more questions to you.
Yes.
Yeah. Thank you.
We move on to the third speaker, very eminent speaker, Dr. Archana Sarda. She is a consultant diabetologist and a director of the Sarda Center for Diabetes and Self-Care, Aurangabad. And she is doing really outstanding work for type 1 diabetes since many years. She's a founder of UDAN. And UDAN is an NGO for underprivileged children with diabetes, currently supporting more than 1,000 children. Hello. And I have seen the videos of how she conducts camps and even rappelling this for type 1 diabetes patients and really peps them up. And each of these patients help the other patients. And it's really commendable. She's a convener of the National RSSDI Type 1 Task Force. She has 20 years of work in innovative diabetes care in rural and rural setting. And she's a co-author ISPAR guidelines in the limited setting in 2002. May I invite Dr. Archana Sarda? She'll be speaking on type 1 diabetes in India, challenges and solutions.
Thank you so much, Penny ma'am. Thank you. Thank you, Dr. Shalini and Dr. Ajit for having me here. Hello, Dr. Roderick. So it's really nice to be in a type 1 symposium, as always. So I will just share my slide. Where has it got? Just give me 1 second. It was ready and suddenly it's... Okay. Is it visible?
Yes.
Yes. So after the two very, very inspiring knowledge-based talks, which made me wonder about the inadequacy of care in type 1 diabetes, actually, because when we are looking at prevention, we are looking at newer drugs, then we are looking at diagnosis beyond type 1 diabetes. I think it is very apt that we end this session with talking about at ground level what is happening in India and what role can we play when we are trying to take care of our children, our youth, and now lots of adults with type 1 diabetes. So far, for so many years, it was not a very big issue in various conferences because all the adult physicians did not see that many people with type 1 diabetes. This was mainly thought to be with the pediatricians. But now, when the survival is good, the facilities are more, we have so many adult patients and we have to be there for our people with type 1 diabetes. So what is our goal of therapy if we see, and then where do we stand in India? So the goal cannot be just, as we always say, glucocentric of having a normal blood sugar level. The goal in India for the entire type 1 community is to have access to a positive ecosystem. And that ecosystem is of medical care as well as psychosocial support, because these are children who are growing up, becoming adults, and becoming very productive members of the society. And hence, it has to be a comprehensive system. Surely, it's not too much to ask for in a country which is so rich to say. I mean, there are many Indias in India, but it is rich in terms of culture and money and medical science. So why is it so difficult? And that is what we are going to talk about. So broad components of type 1 care, this is like very, very broad components, is early diagnosis. And that is what we were talking earlier than even the symptoms, as was taken by Dr. Dan, which makes so much sense. That would be wonderful, because even now children are actually detected in DKA in the rural setting or even in the urban setting, which means coming to the next point is the awareness. Awareness amongst doctors, awareness amongst people, amongst the healthcare providers, then access to qualified healthcare. There is still, healthcare may be there at various PHCs, but is there access to people who understand type 1 diabetes? Still in rest of hospitals, if a surgery is happening, people will keep a person NBM overnight in a person with type 1 diabetes and stop the insulin, and that happens every other day. So we really have to have qualified healthcare with knowledge of type 1 diabetes. And then continuous and affordable insulin and monitoring is still a basic need, which is not yet fulfilled in India. And self-management via structured education and technology. So if we look at all these components, where are we today in India? till now, we did not have numbers. Something very exciting happened this year, and this is T1D index, and that can be, you can see it on that site. And this is a type 1 diabetes index created by International JDRF, by LFAC, Life for a Child program, IDF. So all people who are committed to type 1 diabetes actually got together and did a lot of research. They did questionnaires from more than 800 setups across the globe. All the studies and analysis gave them a way of having an index, of actually assessing what is happening in each area, especially in a country like India where we don't have an index. So what is the current fact sheet for India? So current state of in 2022, the number of people living with type 1 diabetes in India is 860,420 as per the current measurement number. But the number of missing people due to type 1 diabetes in this year are 9 lakh plus. So average number of healthy years that are lost, if you assume diagnosis at 10, is 1 to 2 years. But loss to treatment and care is 4.4 years. Loss to complications is whopping 39 years, because life expectancy is shortened by 39 years. And remaining healthy years, which life, if diagnosed at 10 years, is only 28.7 years after diagnosis. So this reduction of almost 39 years of a potential life is happening in 2022 in a country like India. And that is why these numbers, why we were very happy when the index came, the type 1 diabetes index came, because this is something we can tell the policymakers now, where we can create a lot of movement, where we do not have great numbers to show. And that is something which is actually quite scary if you look at it. So if you look at the growth, today the population is growing at 6.7% per year. And if you compare to the general population growth, which is at 1.2% per year. So this is a very rapid growth, and expected number of people by 2040 in India is likely to be 1.8 million. And still, how many missing is 1.6 million are expected. So that is the gap that we need to fill in India. So if we can diagnose people in time, currently 1 out of 6 is lost simply because of late diagnosis. Number of deaths due to non-diagnosis is 7,610 in 2022. Healthy years which would have been restored per person if the diagnosis had been on time would have been 3 years. A number of additional people who would have been alive by 2040 is 1,23,000. So these are all statistical numbers by analysis, but they have been cross-verified, checked, validated, and so many things match. So I won't go into numbers again, but just enough to say that if we had timely diagnosis, insulin and strips, that's all we're talking about. And of course, the quality of life and better control happens with pumps and CGMS. That also has been shown. So this is all that we could do. And very simple number like hours of healthy life restored by 1 strip. 1 extra strip gives 3.5 hours of more life. 1 testing, 1 decision making because of a good glucose strip. So this is a huge way, a benchmarking that can be done, numbers that can be used to shake the policymakers, the availability and the accessibility of care in India. Because in India, we have so many Indias. A given for some is an aspiration for others. So saying it emotionally, passionately is not enough. To change the policies, to bring it into action, we need a lot of numbers and studies. And with the type 1 diabetes index, we have that today, which is great. So if you look at all the components that we talked about, from awareness to access to care to education, each is a challenge by itself in India. Because in some places, everything would be available. State of art would be available. Some places, nothing would be available. But if you look at the entire Indian population, we are the largest number of people with type 1 diabetes in the world today, simply by virtue of our population. Although our incidence prevalence won't be that high. So look at the problems, and I have just taken the liberty of going through it from my perspective of the experience of 20 years and what can we do. So the problem here is awareness and early diagnosis. We were talking about early diagnosis. Here, I'm talking about early, not is that early. I'm not even talking about stage 1, 2, 3, A, B, C. I'm just talking about even after symptoms have appeared. That is the time also that often There is still not a suspicion of index of type 1 diabetes today. So illiteracy, social myths, lack of dialogue, the GP, the first doctor that a patient goes to, is unaware. So what can we do to have early diagnosis and awareness at a local level? All of us can have a lot of advocacy programs. We can have newspaper articles, radio talks, specialists, make as much noise as we can. We can involve NGOs. In the entire country, beautifully, the type 1 scenario has risen in last 10, 15 years. There are wonderful NGOs across the country run by people with type 1 diabetes, by doctors, by parents association. So let's involve them and make a lot of noise. Then T1D leaders and celebrities have to come out and talk about it. And at the grassroots level, the last doctor has to be made aware, because that is where the diagnosis is missed. That is where the child is not referred. That is where they'll end up in DKA as the diagnosis in a peripheral referral hospital. So that is a scenario we wish to change. At a national level, we can have a structured advocacy program that goes to the last mile. We can have a very targeted GP and public awareness program. We can use the national media to disseminate information, but it will take a lot of political will. And that is why those numbers will be very important when we can present it to the political leaders. We can make ASHA and Anganwadi workers very aware. They are doing an amazing job in so many fields, and this could be one field where we could actually empower them. So this advocacy by the children, for the children, is going to come a long way. Another aspect which is very important is qualified HCP. Now we know it's very difficult. It's a very specialized case. I, being an adult physician, I have to study so much to take care of children. And I always feel I am missing somewhere. When I was looking at all these different kind of diabetes, I was wondering how many children have I missed what? So every day it is a challenge, yet at least the basic updating has to be there. We are not updated in the current guidelines. So it's very important, and I'm very thankful to all conferences in India to now showcase type 1 as we are doing today. But we need more CMEs. We need local bodies to create guidelines. We have Indian guidelines through CMRE, and I talked about the ISPAT guidelines. Those are there. So, but we need the local bodies to actually talk a lot about them, to all the pediatricians initially and physicians as well today, because this is not a topic which is taken in local CMEs. It's always there in the national, international forums, but it's not really a big topic because average doctor has 1 or 2 patients. But that now the time is changing, and hence it's very, very important. Again, pharma support to reach the doctors can be taken at a national level, like RSSCI is doing, creating centers of excellence, created certified courses. There's so many of them, but how do we motivate them? How do we motivate doctors who are not treating a lot of type 1 diabetes to learn? That is a big task. So it's very important. Training is a very important process. And of course, no matter how much we know, if we cannot provide insulin and monitoring devices, we fall short. And most of the doctors I meet, all the healthcare providers finally say the patient cannot afford it. But today, let us not compromise. It is not the era of premix insulin. Please go through the limited resource guidelines in ISPAT, which has come out for the first time. And I was very happy to be part of it. And we are absolutely saying no premix, except as a life-saving step initially, till you can move on to a basal bolus, right? Glucometer strips are expensive. CGMS pump is very expensive, but scenario has changed. There are so many support groups. Life for a Child is working in India. RSSTI is supporting. Pharma groups are supporting. You reach out to any NGO, for example, UDAN. You reach out to me. I will find a way to get insulin to your children wherever they are. So there are ways in the country that has changed from the last 10 years. The scenario has changed. Let us reach out, and everyone should be on a basal bolus regime at least. And at a national level, the school health program and NCD clinics will make a big difference. The good news is, which is going to come in March, because I was talking to Dr. Sujoy Ghosh from Kolkata, and he's on that panel, and they have in writing accepted that juvenile, they call it juvenile diabetes still, as a part of NCD program. So maybe what we have been fighting for last 20 years, maybe in coming March, we will find that it is a part of the school health program and NCD as the government, central government has promised. And if that happens, then maybe from March to 2023, we will see a new light where we will have insulins and glucometers, the best of them available at all PHCs also, because it will come to the national non-communicable disease program. So that was a dream, and it seems it is going to get true. And this is something we should know and look out for. So medical supplies do matter. That is how these children will get a smile and survive. And last but not least is the self-management and structured education. Now, problems is how do you educate? Where is the time? We don't have that many educators, but we have people also don't want to come and learn. So I, for example, teach my children. I have more than 1,000. We teach them, but with the greediness of giving them insulin. I'm sure they don't come for learning initially. They come for free insulin. But in the garb of that, they are given good structured education, and that gradually empowers them, and then it becomes a focus. So that process has to set in. If we do not have diabetes educators, we can create our own training program. As I always talk about, in our area, we do not have any. So we created moms who became from D moms to D coach, and now they are diabetes coaches. But there are so many certified educator courses in the country today. RSSDI runs this, TFSI runs this, so many of them. So let us focus on these courses and ask people to join them, but they will join them only if they get employment. So all of us as diabetologists, if we give employment to a diabetes educator, only then people will go for these courses and actually work, because ultimately they have to earn their livelihood. We should have a resource library, which currently RSSDI has, and all international organizations have, but more Indian. Such a library will help us to remain updated. I believe everyone can learn. The most rural, the more illiterate, the more maybe special learning skills, but it's up to us to find a way to teach them. For example, I just wanted to share with a smile, this is little Shraddha. She's in a remote village and she lives in a tin roof and 6x6 room, but she can actually count carbs and balance her plate. When she eats, she knows her macros and micros and she can take care of. So it's up to us. If we really emphasize, every single person can learn. Another very important aspect which has changed in the country and come up is a lot of peer support groups and 24/7 helplines. So peer support groups are there, but if you are working in type 1 space, do try to give everyone with type 1 diabetes a 24/7 helpline support, whether it is for medical management or just sheer desperation. A number where they can reach out to is something that goes a long way in taking care of people with type 1 diabetes. So to every challenge, there is a solution. We are in a country where we are talking about the pump. We have CGMS, which ideally is best for people in the rural areas. So once we have it in the national program, the technology should go to the least affording people because they need it most. That is where they are not able to cope on their own, or from a simple earthen pot where they still do not have electricity, and hence they have to store their insulin in a pot like this. So solutions are there. And I refer back to type 1 diabetes index before I conclude. This is very, very interesting that all of us as physicians, so what is my thought when I'm talking about India challenges and solutions? If all of us move to intermediate care, by intermediate care, we mean it's not very expensive. It's a few hundred rupees more only. But let us not give minimal care. Let us not give a premix insulin and one odd monitoring and one odd visit once in a while, and the child survives for 30 years and then dies with complication. Let's just move from minimal model to intermediate care, and that gives a child a good 20 to 30 years of extra life. So if we give 100% access to insulin, we give them test strips and support them with self-management education, we can save approximately 5 lakh lives in our own country by 2040. I think that's a beautiful mission. And now we have it in numbers, we have it in targets. And as I said, 3.5 hours by one single strip. I love that type 1 diabetes index, kind of a statement, because it immediately strikes home. That is what a simple thing can do. So if we always thought, when I started, I was always lost with the guidelines because I felt I can't do what the guidelines are saying. And I always felt inadequate when I was treating type 1 diabetes because I felt, I need a pump, I need a CGMS, I need this many monitoring, I need the best of insulins. But then it's very important that even in the lowest resource setting, that we do not go for the minimal model, but go for at least an intermediate model. And these are guidelines that are just coming up very soon. They'll be there and they're already up for observation on the ISPAD page. And this is something for wherever we do not have resources, which could guide us to take care of our children in an optimized manner. So I just would like to share this picture before I end. Those are the children in 2007. Okay, the date has gone, it was there. And these are the same children 3 years back in the World Diabetes Day program. So these come from remotest of villages, right? But what a good insulin continuous supply, what monitoring and education can do is what we saw observed in the T20 index output, is that you can add life, you can add quality of life and survival. And that is something we are aiming for. Thank you so much.
Thank you so much, Dr. Archana. I think you have given us realistic information, and it is an eye-opener that we are the largest nation of type 1 diabetic children in the world on account of our numbers. And there are so many challenges, not only in the rural area, but also in city. For example, I find a transition phase from a pediatrician to a physician very challenging. You know, they are used to one doctor, they are used to one setup, and then they come to adult diabetologist and they say, no, they want to go back. It is a huge challenge. How do you cope with this?
I, being an adult physician, I have now metamorphosed myself into a pediatrician also. But the coping has to be with education. When there is a structure in place, when we are tuned, when we are speaking the same language, the whole stark difference is because physicians and pediatricians are not speaking the same language today. When this whole process is with consensus, with guidelines, then it becomes really smooth. It is not difficult at all. But that difference has to be covered by us. It is our job as clinicians to be able to do that.
Wonderful. Thank you. Dr. Colin is here. Nice to see you, sir. So I was really impressed with your lecture. And there's a lot of basic science in that, half of which I think we have not understood too well. But one thing that impressed me markedly was the drug verapamil. I mean, it would be a wonderful thing to use verapamil, maybe to reduce the immunity. I just want to know more about the drug verapamil, and can we manage this drug in the management of our type 1 diabetes patients, sir?
Yeah, thank you very much, Benny. And I also feel very humbled by Archana's talk. Here am I talking about very expensive medicines, and there she's talking about saving millions of lives. So we have to always balance these two things, don't we? But in a way, what you've picked up is there a simple solution? Is there an easier solution? Verapamil clearly would not be an expensive medication. It's a very inexpensive medication. It's made by generics companies. So there's only really been one study that suggests that it protects beta cell function. And we're very actively running another. So we're over 1/3 of the way through recruitment in adults. And then there needs to be a pediatric study. But just to emphasize, the idea is that it would slow the loss of insulin production at diagnosis. So it might still be something you would take when you're diagnosed if you still have some insulin production. And then it would make it, the honeymoon, if you like, last a little bit longer. For a few more years, it would be a little easier. Then eventually, when you can, in health systems, screen and detect people early, you could use it to delay when you need insulin. So I agree with you. I think finding less expensive solutions would be very exciting.
Thank you, sir.
May I ask Dr. Colin a question?
Sure.
Yes.
So I just wanted to know, would it really benefit, in children, siblings, to do the screening as you showed? The only thing we can achieve currently is maybe prevent DKA, as was shown by you. But in a country like India, do you think that's worth it? That's something we can invest in and go forward trying to do that?
Well, I think that's, you have to answer that question, Archana, because you understand the numbers a bit better. What we are trying to work towards is reducing the cost. And I think if India gets involved, they're very good at reducing costs of things. So the cost of the screening tests, can we do it much more cost effectively? Currently, it's often charging between $20 and $50 for a screening test. So, and it can be done on a finger prick. You can send it off. You don't have to It's done on dry blood spots. So you don't have to have a facility right next to you. So it does reduce the incidence of decay, as you say, quite dramatically. In siblings, the effect is not usually so big because the family sees it coming. But as I mentioned in my talk, 90% of cases don't come from families. They don't know what's happening, and they misunderstand it. And as you say, in healthcare situations where there's not much support, it can be fatal because then they actually die from diabetic ketoacidosis. So there will come a point, I think, when you make that a little bit cheaper. And then if there was an inexpensive way of intervening, then that would be very helpful, because that would be maybe a year or two that they didn't need insulin at all. And then the advantage becomes much greater. So many people are saying wait until there's an intervention. Obviously, it needs to be a cost-effective intervention. I should just emphasize that verapamil has not been tried in prevention, only in new onset, but as Benny says, it's very attractive to do that.
Yeah, Dr. Anshul, I have a question for you. You have elaborated all the secondary causes of diabetes,
Yes,
but what is most commonly seen in our practice is thyroid and diabetes. And if you have diabetes, I think thyroid is inevitable in later years. So I just want to know whether diabetic therapy can interfere with the thyroid function test or actually give rise to thyroid in later years. And on the contrary, that is vice versa. If we are taking anti-thyroid medication, and if the dose is too large, you do see many patients who are taking a larger than necessary dose. Does it disturb the glycemia and we label it as type 2 diabetes?
Thank you, ma'am. Thank you for the question. So, ma'am, like you said, yes, type 2 diabetes, both type 2 and type 1, in fact, have an increased association with thyroid dysfunctions. Like I've also mentioned, that patients who have type 2 diabetes, if we are talking about hyperthyroidism, there is roughly a 4.4% incidence as compared to the general population. Now, as far as the treatment is concerned, yes, if there is an overdosage which is happening in patients who are hypothyroid, there is dysglycemia which is associated. All the symptomology that comes from it is similar to
Yes, sir. Yes. Yeah.
To a patient who has hyperthyroidism rather. So same insulin, increased insulin resistance, increased free fatty acids, increased lipolysis, increased insulin resistance, and decreased secretion. All of this contributes to hyperglycemia in a patient who is being overtreated for hypothyroidism. And with type 1, obviously, we have the autoimmune polyendocrine syndromes where there is an association, and all type 1 diabetics, of course, will need to be screened for hypothyroidism as well.
Thank you. Thank you so much.
Can I just
thank you, everyone. I think we'll have to wind up because we're already running a little late. So thank you, Dr. Colin, Dr. Benny ma'am, Archana, Dr. Lily, Dr. Anshul. Those were excellent deliberations, and I'm sure a lot still needs to be done. But yes, we're taking baby steps, and I'm sure we do have a bright future. And with people like Dr. Archana at it, I'm sure type 1s in our country do have a lot of hope.
Thank you, Professor Colin, for being there. Thanks a lot. Thanks,
excellent sessions. Thank you so
Lily,
much.
Dr. Benny, Dr. Anshul.
Thank you, sir. Thank you.
Thank you.
Thank
you so much.
Thank you, sir.
Thank you.
We now move on to another very, very important symposium, something very close to our hearts, and all my friends are here.
Yes.
So we move on to the symposium on diabetes in women, and I'm sure any meeting that I am in cannot go without this very important symposium. So to chair this important symposium, we do have Dr. Archana, who has just spoken so passionately about all her work in type 1 diabetes, director at Sarda Center for Diabetes and Self-Care, Aurangabad, and my very close friend, good friend, Ami Sangvi from Mumbai, director and consultant diabetologist at Sangvi Eye and Diabetes Care Center, Mumbai. So welcome, Ami, and it's all yours.
So a very good evening to everyone present here. Archana ma'am, would you like to start with the case as we discussed, ma'am?
We will do that after the talk.
Okay. So we start with the first lecture of this session by none other than Dr. Benny Neglu, someone who has always been an inspirational figure. So ma'am is the director at Neglu's Diabetes and Thyroid Specialty Center. She's a consultant diabetologist at Jupiter Hospital, teaching faculty for fellowship in diabetes at DY Patil and Public Health Foundation of India. She's a founder and executive committee member of the Association of Diabetes Educators. She's been the founder, president, and organizing chairperson of WordCon Women in Diabetes Conference, a very successful conference since last 5 years. Speaker at various national and international conferences and fora in diabetes. Scientific chairperson of RSSDI Maharashtra's chapter. Okay, so ma'am is going to be speaking on the journey from PCOS to GDM to diabetes, and we are really looking forward to hear you, ma'am. Over to you, ma'am.
Thank you so much, Abhi. I'll just share my screen. What is this? I think there's some problem.
Can you try again, ma'am?
Yeah, I'll just try.
Some problem?
Yeah. No. Is it seen now?
No, ma'am, not yet.
Oh God.
Maybe you need to unshare and reshare again.
I'll just log out and log in again.
Yeah, please.
Can you
please.
go on to the next speaker so we don't waste time, and I'll come back as the second speaker.
Okay, no, ma'am, no problem.
Yeah.
So,
yes,
that's okay. It's me only.
So our next speaker is none other than Dr. Shalini Jaggi, and we know her very, very well, and her smiling face and brains, so beauty and brains together for preconception planning and care. I've heard her before. I'm really looking forward to it. Over to you, Dr. Shalini.
Thank you so much, Dr. Archana, for those beautiful words. Mahima, can you stop sharing so that I can share my slides? Yeah. Okay. So I chose this topic because I think this is something which has become very, very important whenever we're talking of diabetes management. Let me just put this in screen share mode. Yeah. So we all talk about diabetes management and diabetes prevention. I think everything starts right from preconception, and that is why it's become very, very important because, you know, we have so many people, the burden of diabetes is increasing, the burden of hyperglycemia in pregnancy is increasing, and diabetes keeps going and on. And now we're talking even in terms of primordial prevention, which means catching them even before they conceive, because that is where the gestational programming for diabetes can be stopped, and probably you can make an attempt to actually prevent the occurrence of diabetes altogether. So if you look at the IDF statistics, the hyperglycemia in pregnancy prevalence just going up all across the world, anything between 15 to 16%, and Southeast Asia, unfortunately, leading the bandwagon all across the world, 25 to 28% hyperglycemia in pregnancy, which translates into 1 in 4 live births in the IDF Southeast Asian region being affected by hyperglycemia in pregnancy. Now, the WHO and FIGO have actually tried to classify HIP into 3 categories: pre-gestational diabetes, gestational diabetes, and diabetes in pregnancy. Now, pre-gestational diabetes, of course, is any woman who's already been diagnosed with type 1, type 2, or any of the other forms of diabetes before she gets pregnant. Gestational diabetes is a diagnosis of diabetes occurring anytime during the antenatal period and is not expected to persist postpartum, while diabetes in pregnancy actually applies to pregnant women with hyperglycemia who were first diagnosed during pregnancy, but they meet the WHO criteria of diabetes in the non-pregnant state. That means overt diagnostic values. So DIP is essentially best detected in the first trimester.
So if you look at the numbers, the total live births to women in the reproductive age group in millions, you can clearly see 80% of them may be gestational diabetes, but then there's a proportion of 20%, almost half each, half being a proportion of cases because who have diabetes that is first detected in pregnancy, the DIP group that I just described, while remaining 10.6% are the pre-gestational diabetics. And like you can see here, these days, women get married little later, have children little later, and this is a global phenomenon where you see that the prevalence of hyperglycemia in pregnancy based on age groups, as the age progresses, the prevalence keeps going up. Now, why this becomes significant is because of all these complications that they can land up in. So if it is early pregnancy, the congenital malformations, neural tube defects, anencephaly, microcephaly, sacral agenesis, which is most pathognomic, besides a higher incidence of stillbirths, and then later pregnancy, there is hyperglycemia, polyhydramnios, fetal macrosomia, difficult labor, neonatal hypoglycemia, asphyxia, and hyperbilirubinemia. And for the mother, again, an increased incidence of miscarriages in early pregnancy, or as the pregnancy progresses, hyperglycemia again increases the chances of preeclampsia, preterm labor, difficult labor, assisted delivery, cesarean sections, and in type 1, especially acute metabolic complications such as DKA or worsening of pre-existing microvascular complications, both retinopathy, proteinuria, and edema. So this is something which is very, very important. Even before the lady knows she's pregnant, that is the time organogenesis has already started. So the first 8 weeks are very, very crucial, because by the time it is 8 weeks of pregnancy, as you can see here, the heart, the upper limbs, the lower limbs, most of the organs are already formed or almost on the way of complete formation. So major morphological abnormalities can occur as early as 4 to 6 to 8 weeks of pregnancy. Now, this is a timeline of the congenital malformations, clearly showing you that at 4 weeks, spina bifida, anencephalus, and caudal regression may have already occurred. And that is the reason why you need to aim for tight glycemic control just before she plans pregnancy, rather than intensifying glycemic control once she has become pregnant. So the idea is to aim for an HbA1c of less than 6.5%, along with, of course, folic acid supplementation to reduce the risk of congenital malformations that I just described. And that is why we see that for each 1% increment in HbA1c beyond 7%, you clearly see that the odds of a pregnancy being affected by congenital anomalies increase by almost 30%, underlining the fact that glycemic control preconception is very, very crucial. The fetal origin of adult diseases given by David Barker again talks of intrauterine programming, the gestational programming, wherein a stimulus like hyperglycemia or any stress occurring at a critical or sensitive period in fetal development can permanently change the structure, physiology, and metabolism, predisposing these individuals to diseases in adult life. And that is why Norbert Frenkel actually talked of the fuel-mediated teratogenicity, wherein he talks of targeting interventions early in pregnancy, going beyond glucose that may be critical to improve the fetal growth patterns and stop this NCD pandemic that we are all facing. As the woman gets pregnant and as pregnancy proceeds, we know in the second and third trimester, there is a progressive increase in insulin resistance that happens in ladies with type 2 diabetes. And the diabetogenic stress of these placental hormones worsens glycemia, not only resulting in adverse maternal and fetal consequences, a rapid increase in insulin requirement for ladies who are already on insulin, as well as potentiates a worsening of complications. And that is why screening for complications preconception becomes very, very important. So this is CMAC data clearly showing that if a mother already has type 1 or type 2 diabetes, you can clearly see the relative risk for malformations, preterm deliveries, LGA, perinatal mortality, all going up multifold. So why we are discussing this is because of all these complications, and we've seen that especially when it comes to babies born to mothers with type 1 diabetes, they have significantly higher rates of being large for gestational age, as well as being born with macrosomia and neonatal hypoglycemia, which again is important in women with type 2 diabetes, especially an increased incidence of difficult births, preeclampsia, preterm births, induction of labor, cesarean sections, and delivery complications. Therefore, friends, pre-pregnancy planning with optimization of glycemic control before conception, all through gestation and then postpartum has to be very, very importantly reinforced to reduce all these risks. Now, this is a paper that actually looks at the LGA neonates in type 1 diabetes and pregnancy and looks at factors beyond hyperglycemia and clearly talks of the modifiable factors that can probably improve outcomes. So something as simple as maintaining good glycemic control, targeting an HbA1c of less than 6.5 preconception, and then throughout pregnancy, if possible, to maintain it at 6% or less, reducing glycemic variability, losing weight even before pregnancy is planned to achieve a BMI of less than 25, which does have a moderate incidence, which has a moderate relationship to the outcomes. Gestational weight gain has to be minimized, and maternal lipid levels, even before she conceives, have to be very, very standard. So preconception counseling and care, in simple words, refers to the information, care, and advice to women with diabetes who are planning to become pregnant, has to start from adolescence and has to be ongoing at every visit. You need to reinforce the dangers of an unplanned, of an accidental pregnancy, which are in our part of the world is very, very common. So it's important to optimize glycemic control and explain that the risks can be reduced but may not be completely eliminated. That's very, very important. So talk about the risk when she's planning a pregnancy. Talk to her about all the dangers that can happen if it is an unplanned pregnancy. And it does not mean only women with diabetes, but also in men with diabetes. Poorly managed blood glucose can impact erectile function, sperm count, and sperm health and should be addressed. During the preconception counseling process, you need to talk about the risk behaviors and exposures that can impact the fetal development. You need to identify them and change them. There has been a positive association between the appropriate preconception counseling and maternal behavior change, which ultimately translates into reduced adverse outcomes of pregnancy. Even when it comes to mothers with type 1 diabetes, it's important that you talk about the risk. So, for example, if the father has type 1 diabetes, there is a 1 in 17 chance of still getting type 1 diabetes. For a mother with type 1 diabetes, if she's planning the pregnancy at an age which is less than 25 years, there's still a 1 in 25 chance. But if the pregnancy is planned at a later age beyond 25, the chance reduces. So it's 1 in 100. Unfortunately, if both the parents are type 1 diabetic, the chances of the baby getting type 1 diabetes becomes very high, almost 1 in 4. So what are the components of preconception counseling? Of course, like I said, you need to talk about the importance of tight glycemic control and reinforce this at each visit because it's pertinent to avoid an unplanned pregnancy. Ideally, try and achieve an A1C target of less than 6.5% to reduce the risk of congenital anomalies, preeclampsia, macrosomia, and all the other complications that I talked of. Of course, contraception has to be advised till good glycemic control is achieved. And also you should tell them when to stop contraception, of course. And the choice, of course, is based on their own choice and the cultural and the ethnic choices. A structured diabetes education through a diabetes care team, which is individualized to that particular lady, her individualized diet advice, exercise advice is very, very important all throughout. Women who are overweight or obese, they should be offered a chance to lose weight in line with current recommendations before they plan the pregnancy, because we know the adverse outcomes that can happen in obese women who get pregnant. And of course, a review of possible changes to the medications that she may be on is very, very important besides optimizing glycemic control. So this is exactly what the ADA guidelines also say. The multidisciplinary approach that's required, it has to be a teamwork between the diabetes specialist, the maternal-fetal medicine specialist, the obstetrician, the registered nutritionist, the diabetes educator, where all available. So the focus has to be multi-pronged. Like I said, talk about the weight management, talk about the contraceptive advice. Screening for complications becomes very, very easy. The need for assessing diabetic retinopathy, because we know there can be a worsening of background retinopathy in pregnancy. Screening for nephropathy is very important for ladies who have long-standing diabetes. Talk about how nausea and vomiting and change in appetite in pregnancy can affect blood glucose control and how they need to talk about the glucose targets, the glucose monitoring that's required, the medicines that may need to be altered, complications need to be addressed, the temporary health problems that may
the baby may develop in the neonatal period, which may require admission to a neonatal unit, as well as the risk of the baby developing obesity or diabetes in later life if glucose control is not maintained well throughout pregnancy. So it's very, very important that we give some more time to our patients and put in some more efforts to manage diabetes during pregnancy. She has to be in regular touch with the HCPs and the whole team. So moving on to the targets preconception, very, very important. Like I said, an HbA1c of less than 6.5%, if this is achievable without causing too much of hypoglycemia, which means a fasting plasma glucose, anything between 80 to 130, ideally between 90 to 120, and a peak postprandial less than 180 which is there in non-pregnant adult, and strongly advise women whose A1C levels are beyond 10% not to get pregnant because of the multifold increase in risk of congenital anomalies that may happen. So this was the retinopathy screening that I was talking of, a dilated eye exam, which should ideally occur before pregnancy or in the first trimester. And then she needs to be monitored every trimester as well as 1 year postpartum based on the degree of retinopathy that is detected. Again, a complete renal assessment before she stops contraception is very, very important. Starting folic acid until 12 weeks of gestation is very, very important to prevent the neural tube defect in the baby. Very important tool is SMBG. So you need to motivate your patient to do frequent SMBG. If it is somebody with type 1 diabetes, of course, ketone testing strips should be made available to her, and she should be asked to check for ketosis, especially when she is hyperglycemic or unwell, because then there is an increased risk of getting into ketosis. Standard care involving screening for STDs, thyroid disease, hypertension screening, vaccinations, routine genetic screening, everything is important. Now, again, somebody who's got type 1 diabetes or even type 2 diabetes, if the duration of diabetes is more than 10 years or there is coexisting hypertension or dyslipidemia, it's important to screen even for heart disease. So this is where, especially in ladies who are more than 35 years of age, these days we have a lot of IVF-assisted pregnancies coming in where the ladies are beyond 35 years of age. So a simple resting ECG may be all that you need. Or if somebody who's already got diabetes more than 10 and is at a high risk for CVD, suppose you picked up a carotid bruit for her, a simple stress ECG or echo can help in picking up heart disease as well. So this is the checklist that the ADA for the first time has actually come out with in the 2021 Standards of Medical Care, wherein they talk about an appropriate nutritional assessment and recommendations. They talk about stopping coffee, caffeine intake needs to be restricted, lifestyle recommendations in terms of getting adequate sleep, which is very, very important, besides moderate exercise, a comprehensive diabetes self-management education strategy, then all the different things that I talked about, the complication screening, inform her about the risks, supplementation with folic acid, use of over-the-counter medications that needs to be discouraged. Again, medical assessment and plan, wherein you do a general evaluation of her overall health, look for comorbidities, screen for complications, evaluate all the things that are required. And then screening for women who are at high risk for anemia, genetic diseases, infectious diseases, besides immunization and preconception plan should have nutrition and medication plan as well. So it's not only the medicines that you need to look at, but her nutrition and her exercise. So when it comes to the medicines, of course, for a woman with type 1 diabetes, we all know it has to be insulin all the way. She's most likely on an MDI or a CSI, so that has to be continued. But for somebody who's got type 2 diabetes, remember, most of the oral drugs do not have data on when it comes to safety, except, of course, metformin, where, again, long-term safety data is lacking. So I think it's best that before even she plans pregnancy, right in the preconception time, she is converted to insulin, a substitution with insulin, so that when she conceives, it's very easy to transition and then continue and increase the doses of insulin. So it's very important that you take her on insulin, convince her to start insulin so that it becomes easy to up-titrate the doses later once she's pregnant. Of course, teratogenic medications such as statins need to be stopped. ACE inhibitors and ARBs, if she's on any of these, need to be stopped, and maybe you can give her some alternatives like methyldopa or labetalol for her hypertension. Review all the other medications that she's taken. Again, it's important these days. Smoking, alcohol in women is very, very common. So you need to review and counsel them on use of recreational drugs as well as smoking and alcohol, which may be detrimental during pregnancy.
Again, folic acid supplementation, as well as low dose aspirin at 12 to 16 weeks of gestation to lower the reduce of preeclampsia is very, very important. Insulin, I think all of us know, very, very safe in pregnancy. Most of the analogs, Aspart and Lispro, are approved. Of course, glulisine has limited data. When it comes to the human insulins, I think all of them are safe, be it regular, be it NPH. And of course, analogs have shown to be faster, predictable, and giving less hypo. So maybe this is something that we prefer. When it comes to whether it is a pump or multiple daily insulin injections, I think both of them are reasonable strategies, and not one is superior over the other. So depends on the convenience of the patient. Somebody who needs a basal insulin, especially if it is a type 1 or even a type 2, we know that insulin detamir as a basal insulin is approved for use in pregnancy. But now there's sufficient data that shows that glargine is also safe in pregnancy. So if it is somebody who's got type 1 diabetes who is already doing well on glargine, there's no reason why you need to stop glargine and put her on detamir. So it can be continued. And I think in the current IDF, Dr. Rutul and I, we presenting a paper where we actually used U300 glargine for women with pre-existing type 2 diabetes. And we did not really see any adverse outcomes. So glargine pretty safe in pregnancy. This is another review on glargine in pregnancy, clearly showing that glargine does not really cross placenta when used in therapeutic concentrations. And since you cannot really have RCTs in pregnancy, so this is a lot of safety data is still available. So it's important, friends, that optimal glycemic control preconception is necessary for better maternal fetal outcomes in all women with pre-GDM. Preconception care and planning forms an integral part of planning a pregnancy in women who have pre-existing diabetes, and therefore it's important to offer information, care, and advice to all these women with diabetes and even pre-diabetes or somebody who's already had gestational diabetes in the past. Because for her, most often we see that a woman who's had GDM turns pre-diabetic and then eventually turns diabetic even before she's planned the second, because before she gets pregnant the next time. So it's important to tell them about the impending risk of diabetes, and these are again women who need to be offered preconception advice. So preconception counseling has to start from adolescence and has to continue all through the reproductive period of a female's life. Discuss and advise contraception until good glycemic control is achieved, especially when she's planning pregnancy, and of course when to stop. Address the importance of glycemic management as close to normal as possible. Like I said, an A1C of less than 6.5 to reduce the risk of all these complications that I talked of. When it comes to retinopathy, if necessary, if you picked up PDR, I think it's important to photocoagulate even before she conceives. That's very, very important. Contraindications to pregnancy when it comes to somebody who's got coexisting diabetes are only ischemic heart disease, untreated proliferative retinopathy, and severe renal impairment. Besides this, I think if you can actually counsel her and handhold her, there's no reason why she cannot have a safe pregnancy. Explain the risk of diabetes in pregnancy and how to reduce them with good glycemic control. Review and possibly change medication, glycemic targets, and SMPG routine is very important. And this is where a structured diabetes education with a good diabetes care team is of utmost importance. So I think with that, I'll stop sharing and we can move on to our next session. Thank you.
Thank you, Dr. Shalini. That was very, very comprehensive. And we will take questions at the end. I will ask Dr. Benny to please take over with her topic, which was PCOS to GDM to diabetes.
Thank you, Archana. I'm just sharing the screen.
Visible.
Yeah, thank you. And I'm so sorry for that problem that happened. So sorry. So we'll go on to PCOS to GDM to type 2 diabetes. This is a continuum. As you can see, it starts with loading the gun where the genes are faulty or adverse. And then on top of that, you have an adverse lifestyle, increased calorie, decreased activity, giving rise to obesity, insulin resistance, early menarche, polycystic ovarian syndrome, and gestational diabetes, pre-diabetes, diabetes, and cardiovascular disease. So now we will start at the center of this continuum, which is inevitable if left untreated. Polycystic ovarian disease is a heterogeneous condition. It presents with reproductive, endocrine, metabolic, and psychosocial symptoms, and it has a huge impact on the quality of life. And there are two hormones that are key in the understanding of PCOS. One is androgen, and second is insulin, and how the body's response to its elevation can give rise to the signs and symptoms and this disorder. So we have studies in India. One was done in Mumbai. It was an OPD setting in 778 girls, including the USG, and they found that the prevalence of PCOS is 22.5 by the Rotterdam criteria and 10.7 by the Androgen Access Society criteria. Another study done by Ramnidhi and all shows that the prevalence of PCOS in Indian adolescent is 9.13. And this draws attention to the issue of early diagnosis in adolescent girls. The prevalence of PCOS worldwide is from anywhere between 5 to 15%. So how do we recognize this? When should we be alerted? It should be considered in any adolescent girl with hirsutism or treatment-resistant acne or menstrual irregularity or infertility or acanthosis nigricans. See, most of these patients actually do not come to us with all these symptoms. They go to the dermatologist, they go to the gynecologist, and they may come to us for evaluation of obesity. And when we see the signs of acanthosis, we have to find the signs and symptoms of PCOS, and diagnosing early will go in a long way in the management of these patients. What are the diagnostic criteria for PCOS? NIH in 1990, that was an old classification. We have the Rotterdam classification in 2003, where any 2 out of 3 of these should be present to make a diagnosis. One is chronic oligoanovulation, second is hyperandrogenism, and third is polycystic ovarian morphology changes. But in 2006, the Androgen Access Society has made it mandatory that we must see hyperandrogenism, and then out of the other 2, one is enough, along with hyperandrogenism, to make a diagnosis of PCOS. But at all times, we must exclude secondary causes like thyroid dysfunction, hyperprolactinemia, non-classic CAH, adrenal ovarian tumors, Cushing syndrome, or acromegaly. So here we have a picture of hyperandrogenism. You see acne there, which are resistant to treatment. You have thick, dark, terminal hair on the chest, chin, upper lip, abdomen, and thigh. And you can see the Ferriman-Galway score here, seen excess hair in all these regions. You have to have at least 8 positive to make an authentic diagnosis of hirsutism, and then a male pattern hair loss. All these are features of increased androgens. You might also see biochemically increased levels of androgens more than 6 to 86 nanograms per deciliter. And then what is oligoanovulation? It is less than 8 menstruations per year, or more than 2 cycles of less than 22 or more than 42 days per year. And polycystic ovarian morphology, 12 or more follicles, 2 to 9 millimeters per ovary, or an ovarian volume more than 10 ml in the absence of a dominant follicle. So you see, it is already a heritable disease. As I told you, 70% of PCOS is heritable. And in addition to that, there's a later on postnatal provocative hit in the form of insulin-resistant hyperinsulinemia, as occurs in metabolic syndrome, and postnatal obesity. And also puberty can be a hit. It is at this time that we start seeing the signs and symptoms of PCOS, and most of them who come to us are adolescent. What is the cause? What are the drivers? You see, it happens in various tissues. There's an increased GnRH pulse, which increases the LH pulse frequency from the pituitary gland, increasing the ratio of LH to FSH. And we know that low FSH will arrest the follicles in the follicular stage and will prevent ovulation from happening, will prevent the corpus luteum from forming, and that's what forms the follicles in the ovary. In the ovarian compartment, synthesis of androgens by ovary due to defect in the CYP17 gene, with defective aromatization of androgen to estrogen, and stimulation of the thicker cells by high LH and insulin-like growth factor. And adrenal compartment, there is secretion of androgens due to, again, defected CYP17 gene. Now, it can present throughout the lifespan, and we get patients at all ages. You might see a premature menarche, you might see an adolescent with PCOS, finally going into GDM, infertility, type 2 diabetes, or you might see them in the later years with cardiovascular disease or endometrial carcinoma. There is a link. There is a link between PCOS, insulin resistance, GDM, and type 2 diabetes. So on the one hand, there is a genetic predisposition to excess ovarian androgen secretion, giving rise to large polycystic ovaries. On the other hand, there is a genetic and dietary factors which influence insulin secretion or access, and then the influence on the pituitary. All these together, the insulin resistance and hyperinsulinemia, the increased LH levels, finally give rise to the symptoms of anovulation and hirsutism, secondary to increase in the testosterone levels. At the same time, hyperinsulinemia will also have its effect on the liver. It decreases the sex hormone binding globulin and therefore gives rise to free testosterone levels, which further aggravate hirsutism. And then there's an epidemiological link. So PCOD increases the risk of GDM by 200%. It increases the risk of type 2 diabetes by 1600%. Insulin resistance is present in almost 80 to 90% of the PCOD cases, and 60% of GDM patients develop type 2 diabetes. These do see insulin resistance in PCOS, and this was a study where they took obese PCOS patients and compared them with obese normal, and you can see the decrease, almost 40% decrease in the insulin sensitivity. And then they took normal obese PCOS patients and normal obese normal people, and you can still see a 30% decrease in the insulin sensitivity, suggesting that insulin resistance is present in PCOS. There's also the prevalence of diabetes in PCOS. PCOS women have an increased risk of glucose tolerance and type 2 diabetes. Even when we diagnose a PCOS, at least half of them will have impaired glucose tolerance, and at least 15% of them will have type 2 diabetes. So it is this hormonal imbalance that is aggravated by metabolic impairment that is a huge challenge for ovulation and fertility. And most of these patients go to the gynecologist, and you will see the rising incidence or prevalence of assisted fertility technologies that are required, because 85% of female infertility is secondary to PCOS, and that is really alarming. GDM is actually type 2 diabetes triggered by pregnancy. We know we have glucose intolerance that appears or is recognized for the first time during pregnancy is GDM. The two are closely associated. Insulin resistance is common to both GDM and type 2 diabetes. There is a nexus between the two. Women diagnosed with PCOS have a 2.4-fold increased odds of GDM, independent of age, race, ethnicity, and multiple gestation. You see the prevalence of GDM is so high. In India, it is 27.6%. 6.2 million live births are affected by hyperglycemia in pregnancy, of which 5.9 million are due to GDM. And this Tamil Nadu field study has shown that in the urban areas, the incidence of GDM is very high, 17.8%, compared to the semi-urban areas, 13.8%, and rural areas, 9.9%. Even in the rural areas, GDM is high. The thing is that GDM, PCOD, type 2 diabetes are all heritable. And if you see a family history of type 2 diabetes is a known risk factor for GDM. Girls born to PCOD mothers are at increased risk of PCOD in adulthood. And daughters and sisters of women with PCOD had high levels of adrenal and ovarian androgens from adolescent to adulthood. So not only that, GDM, PCOD, and type 2 diabetes have similar impact on the placenta, as you just heard from Shalini. There's villus immaturity, there's chorioagiosis, ischemia, there's villus necrosis, there are nucleated RBDs, all have an impact on the pregnancy. And this you can see a meta-analysis of pregnancy outcomes in women with PCOS. The incidence of gestational diabetes, preeclampsia, cesarean delivery, and prematurity are high. The odds ratio are more than 1. Even the NICU admission and the perinatal mortality are very high, the odds ratio being 2 and 3, which is pretty high. And also the implications of GDM have adverse maternal outcomes and adverse neonatal outcomes. Shalini just told you all this, so I'm not going to repeat. But what I want to highlight is that maternal diabetes has also been linked to offspring that develop obesity, diabetes, and also neurodegenerative and psychiatric diseases, as well as low intellectual and verbal coefficient, language problems, motor impairments, attention deficit syndrome, hyperactivity disorders, and lot of problems with psychosocial development, which we are going to see much later after they're born or even after they cross 5 years. And there's also a risk of type 2 diabetes and cardiovascular disease. It is difficult to nip GDM when it's developing. The later you diagnose it, the more are the rates of perinatal mortality, neonatal hypoglycemia, preterm deliveries. The earlier is the initiation of treatment, better are the outcomes. There are low rates of macrosomia, large for gestational age infants. As high as 80% of GDM patients have impaired OGTT right at the first trimester. And therefore, screening at the second trimester, we might miss out on our GDM patients. This is David Barker's Fetal and Infant Origins of Adult Disease. We know that underfeeding and overfeeding during pregnancy may lead to different pathophysiological mechanisms to insulin deficiency and type 2 diabetes in later life. Just take one scenario where when the mothers are overfed or there is hyperglycemia, the programming is for overproduction, fetal pancreas secretes higher than normal insulin. This leads to early beta cell exhaustion. And finally, in the children, when insulin requirement rises, pancreas fail to reciprocate. So you see type 2 diabetes and GDM in the offspring. On the other hand, underfed state where there's maternal starvation, you see there's programming for underproduction. The fetal pancreas produces less insulin. So the fetal pancreas production capacity gets compromised. And later on, when insulin requirement rises, the pancreas fails to reciprocate. So you get future type 2 diabetes and GDM. So type 2 diabetes is inevitable after GDM. There's a threefold increase risk of type 2 diabetes in the GDM mothers. The yearly conversion is 2 to 3%. There's also a risk of the metabolic syndrome in women with previous GDM 3 times adjusted for age and BMI. But importantly, the vasculature of women with a prior case of GDM is permanently altered. And this predisposes them to cardiovascular disease in later life. This is a WINGS database, and they wanted to see the amount of glucose intolerance over 1 year. And you'll be surprised that out of 5 women, 1 develops glucose intolerance within 1 year. This was done at the Chennai Research Diabetes Center along with the IDF. So in the first year itself, 20% women become type 2 diabetic. And further studies by Dr. Yagnik and Dr. Gatuvi have shown that Indians develop type 2 diabetes after developing pretty early compared to the Western counterparts, within 5 years. And that is very alarming. Even the Denmark study, where they looked at women 6 years after pregnancy of, who had GDM, you see 18% developed diabetes, 17% had pre-diabetes. And when they followed up these women 30 years later, a total of 19 years, only a third had normal glucose tolerance out of 151 participants. Another study of 330 women, 41 had diabetes, 26 had pre-diabetes. So you can see that type 2 diabetes is inevitable. And this is the risk of GDM in future pregnancies. So once a mother has diabetes, and if she has the next pregnancy, she has a 50% chance of getting GDM in the next pregnancy. Now, it's not only type 2 diabetes and GDM and these comorbidities. There are other comorbidities as well with PCOS, which are not talked about much. Obstructive sleep apnea is a complication of PCOS, non-alcoholic fatty liver disease, which is a forerunner of type 2 diabetes. When the type 2 diabetes is brought pretty early, it's a risk factor for heart disease. And then you have depression and anxiety, and we often tend to forget the psychological aspects of PCOS, and then endometrial carcinoma as well, besides the insulin resistance syndrome. And then, in short, I'm just going to show you 3 more slides on treatment methods. In PCOS treatment, this is a summary. Women who don't want to get pregnant and women who do want to get pregnant, we divide these. Those who don't want to get pregnant, combined oral contraception is the drug of choice. It helps treat menstrual irregularities, acne, hirsutism, reduces the risk of endometrial cancer and hyperplasia. In those who have hyperandrogenism, finasteride, spironolactone, and GnRH agonists are used. For those women who want to get pregnant, metformin is a treatment of choice. They may have altered glucose tolerance. It helps regulate the menstrual cycles, treat the glycemia, and also achieve weight loss. And those in infertility, we can give clomiphene citrate and letrozole as an adjunct treatment. Metformin can be given to these patients. But of course, you have to customize the treatment to every patient and follow the lifestyle modification, decrease the calorie intake and exercise, smoking cessation. All these are very important for weight loss, which will decrease the insulin resistance and also the signs, symptoms of PCOS and the androgen levels. In GDM, we know that I think Shalini already spoke the pre-pregnancy, but universal screening is necessary to curb this epidemic. And we know that the DIPSI guidelines tells us that we should use the single step OGTT. So I'll not speak about this, but we need to educate the patient, manage early, prevent the steps for future deterioration, and make a part of routine assessment of women to curb the incidence of gestational diabetes and type 2 diabetes. This is the national guidelines by the Ministry of Health and Family Welfare. So you see, if the 2-RPG is more than 140, you have to repeat the test after 24 to 28 weeks. If it is negative, you manage as normal. If it's positive, manage as GDM. And this is my last slide, where the standard of medical care in diabetes 2020, American Diabetes Association, which says that insulin is the preferred treatment for GDM. Metformin should not be used as first-line agent because it crosses the placenta to the fetus. Metformin, when used to treat PCOS and induce ovulation, should be discontinued by the end of the first trimester. So thank you very much. And I'm open to questions. Back to Archana.
Yeah. Thank you, ma'am. Thank you for the wonderful deliberation. And ma'am, we will take questions in the end if we have time. Ma'am, moving on to the next presentation, which is by Dr. Lily Rodrigues, one of the most pertinent topic right now, talking about CVD in women with diabetes. Dr. Lily Rodrigues is a consultant physician and diabetologist at Stride Hospital in Hyderabad. She's one of the very well-known figure there and nationally too. And she's a principal investigator for several global and national research trials. Over to you, ma'am.
Thank you, Archana, for that kind introduction. Let me share the screen. Where is the screen? Oops.
Go to share screen. Yeah.
Yes, I did. Oh my. I lost the page.
You can unshare and share again, maybe, if you've lost it, or minimize your presentation and see. Happens. You're muted, ma'am. You got muted. Can move on to Anjali's session first.
Yes, sure. No problem.
Can we have her introductory slide, Mahima?
Archana, ma'am?
Yes.
Yeah.
Oh, great. So it's absolute pleasure to introduce Anjali, who's a very dear friend. She's a wonderful endocrinologist, very clinical, very scientific, very focused on trying to create new algorithms wherever she goes, and very passionate about her work from Pune. She's going to take us to a topic which is really very important. We have heard topics from the entire spectrum in the continuum, but we have to think about the mental health as well, and scientifically as well as something we can all relate to. So over to Anjali to take us over to mental health in women.
Thank you so much, Archana. I would take that part of being a friend as a very blessed fact. Almost everyone here, I would say, are blessings, and it's very pertinent to the topic that we're talking about, women and mental health. And I think we being with each other is a big part of our mental health. So thank you everyone for being here for this particular panel. I hope my slides are visible.
Yes.
Yeah. Yes. Perfect.
So we are going to talk about women and mental health. And as a first disclaimer, I would like to say that it's a very vast and distracting topic. As soon as you get into women and mental health, so many channels open, so many things come up, and you feel helpless. You feel that you're not enough to deal with this topic. You will never be able to find it in a focused manner to talk about it in 20 minutes. But what I have tried to do is I have tried to take the key words of the topic One is health, and in particular mental health. What are we going to talk about? Should we or should we not differentiate women from men when it comes to mental health? There are very two beautiful concepts that I found when I was studying for this topic called alpha and beta bias. We'll go ahead to hear about them. What is the importance of mental health, particularly in women? We have been talking about all that, but in one slide, I will just complete the loop with that. And what can we do about it right now? So coming to what is health, we know WHO definition of well-being, mental, social, psychological, spiritual, financial, economical, and all that. In 2009, an addition was done as this was the WHO basic definition was for a basal state. And then it was added that it is an ability of a body. I would like to add here, because we're talking about mental health, body and mind to adapt to new threats and infirmity. We have seen this in a huge manner during COVID times. Our ability to adapt was the something that made us thrive or otherwise. And then came very two important focal concerns regarding health and specifically mental health. That is realization of the fullest potential of self, and then doing or fulfilling one's role and expectations in family, community, and other settings which we are part of. Now, this is definitely a huge plethora of terms, plethora of elements that we are supposed to take. And when it comes to fulfillment of one's role, I think the expectations and a role that a woman is expected to play is huge. And all of us know a woman is expected to look beautiful, talk kindly, be polite, be smart, earn money, equally productive in industry and finance, give birth, breastfeed, take care of infants and kids, take care of kitchen and household, and then be happy about it. I mean, that is what I would say a mental health of a woman would be about, keeping all those things in mind and still have a smiling face, still be happy about everything that you are doing in your personal as well as a community level. When I take about all this to mental health, then I try to see how can we channelize these important elements that come up under the plethora of terms of women and mental health. So it's very difficult when it's come to mental health to remove the culture or social influences, because the mental health is clearly strongly influenced by the surrounding or the environment that defines it. A proper mental health at one place may not mean normal mental health at other. At the same time, a particular behavior in one culture or society may mean differently in other culture and society. But as Valiant has said that common sense should prevail and we should find out some elements that are universally important to mental health of an individual as well as the community. So what are these two universally important components or elements of mental health? They are cognition and emotion. And I think there, I thought we come to a narrow point of understanding how we can concentrate on mental health in women. And at these two levels, I think we need to think about, one is cognition, another is emotional. Second point of the new definition of mental health, a very wonderful article that says what exactly is mental health. Earlier, because the definition of health means that you should be at the peak of your capacity and you should achieve the highest potential that you have and play your role in the society. That means that you have to be good always or positive always. When it comes to mental well-being, a purely positive approach at all the time is not possible. People in good mental health are often sad, unwell, angry for some moments, and sometimes the positive emotions like happiness can make one lazy, and something like sadness or setback can actually lead to motivation. So when we're talking about mental health, it is not always a very positive thing like we have in physical health. We want all the parameters to be in the right phase. We'll not accept something which is out of the parameter. But in mental health, these things need to be understood. These things need to be accepted. And then a person's role needs to be planned or implemented. And that is why it's important to understand what is mental health. So till now, we have seen what is health and what would coarsely help us to understand what mental health would be. Coming to the first universal point that is important, that is cognition. The second is emotion that we'll see later. So as long as cognition is considered, the recent studies in last couple of years, or I would say last 5 years, it is found that the structural and cognitive aspects of brain and wiring of the brain, that is neurotransmission, is not much different in men and women. So the part that come under cognition are your logical intelligence, analysis, memory. These are not very different between men and women. So the cognition is almost similar. Being a woman doesn't change that aspect of your mental ability or mental health. But when it comes to emotion, there is difference, because this is not something that is hypothetical, philosophical, or I would say it is not something that is hilarious that nowadays goes on as jokes or as taunts or whatever. But we are going to talk about the real science and physiological and psychological theories about gender. So this is where we need to make the gender as a specific point. And what I spoke about was alpha bias and beta bias. What does it mean? Alpha bias is present in the theories that are gender sensitive. That means they consider men and women as different and opposite. Specifically, the Freudian viewpoint says that the male anatomy and masculinity from the physical point of view is most desired and a cherishable goal, and female anatomy and femininity are seen as deviation from normalcy. In this case, though they are being gender sensitive, they are putting one gender above the other, and the other gender is considered as a deviation. While in beta bias, the theories are gender neutral. They do not differentiate between men and women. The differences are ignored. Both of them are considered equal. And this is seen more in humanistic and existential theory. Now, both of these are biases. Alpha bias is, even though gender sensitive, it is considering one gender better than the other. Whereas beta bias considers both equal, but they are biologically not equal. So the care required will be different. So in reality, ideally, we need to understand the differences, understand the similarities, do a specific job at the right place, and overcome both the biases when it comes to health, specifically the mental health. So what we have seen is cognition is similar in men and women, but when it comes to emotion, there is a different wiring of the neurotransmitter. The emotion happens at a 3-step level. One is subjective experience. Second is physiological response, and third is a behavioral response. Now, subjective experience and behavioral responses are extremely culture-based, social-based, and community-based. For example, if there is a bag, how a woman and a man will perceive that bag as a subjective experience will be different in different societies. Behavioral response will also depend on how the children, either girls or boys, are raised up and how they are taught to behave. But what is gender specific or biologically specific is physiological response. And this is where the neurotransmitters make a difference. And we will see how, because there are huge number of receptors which are sensitive to estrogen, progesterone, and androgen all over the mind, specifically the areas which are related to emotions, that is hippocampus, amygdala, and prefrontal cortex. And the interacting neurotransmitter systems, these are the systems that regulate affection, mood, and sometimes cognition that participate in response to the treatment. So the gonadal hormones are seen to be strongly interrelated with those of the hypothalamus pituitary adrenal axis also in bidirectional manner. That is, estrogen enhances, whereas testosterone reduces corticosterone release from the adrenal glands, while in another manner, corticosterone levels during a prolonged stress or chronic stress can reduce gonadal hormones, thus affecting reproductive, social, emotional, as well as cognitive functions. Now, I'm going to take one aspect of being woman and correlate it to hormones. The whole thing is out of scope of 20 minutes talk. But we are going to talk about a very important event or aspect of women's life, that is menstruation. We all have learned this diagram in our undergraduate, postgraduate days, that this is a cycle or plot of a hormonal response during the menstruation. In the first phase, first 14 days, we have estradiol, and the next 14 days, that is luteal phase, we have higher progesterone to estrogen ratio. Estrogen is higher in the first phase of menstrual cycle. And there is a very strong correlation of estrogen connected to increase in the serotonin and the number of serotonin receptors in brain. So when in harmony, estrogen is strongly linked to modifying the production and effects of dopamine as well as endorphins, which encourages emotions of happiness and motivation. While progesterone has a very close relationship with GABA neurons and as well as glutamate, which are strongly linked to feelings of calmness and contentment. And this is where the emotional response of the physiological level differs between estrogen and progesterone. And this happens every month in a woman's life, every 14 days cycle. If it is regular, the things happen regularly. In women where menstruation is irregular, this is a real chaos. Testosterone also has a very strong impact on serotonin as well as dopamine. But because we're talking about women now, I am not discussing what is the effect of testosterone on these things. Exactly when these things are imbalanced, as I said, the happiness and motivation along with estrogen may not happen the way it is expected to happen biologically. Similarly, the calmness and contentment that comes with progesterone also will be disturbed if the reproductive aspect is disturbed, like polycystic ovarian syndrome, irregular menstruation, or the mental aspect or the emotional aspects is disturbed, like premenstrual syndrome or postmenopausal state, or for that matter, postnatal depression. So this is just a gist of what happens, which is very specific and scientifically connected to the menstrual hormones and the emotional neuroparameters. Coming to the role of gender in mental illnesses, there is a very different demarcation between the prevalence of mental illnesses to the gender. Like symptoms of depression, anxiety, unspecified psychological distress are 2 to 3 times more common among women, whereas addiction, substance use, and psychopathic personality disorders are more common among men. Now, the same article also highlights that the symptoms of mental illnesses are more internalizing in women and more externalizing in men. And that is why many a times the diagnosis of diseases that are more common in men is very clear and is easily diagnosed, while those symptoms are more internal in women and diagnosis might be difficult. And that is why even the diagnosis as well as care might be biased because of the gender. There are certain women-specific mental illnesses, premenstrual syndrome, postnatal depression, and postmenopausal syndrome. These are, we will not go into details of these things, but what is here to highlight is that there are women-specific biological events happening like menstruation, pregnancy, lactation, and menopause that are very strongly related to incidence of mental illnesses. Now, it's not only the mental illness that is affecting the gender-specific challenges, but also effect of metabolic illnesses during these events of women's life that also contribute to the morbidity, like hormonal basis for alteration in metabolic control. We know post-menopause is something that can definitely influence the metabolic control. Nowadays, studies are coming up which say that even menstrual cycle can influence the metabolic control of young patients with type 2 diabetes or type 1 diabetes for that matter. Safety of medications during pregnancy and lactation is a very important point, because now we have women in their 25 and 30 years of age coming up with diabetes. And when we form their treatment, we need to consider that one day these girls are going to conceive, and the safety of medication is very important. And as the the biological events change in women's life, the life priorities also change. And that also need to be considered when we treat these patients and find it difficult to manage them. Then these are the pointers that we need to consider, which are not often spoken to with the patient, as well as not even often considered by the clinicians in the clinic. Coming to again few of the studies that suggest that there is a very strong clinical significance of serum sex hormones. One of the studies suggested that postmenopausal women with vestibular migraine, there is a very potential role of lack of estrogen in these women. The DASH diet studies follow-up showed that the sleep, mental health, and hormonal changes are very strongly interrelated to each other. And the DASH diet causing 5 to 10% of weight loss is shown to improve sleep pattern, is shown to improve the mental health parameters, as well as their reproductive hormone levels. With 5 to 10% of weight loss. At many places, it is mentioned that we don't know very clearly what is the direct relationship of gender-specific hormone towards the mental health. So everywhere it's said that there needs to be more research, there needs to be more research, there needs to be more research. But the research till now is alpha biased. It is very strongly done from the Freudian viewpoint, where most basic researches or animal researches are done using male animals. They do not choose female animals because there is a distinct secretion pattern of estrogen and progesterone, which they say that will affect the metabolic parameters that they are studying. Clearly, there is a paradox, because against using the female hormone itself is a very strong indicator that it has a very important role. And if this particular aspect is kept away from the research, and the end line is that we do not have much of the data. So importance of mental health of women, we have talked about this throughout this panel, because it's not only about that woman particularly, but she has a very larger role to play in the biological existence, where she's going to conceive, she's going to give birth, she's going to nurture the child in her womb for 9 months, she's going to breastfeed the child. So her health, particularly mental health, has a very strong impact on not only her health, but the health of the future generations to come. So what can be done? We need to remove the alpha as well as beta bias. There was a very famous quote on Twitter going on by Sadhguru saying, once gender is of consequence only in certain private spaces like bedroom and bathroom, and everywhere else it should not even matter. But I think there is a third place where this matters a lot, gender matters a lot, and that is in clinics. That is why we need to have gender-specific guidelines. I'm sure Usha ma'am is going to take us through this topic in detail. We need to have gender-specific research, not excluding women from the research because the research might get biased. We need to know what that bias is. We need to know how the hormones affect the metabolic parameters and all other mental and neurotransmitter parameters. Gender-specific clinical approach to physical and mental health. When a person is sitting in front of the clinician, the gender of the person must be considered before forming the treatment plan. And gender non-specific cultural, professional, and financial approaches, which we will leave because it's out of scope of this. There are certain biological privileges given to women and its mental health, are pregnancy, childbirth, and raising another human being. So we don't have to always talk about illness. We can also talk about the privileges that we have. Coming to the summary of this very vast and distracting topic, we understood that there is a concept of mental health, and the definition of mental health is evolving like nothing. There is a difference between men and women, but not in the cognition, but more from the emotional point of view. And the differences in the reproductive hormones is going to change the emotional response. Importance of mental health is very high in terms of women's own health and the future generation's health. And what we can do about it, the whole. With that, I would like to stop my presentation. And we'll take the questions at the end.
Yes, questions at the end. And that was a very difficult and beautifully done topic. Thank you, Anjali. So we move over to Lily ma'am. Ma'am, are you ready?
Yes, I am ready. I have sent it to.
Okay.
I have sent it to. Yes, I have sent it to RX.
Sorry.
Mahima?
We can see it on the screen, ma'am.
You can
you see it, ma'am?
Yeah, just a minute. Okay. Yes. Thank you, Archana, for that kind introduction that you have already done. My topic for today's discussion is cardiovascular disease in women with diabetes. Am I audible?
Yes, ma'am, you are.
Yes, ma'am. It's not moving.
Mahima, will you be moving the slides or is ma'am moving them? RX, are you moving the slides?
Yes, ma'am.
Okay.
Who has the control?
With me, ma'am.
Okay, so ma'am, you just have to tell her to move.
Yeah. The agenda for my talk is already displayed. Next. Previous slide, please. So, are women more complicated than men? Anjali just spoke about the differences in the gender, even in the mental health. So, is there a difference in the cardiovascular disease as well? Let's look at it. Next. The difference between men and women, the way we see ourselves. Next. Among women, diagnosis and death rates are steady, but among men, they are declining. More than 5 lakhs women die of cardiovascular disease each year, greater than the number of CVD deaths in men. Also greater than the total of the next 7 causes of death in women. Why? Atypical signs and symptoms of CVD that are unrecognized, underdiagnosed, and undertreated in women. Coming to the Indian scenario, in 1970s, it was 1% in urban India. And by 1990, the prevalence of CAD reported by Chadha et al. In Delhi was 9.7%. Remarkably, high prevalence of both CAD and cardiovascular risk factors were also shown in the Jaipur Heart Watch study, of which Dr. Arvind Gupta is also a part of. India is predicted to bear the greatest CAD burden according to the estimates from the Global Burden of Disease study. There is still inadequate population-based data on the prevalence of CAD in India, particularly comparing diabetic and non-diabetic subjects. Next. So diabetes poses a greater risk than any other factor that we all know. The Birmingham Heart Study, women with diabetes had 3 times more cardiovascular events than the other women, with 2.2 times dying from the CVD. Among diabetic individuals, CVD mortality is higher in women than men. Young women with diabetes lose any premenopausal protection. So compared to diabetic men who have 2 to 3-fold increased risk of coronary heart disease, diabetic women are reported to have 3 to 7-fold increased risk. Next. So coming to the risk factors, we all know obesity increases the risk of CAD into 2 to 3-folds. Diabetes, as we just said, because blocks estrogen protection in premenopausal period, risk of CAD 5 times, and sudden cardiac deaths 3 times more than in non-diabetic women. HDL below 58 milligrams per deciliter correlates with increased sudden cardiac deaths. Arterial hypertension is also, but it is more seen in the women above 60 years. Psychological factors like depression, anxiety, again, increases the risk factors for women, which are more in the women-centric findings. Then smoking and history of OC pills important in premenopausal women. Next. Now, coming to the gender difference in atherosclerosis, plaque erosion, that's women suffer from more of plaque erosion as a cause of ACS, and men suffer more plaque explosions or rupture as a cause of ACS. Next. Women have smaller coronary arteries. After correlating for body surface area, women's arteries are smaller. This can seriously affect symptoms from anything that reduces the diameter, that is stenosis and endothelial dysfunction, which is more common, which can be more common in women. Coming to the microvascular, which is very important, the obstruction of epicardial coronary arteries is the common cause of ACS in men, whereas the dysfunction of coronary microvessels, that can be a cause of ACS in women and are not seen usually on an angiogram. Next. So CAD usually develops differently in women. As you can see in this cartoon, the men have a focal stenosis and women have a diffuse stenosis, as you can see here. Next. Now, why there are challenges in recognition of coronary heart disease or other cardiovascular diseases, mainly the coronary artery disease in women, because the chest pain or discomfort is seen like this in many women. They just see as a, pressure on the chest, unusual upper body discomfort, shortness of breath, breaking out in a cold sweat, unusual or unexplained fatigue, tiredness, nausea, or lightheadedness. So these could be the various symptoms in women which are not very often recognized as a coronary artery disease. Next. Now coming to some studies. This is a study done in American source is American Heart Association. So cardiovascular disease is the leading cause of death in women. They compared it to the white females and with black. And in these, all these causes that are mentioned here, the coronary heart disease was the highest in number in both whites and blacks. Next. This is a WISE study, which is Women's Ischemia Syndrome Evaluation, published in European Heart Journal in 2006, which found that about 50% of women sent home with normal coronaries continue to experience disabling symptoms, possibly due to coronary microvascular or macrovascular endothelial dysfunction. 673 out of 936 enrolled in WISE had persistent chest pain, and there were 2 times the number of CV events. These women who had 2 times more number of CV events like myocardial infarction, stroke, CHF, and CV deaths than those without the persistent chest pain. Next. So there are elevated triglycerides which increases the CHD risk in women. Now, for every increase in serum triglycerides level of 89, the risk of CHD increases 30% in men and 69% in women. Next. Coming to the lipid levels by age and sex, here too, there is a difference in women. You can see the LDL, which goes up as the age increases, and men, it comes down. And HDL-C in women, it is actually, it's better as the age goes. However, there is a difference in men and women. Next. Although less frequent, cardiovascular disease also occurs in young women. Very often it is said that, premenopausally women are protected because of the estrogen, but more than 35,000 women under the age of 65 die annually in the US because of CVD, as per this study. Next. Now, less obstructive CAD in women undergoing angiography versus men. This was published in 2006, which also says that, women have less obstructive disease, even if they suffer from myocardial infarctions. Next. Cardiovascular mortality trends were also seen more in women, as you can see in this red. Next. Underdiagnosis of heart attack in women, sex differences when we look for them. So do we have difference in the high sensitivity troponin based on gender cutoffs? I don't think we do have. We just go by the diagnosis of heart attack by symptoms, ECG, and blood measurements of troponin, which is common to both the genders. And there is no different thresholds for men and women. But if you really look for it, there is a difference because women's arteries are smaller. So women were more likely to be misdiagnosed and undertreated for MI. Therefore, sex matters. Next. Virgo, a door-to-balloon D2B study, which shows that there is a delay in young women with heart attacks. So you can see here, 8 minutes longer to treat in the women as compared to men, and 30 minutes longer to treat in women as compared to men in the transfer, direct treatment and in the transfer. There were, in both the sections, there was a delay in the treatment of STEMI in the young women. Next. This is a Get With the Guidelines study, which studied age and gender differences in quality of care and outcomes in the heart attacks in the USA. And then what was found? Quality of care was significantly lower and mortality was higher in young women versus young men. And then similar was the result, and there was less likely the women were less likely to receive ACE inhibitors and ARBs, less likely to receive lipid-lowering therapy, less likely to have controlled blood pressure and discharge, and fewer achieving door-to-balloon time, which should be less than 90 minutes. Next. Now, as already mentioned by Anjali and others, there is underrepresentation of women in cardiovascular clinical trials as well. Next. Next. Coming to the different cycles of women, we talk about postmenopausal women. Postmenopausal status is considered an independent risk factor for cardiovascular disease because the hormone therapy no longer recommended to prevent or manage CVD due to increased rate of thrombotic events such as MI and strokes, as well as breast cancer. Men develop CVD at younger ages, but incidence and prevalence equalize for women after the menopause. Next. PCOS, we already heard a lot about this, and PCOS is definitely increases the risk factor of metabolic syndrome, subclinical CVD, as well as clinical CVD in the future. Next. Pregnancy can be nature's stress test on the heart. So high blood pressure, gestational diabetes, and preterm birth, all these are considered as risk factors for CVD. And what can be done? We have to, as already deliberated a lot about this, pregnancy has to be considered cautiously especially in women who have diabetes and hypertension, and the cardiovascular risks should be minimized by changing their lifestyle and healthy diet and reducing the weight, monitoring their weight particularly. Next. Next. Next, please. The menopause, as I already said, menopause increases the LDL, reduces the HDL, increases the triglycerides, insulin resistance, abdominal fat redistribution, hypertension, type 2 diabetes, and vascular endothelium dysfunction. So all these will lead to cardiovascular disease. Next. This is self-explanatory. So this is a continuum of increasing risk factors of CVD when a woman attains menopause. Next. This is again a study to show that menopause and risk factors of risks of coronary heart disease as the age increases, as the menopause occurs, after the menopause, the cardiovascular disease is much, much, much higher. Next. So now coming to a few comorbidities and addictions in women that lead to CVD. This is about obesity. We have already talked about that because there is increased risk of hypercholesterolemia, hypertension, and both or diabetes. Next. Hypertension, very common factor, it's most commonly associated comorbidity with CVD. Next. Women with addictions to smoking and even alcohol, excessive alcohol, who can, it becomes a very notable risk factor for cardiovascular disease. Smoking reduces the estrogen levels even in the premenopausal stage. Menopause occurs earlier in them, and women smokers have a higher risk of early heart attacks. Women less than 50 years, the majority of coronary heart disease is attributable to smoking. Risk increases with the number of cigarettes smoked and duration of smoking, as per the US General's report. Women smokers on OCPs have a heightened risk compared to non-smoking, non-pills users, about up to 87 times in heavy smokers. So age-adjusted relative risk factor for fatal coronary heart disease or non-fatal MI or current smokers versus non-smokers is significant statistically. Next. Mental stress, as Anjali already alluded to, is a trigger for ischemia and women more often than men. Women had more EKG documented ischemia during mental stress, men more during the physical stress. Women reported chest pain more often during daily activities and mental stress tests, whereas men more often during exercise. So perceived stress scores, PS14, was significantly higher in women, 27, as compared to men, which was 23.4 before suffering an MI. Next. So psychological stressors in women with CHD, the Stockholm Female Coronary Risk Study also showed that among women who were married or cohabitating with a male partner, marital stress was associated with nearly threefold increased risk of recurrent coronary heart disease events. Now, living alone and work stress did not significantly increase the recurrent CHD events. Marriage or partnership benefits men, however. Next. Heart disease and breast cancer also has higher risk, almost 7 times when the cancer patients take radiation and chemotherapy both together will have 7 times more likely to develop heart disease or heart failure if received both. Next. Now, what do we do after knowing all this? We need to prevent. Next. Weight loss and maintenance is not easy, but it is doable when you have a plan. Primary prevention of cardiovascular disease with the Mediterranean diet was published in New India Journal of Medicine. Next. There are various studies which are shown that aspirin trials for primary prevention have not really benefited much. Thousands of patients have been studied in ARRIVE, ESPRI, and ASCEND studies. However, the endpoints were not really very encouraging. Next. So current recommendation based on meta-analysis and with the recent 3 trials, low-dose aspirin might be considered for primary prevention of ASCVD in select higher ASCVD adults aged 40 to 70 years who are not at increased bleeding risk. Low-dose aspirin should not be administered on a routine basis for primary prevention of ASCVD among adults and women above 70 years of age. Low-dose aspirin should not be administered in primary prevention among adults at any age who are at increased bleeding risk, including history of GI bleeding, peptic ulcer disease, bleeding from other sites, thrombocytopenia, coagulopathy, CKD, and concurrent use of NSAIDs, steroids, and anticoagulants. Next. The secondary prevention lipid lowering studies in women, though it has to be continued for those who have already have cardiovascular disease as per the advice and the guidelines. Next. So does hormone replacement therapy prevent heart disease? hormone that I already alluded to, HRT at present not recommended for primary or secondary prevention of CVD. However, if a patient has attained very early menopause and has very severe symptoms of postmenopausal symptoms because of the symptoms which trouble her, then HRT may be considered. But generally, it is not. It does not really help these women, the postmenopausal women, with the hormones. Next. Now, the primordial prevention of CVD in women has to be known to all of us. Behavior modification is the key to prevention. More than lifestyle management, I would say behavioral modification that is required. Keeping HbA1c between 6.5 to 7 and keeping the blood sugar in range for more than 70% of the time. Blood pressure less than 130/80 and keeping the BMI near normal as much as possible, and difficult but doable if one sees it. Next. To summarize, CAD in women is common and has important variations in clinical and risk factor profile as compared to men. Stable angina, ACS, and STEMI can frequently occur due to non-obstructive CAD in women. Non-invasive modalities like treadmill test, nuclear imaging, stress echo, CT, angio, stress CMR, and invasive coronary angiography can help with diagnosis and management should be according to the guidelines. Thank you very much for your patient listening.
Thank you, Lily ma'am, for this wonderful presentation on CVD and diabetes in women. So last few talks, we've just understood that women are definitely different and very special. There has been an alpha bias even in research, in addition to many other platforms. So do we actually need gender-specific guidelines? So who other than Dr. Usha Sriram, who would be here, talking about this? Dr. Usha Sriram is the founder of DIVAS, president of Indian Society for Bone and Mineral Research, a very well-known figure from Chennai. Over to you, ma'am.
Thank you so much, Ami. First, my apologies to everyone for this bad voice, but great thanks to Shalini and Dr. Rajiv Chawla for, first of all, such a brilliant session and giving me this talk and inviting me to be part of this symposium. Always a pleasure. I've been up from I'm traveling right now, but up from 4:30 listening to Archana Sarda and Colin, and so inspired. Thank you all so much for doing this. Let me share the screen and hope I will have good luck. Yes, I do. Yes, I do. Okay, so this it's making the case for gender-specific diabetes care, and I only hope I am 10% as passionate and convincing as Archana, who spoke about type 1 diabetes. Put that talk on steroids, and that's what we need for all of women and diabetes. Really, it's such a big problem because globally, 50% of the women, 50% of the people with diabetes are women. So in India, it's somewhere to the tune of 35 to 40 million people. And just to put that in perspective, that is the entire population of Canada. And so, we have a very significant problem. And just to, say thanks where it is due, in 2017, the International Diabetes Federation made the theme as Women and Diabetes, Our Right to a Healthy Future. That's really when the whole thing got truly validated and pushed on the global agenda. So this was an editorial in the Lancet. It said on November 14th this year, the focus of World Diabetes Day is Women and Diabetes, Our Right to a Healthy Future. With ever increasing evidence that diabetes adversely affects women more than men, this timely theme will help to boost awareness of the need for specific approaches for prevention and care and treatment and education. This year's theme is education to protect tomorrow. And as you all know, I have added a tagline that says, the future is her, because truly the future is her when you're talking about, girl children and transgenerational transfer of everything we have been talking about, and the role of women, everything, including economy. So the future is her. And so I'm very grateful for this editorial that put the thing. And I think we should really make it clear at this point that any discussion on gender-specific guidelines, or when we're talking about women and diabetes, it's not his versus her. It's not some battle of the sexes or a feminist issue. It's a hardcore medical issue, hardcore public health issue. So that's what we are talking about, and nothing else. And like everything else, COVID pandemic has really hurt. Though it caused more COVID in men, it caused more COVID-related problems in women. One of the big things is pushing women and girls into extreme poverty, 47 million more people. And that's true for, our country. And that's why Archana's talk is super relevant today. And you take all NCDs, what has happened is the COVID-19 pandemic, the lockdown and everything else that came along with it has rolled back a lot of the progress. And watch out, there's going to be a huge uptick in all NCDs. Already we are having reports about GDM having gone higher in some countries, diabetes being higher in countries. So when the dust settles down, as they say, we're going to see a lot. And as I mentioned right at the beginning, now the most powerful engine of global growth, forget all the other things, really need to, focus and invest in girls and women. And when it comes to women and diabetes and the importance of gender, the experience of diabetes is different in women, more serious adverse outcomes in women, and the life cycle of women is different, and the socio-cultural economic context is different, just one. So gender-specific research and technology, which we have heard about, is lagging behind, and gender inequities in healthcare, and need to view this whole one size fits all. What's good for the goose is good for the gander. All that has to be put to bed. We need to view therapeutics with the gender lens, because we're learning more and more how each medication can be, work differently in men, work differently in women, and cause different problems. You give a woman metformin or a TZD, she could start ovulating, someone who was not ovulating, and have unintended pregnancy. And Shalini so elegantly showed the risks of having unintended, unplanned pregnancies. So, and gender mainstreaming. So no more gender neutrality, not acceptable. No more being gender agnostic. No more being, all is equal. It's not equal. We need gender mainstreaming and need to be really gender sensitive in everything we do. So a ton of misconceptions about diabetes being more prevalent in men, caused by the same genetic environmental factors. Heart disease is a man's disease. Diabetes care is ignored by women. All diabetes is the same. All women are a monolith, same. All treatments work the same way. You know where I'm going. None of this is true. So very quickly, I want to show you 50% of the people in the world with diabetes are women. And the little difference that is there between men and women is shrinking. And very soon we are going to outnumber. The lifetime risk of diabetes is higher in women globally and in India. And you look at the drivers of diabetes, besides the usual urbanization, globalization, obesity is more in women. And this pregnancy and GDM and PCOS and metabolic changes during menopause and women who have, low birth weight themselves being at risk for future GDM and diabetes. And if a mother has diabetes, her daughter has greater risk for GDM, like mother, like daughter, which is Dr. Yagnik has, used that recently. And caregiving and stress are big issues for women. And I want to congratulate Anjali on a very difficult, navigating a difficult topic. But I want to also add here, you take diabetes, women have 2 times more diabetes related depression and complications. Depression in women. So are these differences a function of biology, life cycle, social determinants of health, or behavior? Short answer, all of the above. There are physiologic and pathologic sex differences. Pregnancy and life cycles like that causes gestational, which man has to gain about 10 kilos or 15 kilos during a pregnancy, and then work hard to get rid of that, do the breastfeeding part, lose sleep. Imagine the beating our body takes. It's most beautiful kind of a journey, but it's a beating nevertheless. So this is, some gestational weight gain, retention, all of that leading to metabolic complications later. And let's not completely, let's take some blame for it as well. We tend to be less physically active, more sedentary pursuits. Part of it, of course, is cultural. And then the big social determinants of health, everything from housing and education and social support systems and access to healthcare and, things like pollution, which is now increasing the risk of diabetes and heart disease. So not only all this increased risk, more women are dying in every continent except North America when they have diabetes. And that's a very strange thing. And why is that so? And it's been shown whether it is coronary artery disease, stroke, vascular dementia, end-stage renal disease, and more recently, cancer, more the sex differences are very obvious, that 27% more cancer in women with diabetes compared to women without. But the thing is this, just look at this picture, and that is the essence of my talk, because that women could have heart disease or mental health issues or fractures or cancer is not in our radar. When we think of women, we only think of pregnancy. So this narrow vision of women's health from just a reproductive angle has, I think, really what has hurt us in a big way. And if you see here, all this is wrong. The only thing they've shown is a woman is pregnant. So we need to change that. So as you can see, more heart disease and non-traditional risk factors. Lily has beautifully gone through this, that we have to be cognizant of GDM and hypertensive heart disease, hypertensive disorders, preterm delivery, miscarriages, infertility. Everything is and low birth weight are all risk factors for heart disease in women. And pregnancy should start be viewed as a window to future chronic disease, which is things like diabetes and heart disease. The symptoms are different. Heart failure is different in women compared to men, the type of heart failure, but more heart failure in women. But unfortunately, understudied, under-recognized, underdiagnosed, undertreated, underrepresented in clinical trials. Just now, I saw a tweet this yesterday that showed that in a big study, hardly represented women were in a heart failure study. So stroke is more common in women, fractures more common in women. The INDIAB data showed, that's from India, after gender stratification, diabetes was a risk factor for fracture only in women. We need to start looking at bone health, mental health, cancer, all of these things as complications of diabetes. only then we'll start looking for them, and only then we'll start screening for them. Just wanted to show you this whole mental health and diabetes. This whole diabetes distress, we know, is a very big problem and could be a huge problem for women because they're already overwhelmed with caregiving and other responsibilities. Imagine, add to that, eating the right thing, eating on time, taking medications, being physically active, going to the doctor, affording medications, coping with all of that, planning a pregnancy, talk about adding so much. So when it comes to gestational diabetes, I know that's not the scope of this talk, but just want to say that's taken a Vishwaroop of its own globally, particularly in our country. And we need to really start focusing on young people, primordial prevention, and talking to high school girls and college girls and young working women and just married people. We need to really target this group about how to prevent this, because once they become pregnant, as they say, the horse is out of the barn, and we can't do a whole lot because we really can't people on a super strict diet. We know all the complications that happen because of GDM, more diabetes in them, more diabetes in their offspring, recurrence in the subsequent pregnancy, more cardiovascular disease, obesity, and visceral adiposity in their offspring. Speaking of adiposity, women just seem to have more obesity, and therefore why gender-specific guidelines are needed is also, I also want to say, say thanks here to Penny Neglur, who's been a great champion in this, in pushing for this gender-specific guidelines. So we need to be avoiding medications that can promote obesity and looking for things that are either weight neutral or actually help with weight loss in women who have issues with weight. And, one more thing that I want to mention is this whole high burden of pre-diabetes and in our country. And if you look at the broken blue dotted lines, that's pre-diabetes in women. Enormous amount, 30%, 40% pre-diabetes in young women, which all will change to diabetes going forward. So why it is so important that we have gender-specific guidelines, even for something like pre-diabetes, because that is really, there are sex differences that there are that in endothelial function before conversion to pre-diabetes. So the clock does seem to start ticking earlier among women. And one of the most beautiful explanations is that it takes about 2 years for women to accumulate the amount of fat. And in that 2 years, they are now then developing all the cardiovascular and other metabolic markers and complications that sets them up for higher risk for heart disease. So what are the solutions? Let us really, really focus on our young women before they become pregnant. So preconception care. I'm not talking about pre-GDM care or GDM care or anything. I'm talking about healthy, normal women. Screen them for diabetes, screen them for pre-diabetes, screen them for nutritional issues, and watch out this space. We are coming out with a program called Be Ready. Will be launched very soon. A simple questionnaire that women can take, and at the end of it, they get a report card on if they are ready for walking into the most beautiful journey of their life. So that's one solution. We need to make sure our mother's weight is good and the baby's weights are good, because as you can see, birth weight is linked to both diabetes, metabolic syndrome in women, and their own birth weight is linked to the risk of GDM in them. And we also know what happens, the developmental origins of disease. At every stage of life, it has a huge outsized role to play. And so we need to make sure pregnancies are healthier. We need to have a very gender-informed perspective about care of people with diabetes. What will happen to an older woman? If she is put on, let's say, TZDs, could she have a fracture? Should we be screening them for cancer, breast cancer, endometrial cancer, oral cancer, colorectal cancer? All of these things are high in women with diabetes. The pillars of diabetes management are same, but we need to always look at things with that gender lens. So this is what the ADA EASD gave out. No mention anything anywhere about gender. And all that we are saying is apply the gender lens. Look at women as, are they in their reproductive years? Are they planning a pregnancy? Then ask them to follow the pre-GDM guidelines. If they're not planning a pregnancy, but they are, let's say, they're not sexually active, pregnancy is possible, then make sure that contraception is prescribed. Preconception care is recommended to them. But if they are using contraception or pregnancy is not possible, then make sure that they get the good lifestyle modification, good control, BP control, lipid control, glucose control, weight management, stress reduction, surveillance, all of those good things. But if they are peri or postmenopausal, make sure if they are perimenopausal, you assess, make sure they, their GU symptoms are not confused with a UTI, that they have, their lipid profiles are managed. Should they or should they not get Medicaid? Things like a hormone therapy that has to be weighed, because women with diabetes can get high triglyceride issues, or they may be at risk for thromboembolic events. So we need to be very careful about that. If they are postmenopausal, always make sure CV risk, bone health, mental health, cancer screening, very, very important, GU health. All this we have to pay attention to them. Now, when it comes to women, there are 2 or 3 things. They may, unless they understand why the medication is being given, and unless they can afford it, okay, gender differences in medication, non-adherence, more in women because they may not be able to afford it, or some side effects are bothering them. So always have to look at it. And we have to consider a patient perspective all the time. What is it that bothers them? In which stage of her life is she, and what is worrisome to her? Can she afford this? And in women, we really have to, start early and stay persistent throughout, because as you can see, from normal glucose tolerance, exposure to risk factors, by the time they may have a longer diagnostic delay, and then screening for vascular complications that may be delayed. There may be health system issues. So we have to make sure that we do both primary and secondary prevention. And we should use our frontline health workers. And I think Archana mentioned this, our ASHA and Anganwadi workers are a great resource. If their capacity can be built on this, they, I'm sure, can be our, messengers in this big battle that we are, we have entered. And successful models in the world, like the Go Red for Women, which is purely a empowerment program, how successful it has been. My last thing I want to say is, we've been trying to fit a round peg into a square hole all along, and we know that doesn't work. And we really need to have a very, gender sensitive, gender appropriate, and gender mainstreaming in medicine in general, and in diabetes care in particular. And thank you all so much.
Thank you, ma'am. That was, yes, that was an apt and very, very emphatic end. I think now I'm going to think about, look at everything to the gender lens. I hope I don't end up fighting at home, just because that's going to be so embedded in the mind. We had a wonderful day, wonderful session about women, by women, and all the topics covered. Unfortunately, although we want to take a lot of questions, the organizers have set us a message that there is no time. So anyone who has questions, all our speakers are always there. They mentor us, they nurture us, they're always there for any kind of discussion. So please reach out to them personally. Thank you so much for this.
Thank you so much, my diabetes and women's gang. This was an awesome session. We all loved interacting, and I'm sure it's so nice to see the entire gang on the same screen together. It's been great. I'm so sorry because of shortage of time. We'll just have to skip the discussions. So I think we're all holding the flag, marching ahead, full throttle, full speed. And I'm sure once all of us march together with all our friends, not essentially females, but all the men in the community, I'm sure there's lots that we can achieve in this particular field. So with that positive note, many thanks, Dr. Usha ma'am, Lily ma'am, Dr. Benny ma'am, Dr. Archana ma'am, Dr. Anjali, Ami, everybody who's here. So great sessions. Thank you so much.
Thank you, Shalini.
Thank you. So we now move on to our very important debate, the only debate we wanted in this particular session. And to chair this debate and to decide, we have Dr. Anjali, who's continuing, and Dr. Vipul Chavda from Ahmedabad, a diabetologist and cardiometabolic physician, to do the honors, invite our debaters, and get the debate going.
Thank you so much, Shalini ma'am, for wonderful opportunity, and once again, congratulations for grand success. Since last 2 days, we are witnessing a wonderful scientific feast, and we all are talking about diabetes, and we know that after the use of SGLT2 and GLP-1RA, we are forced to think that only glucocentric approach will suffice, or we have to think about vasculocentric approach or not. So to discuss this, we have two eminent speakers from our country, and I am privileged to introduce the first speaker, Dr. Tejas Shah. He is a diabetologist and director of IBA Diabetic Care Center, Mumbai, honorary diabetologist, SL Raheja Fortis Hospital, Diabetic Care Center at Malad and Andheri. He is a visiting as well as teaching faculty for Fellowship of Diabetology by Dr. D.Y. Patil Medical College, Navi Mumbai, founder and president of UDF, and organizing committee member and faculty for CID since the very beginning. So, sir will talk about the glucocentric approach in the management of diabetes. Sir is practicing as a diabetologist since 23 years, though he is not looking that old, but over to you, sir. Sir, you are mute.
Thank you very much, Vipul, for the introduction. Thank you, Shalini, Dr. Rajiv Chawla, and the entire team for having me here today. Interesting debate, which we are going to have. I also welcome my co-speaker and opponent, Dr. Srinivas Murthy, here. So the first thought that came to my mind when I thought or read this topic, or when I'm talking today, is that it's such an irony that we are more than 100 diabetologists since yesterday and today attending this mega event. We are about diabetes. We have been managing diabetes for the last so many decades. All of us, our bread and butter is controlling blood sugars. And today we have to debate whether controlling blood sugars is the first step or is more important, or whether targeting ASCVD is more important. And so that is what I am a diabetologist. What I know is controlling sugars best. And I think that is what I am going to talk about, that glucocentric approach is something which we require as the first step when a patient walks into us. So let me paint you a picture of this individual who comes to us came to the OPD for the first time with an HbA1c of 9.5. He's a 42-year-old male. His BMI is 26. His blood pressure is moderate. And he walks in with his lot of hopes, and he comes into Dr. Srinivas Murthy's clinic, asking that he needs his blood sugars to be well controlled. So my question is, will you focus on his blood glucose, or are you going to think about what is going to happen after 20, 30 years, whether he's land up with an MI, whether he's going to land up with a cardiovascular event? So what should I do with him now? Or whether the first concern is to bring down his HbA1c from his 9.5 to the target A1c of less than 7 is what is the question that is going to be in the mind. Why this approach? Well, everything is glucocentric. If you look at what we are doing in our practice, controlling blood sugars is glucocentric. A patient coming to us with the hopes of bringing down his blood sugar is glucocentric. What he's paying us for is glucocentric. So why are we even talking about this? What we know is that if we bring down the HbA1c by even 1%, we know that diabetes-related deaths can decrease by 21%. We know that the microvascular complications can reduce by 37%. We know that myocardial infarction comes down by 14%. The UKPDS clearly taught us so many things. It's an old trial, no doubt, but it is still the most important trial for us when we are treating a patient with type 2 diabetes. We know that there was the initial part of UKPDS where the intensive arm was compared to the conventional arm. The intensive arm was well controlled or better controlled as compared to the conventional arm. And then they were followed up for a period of 10 years post UKPDS also. And what it showed clearly was that the reduction in deaths from diabetes reduced by 21%. The heart attacks came down by 14%. The microvascular complications came down by 37%. And peripheral vascular disease came down by 43% by just 1% mere reduction in HbA1c. If you look at the long-term study of UKPDS also, the macrovascular complications also came down even after 10 years in the intensive group as compared to the conventional group. What does it tell us? That it tells us something about the metabolic memory. Metabolic memory is something which has been associated directly to vascular diseases. If you look at various trials like ACCORD, ADVANCE, VADT, UKPDS, DCCT, EDIC, some may have not shown any benefit in the initial part of the study, but even after follow-up, after 10 years, these studies have shown a reduction in terms of micro as well as macrovascular complications. What it tells us is that hyperglycemia, the initial reduction of hyperglycemia becomes the most important aspect. There is the accumulation of superoxide anions, there is the oxidative stress, there is the product and the accumulation of advanced glycation end products that happens over a period of time. For the longer duration of time the hyperglycemia is in our body, the more chances that the body is exposed to the advanced glycation end products, and thereby which further leads to the increased incidence of vascular diseases. And therefore, friends, first target is to bring down blood sugars. First target is to control the patient better in the initial years. If you look at the STENO2 data, again, STENO2 was a study which looked at multifactorial intervention. It tried to show that if you do multifactorial intervention, controlling the blood sugars, lipids, cholesterol, blood pressure, whether you are able to bring down the primary composite endpoint of cardiovascular death, of stroke, of amputations, or surgery. And clearly, again, the STENO2 study where the HbA1c target was kept at less than 6.5, the cholesterol was well maintained to less than 175, the systolic, diastolic were well controlled in the intensive group. It showed almost a 53% relative risk reduction in any kind of CV event and overall an improvement of CV outcomes. So telling us again that bring down the blood sugar in a better way or initially helps us in the long run. If you look at the microvascular component in the STENO2 study, again, it clearly showed the incidence of nephropathy, retinopathy, and autonomic neuropathy. All three were relatively decreased by almost more than 55 to 60% in all the three. The only benefit did not show was in terms of diabetic neuropathy. If you look at the DCCT EDIC data again, DCCT again was a study done in type 1 patients, and EDIC is the follow-up study of DCCT, which was seen even after 10 years of the trial got over. Again, comparing the intensive versus the conventional group. If you look at the effect of intensive therapy, there was a difference of almost 2% in HbA1c between the intensive arm and the conventional arm. A reduction of retinopathy was clearly seen as early as 4 years in the EDIC follow-up data, and after 10 years itself, the EDIC data showed that the incidence of retinopathy was significantly reduced by more than 50%. If you look at the nephropathy data at 7 years, again showing an improvement at the end of 7 years, and neuropathy in data again showing an improvement at the end of 8 years as well as 10 years. So what the EDIC study taught us again, that the initial few years where the HbA1c is high, and if you try to bring it down fast, clearly it helps us to reduce the microvascular complications as well as the macrovascular complications. The cardiovascular data of EDIC study came at 17 years, so it's after a considerable period of time, but again it showed that a 1% reduction in HbA1c was associated with almost a 21% reduction in the risk of CV, where there was a reduction of calcium score seen, there's a reduction in the myocardial infarction rate seen, as well as heart failure seen. So clearly in the initial years becomes very, very important. Intensive diabetes therapy overall we know has a long-term beneficial effects on the risk of CVD, and there Now, the question in today's times comes in this cardio-centric area that we are talking about, that how can we reduce the CV risk per se in the type 2 diabetes by a glucocentric approach, whether we'll be able to reduce the CV event that is there or no. The answer is clear. You need to reduce the blood sugars. You need to use good agents, the agents which will reduce the glycemic variability. We know that glycemic variability is a known factor to cause cardiovascular disease. The trials which were done in the past were done with older drugs. There were drugs which were causing hypoglycemia. So reduction in hypoglycemia is one of the third important factor that will help us in reducing the CV risk. So it is not per se in this CVOT area that it is not only the drugs, the newer drugs or reduction of ABCD happens because of these only. If you try to control the blood sugars well, if you try to reduce the glycemic variability well, and if you prevent hypoglycemia with better drugs, clearly we are able to reduce the CV risk. A meta-analysis done with almost 100 studies showed that fasting blood glucose more than 126 had an increased risk of coronary artery diseases. IGT and elevated HbA1c1 about 5.7 has been associated with an increased CV risk. And an increased blood glucose concentration in the general population per se confers a population to a higher risk of CVD. And therefore, individualized management, targeting the A1C, bringing it down according with the better drugs is the need of the hour. Now, if you look at the impact of intensive therapy on the various trials, again, in the long term also, the microvascular complication reduction has been uniform for all the trials. Yes, Accord showed an increased rate of deaths. My opponent will definitely talk about it, but it was primarily because of increased hypoglycemia, because of maybe the drug used in that to bring down sugar or to intensively manage was a sulfonylurea only, when not the newer present, more safer drugs. But overall, the cardiovascular disease reduction is seen in UKPDS, the mortality reduction is seen after 10 years, and the DCCT EDIC as well as the advance and VADT were more or less neutral in these terms. Now let us imagine a child who is sick. A child who is sick but and is not able to appear in school exams, has poor grades in school exams. What do we do for him? Are you not going to treat his illness first, or are you just going to look after the school grades and whether you are going to try and correct the school grades first? Clearly, the analogy stands true when we talk about the diabetes management itself. Hyperglycemia is a detrimental part to cause cardiovascular diseases. And if you control the sugars well, if you target the patient well, give him a safer therapy, we are able to bring down the A1C with the proper drugs. Naturally, we are going to avoid the ASCVD risk which the patient has in the future. So wouldn't your management be glucocentric in the first place is what I'm asking. Now, when we talk about prevention of cardiovascular disease, we know that pathology, the low-grade inflammation, the oxidative stress, and are all endothelial dysfunctions are all the factors which causes atherogenesis in the long term. But all these factors primarily are because of the direct effect of hyperglycemia in a patient with type 2 diabetes. And if the hyperglycemia is well managed, I don't think we need to worry about these factors in the long run. HbA1c reduction has been the gold standard for us. If you look at the various meta-analysis again done related to long-term glycemic variability, higher A1C variability was associated with increased macrovascular events as well as renal disease or cardiovascular diseases, and more or less positively associated with micro and macrovascular complications. And therefore, reduction of HbA1c with the better drugs is the need of the hour. And finally, when we are talking about glucocentric management in today's times, again, the cost effectiveness always comes. We know that in India, the patients are paying from their pocket. And when you talk about targeting a patient with ASCVD management and not only going for glucocentric, we are definitely increasing the burden on the pocket of the patient. The cost of the treatment increases, and we need to think about the financial burden also. Now, when we talk about the ADA 2022 algorithms, or be it the RSSDI algorithm, or be it the ACE algorithms, what does it tell us? It primarily is talking about bringing down the A1C initially. The first line of therapy with metformin and lifestyle and targeting the A1C to less than 7. If you look at the ACE guidelines also, what does it tell us? It tells us to use drugs based on the A1C. It does not tell us to use drugs primarily just to reduce ASCVD, but it tells us to bring, depending on the A1C, you start using 1 drug, 2 drug, or 3 drug. And in fact, if the A1C is high or more than 9, you straight away go on with 3 drugs. Similarly, the ADA or the RSSDA guidelines is telling us to stepwise add the drugs if the A1C is not under control. So friends, HbA1c and glycemic control still remains the criteria to intensify treatment, and it is not only at ASCVD based management. What we know, to summarize, that no change overall in a patient subgroup. Intensive glycemic control may also decrease macrovascular complications. Hypoglycemia is a condition which we should be avoiding, but at the same time not at the expense of a poor glycemic control. The weight increase experienced by patients with aggressive therapy is not a negative prognostic factor. It has been proved in studies that it does not increase the cardiovascular mortality. Therefore, glucocentric as well as cardiocentric approaches both are necessary in a patient with diabetes. Adequate care of patients with diabetes must involve early diagnosis of hypoglycemia, treating the risk factors, as well as identification of patients with established heart diseases. And considering the number of patients with diabetes being increasing, let us understand that a sound approach, a synthesis approach where glycemic control is as important as control of the cardiovascular risk factors should remain as a target to be achieved. So there is no doubt in my mind that we need to be glucocentric when we are dealing with a patient. We need to bring down his blood sugars well, avoid hypoglycemia, and treat him, and we will automatically be avoiding the complications in the long run. But let us understand that a patient who's coming to us for the first time, our aim is to control his blood sugars well and thereby reduce his micro and macrovascular complications that could happen later on in life. So glucocentric approach, friends, will always be the first step that we'll be initially talking about or dealing with in our patients. Thank you very much.
Great. After an extremely clinically relevant talk by Dr. Tejas Shah, we have the debater. Is he here? I can't see. He was here a few minutes back, Dr. Srinivas.
Yes,
I am here, Dr. Anjali.
Oh, so sorry. I couldn't see your window. Great. So we have the most apt person who is known to question everything and who is not ready to accept anything unless it is proven through a evidence-based protocols. And he will question everything that we think is clinically relevant and accept only if he thinks it is clinically as well as evidence-based. So we have a huge list of accords to Dr. Srinivasa Murthy. What I would like to say is he's considered one of the most active person in the clinical research in country today and the best person to debate over a very, very beautifully put in clinically relevant talk that Dr. Tejas sir just gave. So over to you, Dr. Srinivasa, eager to listen to your views on this point.
Thank you. Thank you, Dr. Anjali. I'm audible?
Yes, sir.
Yes, you are.
Yeah. Just one sec. It's visible, right?
Yes, sir. It is visible and in PowerPoint.
Yeah. Thank you. Thank you. And thank you, sincere thanks to Dr. Rajiv sir and Dr. Shalini. And I acknowledge presence of Anil Bansali sir also that adds on to our discussion. And ASCVD-centric management versus glucocentric. I think they just put up the first slide itself about a clinical case. In 2022, he wants to just control the sugars and he doesn't even put the BMI of the patient, doesn't even put about the other screening, which is important. And that is what we are talking about. The traditional glucocentric approach, what Tejas had put up, which we used to do it back in 2005-06. So the current paradigm in diabetes is glucocentric, we know, being exclusively categorized by the glycemic characteristics. So the glucocentric paradigm views hyperglycemia as the primary target. We all know that, and that's what we are debating today, which it views hyperglycemia as the only primary target, which is driven by the resistance to insulin combined with the progressive beta cell failure. And it considers the glycemic control its ultimate treatment goal. And that's the problem. Is most importantly, the glucocentric paradigm, which most of us used to follow, it has not considered the non-glycemic diseases associated with it. That's the basic problem, as you can see on the right-hand side. And that is where we are trying to move towards from this glucocentric approach to the ASCVD approach. So if you look at this therapeutic advances, there is more than 40 new molecules have been since 2005 after metformin. I think this is where we end up today. And look at this slide, which is people with diabetes and glycemic control in India. This is about only 23%. So only 1 out of 4 are controlled well.
And what does it result in? It results in all these complications. More than 50% of them end up with microvascular, more than 25% macrovascular, and about 25% in DKD. And despite available all these numerous. So this is my one slide, which will summarize literally my approach or my argument that only glucocentric is not going to be enough, because managing diabetes is targeting the basic pathophysiology of diabetes, not only the glucocentric. It has to preserve the beta cells, of course, with reductions of A1Cs and SPG, PPG, but it doesn't end there. That only forms 1/4 of this pie. Minimal risk of hypoglycemia, meaningful weight reduction, proven CV efficacy, and this is where the renal or hepatic impairment with tolerable side effects.
Only I have to put the effort.
So this is where we are ending today. That is why it is not only the glucocentric approach what is required, but you require a 360-degree care with a cardiometabolic approach. And that is why I said, Dr. Tejas showed us the case with only the FPS, PPBS, and A1C and his age, and never talked about the cardiometabolic risks, which we need to evaluate at baseline so that we prevented the complication. At the end of the day, whether it's glucocentric or the cardiometabolic approach or the ACVD approach, what we are trying to do, our essential goal is to prevent complications. So this is the multiple pathophysiological defects what have been identified and the various class of drugs. And that is where the glucocentric approach is void and null, because we need to choose the right drug at the beginning so that you prevent complications. And that is where the problem is with only the glucocentric approach, because you don't categorize risk stratification. And this is by the statement by Dr. Di Franzo himself way back in 2009. He said multiple drugs used in combination will be required to correct the multiple pathophysiological defects. Treatment should be based upon reversal of known pathogenic abnormalities and not simply on reducing the A1C. So this is the message from the big boss itself. So the therapy must be started early to prevent or slow the progressive beta cell failure that already is well established. So paradigm shift in treatment is recommended. And this is what we're talking today about, instead of targeting only the glucocentric. Because see, even today, the way back, the euglucan tablet, which used to be used, is a very potent glucose lowering agent. But we almost stopped this, except in certain places in the government sectors. Except there, we never use these molecules now, if you remember, glibenclamide. And this is where we have moved on to SGLT2 and GLP-1s. Now, why is that? Because we are not targeting only the glucocentric approach, we are targeting the cardiometabolic approach. So the person-centered, outcome-driven treatment is the key. And this comprehensive and multifactorial treatment approach, which has to start in the beginning of diagnosis, it widens to address the continued cardiovascular risk continuum, and the latest guidelines, whether it's ADA, ESD, ESC, all these guidelines on hyperglycemia management recommend an approach that represents a paradigm shift in the management of diabetes. And this traditional glucocentric strategy has given way to a more expansive approach, which seeks to tailor the pharmacotherapeutic regimens, which are individualizing. So this is just what they just also showed the expenditure, because it's out-of-pocket market in the country. So I'll skip that slide. Look at this Indian study. The cost increases with comorbidities and complications. So if you don't diagnose the comorbidities and if you don't have the cardiometabolic approach initially, and this is where you end up with our patients, where the total cost because of the complications will add on to the patient. And of course, the cardiovascular diseases, we know this is the prevalence, which is huge in our country. I don't think this August gathering requires any definitions of these, so we'll skip this. But this is where we end up, and look at the numbers. They are the number one cause of death globally, the CVDs, and about 31% of all global deaths are attributable to this, and of these, 85% are due to MI and stroke. And CVD is expected to account for more than 22 million deaths. And this is where the cardiometabolic risk is highest, and that is what we need to prevent as a primary prevention when you diagnose a patient. We know that definitely there is an interplay between your diabetes and cardiovascular diseases. These are the basic pathophysiological omnes octet what we talk about. And of course, we need to target these multiple mechanisms whenever you diagnose for the first time. You don't just only look at the hyperglycemia, but you need to look at these basic pathophysiological defects to various molecules. How do you choose? You don't just choose a sulfonylurea just to bring down, because glibenclamide is the most potent agent which can bring down your sugars. But that is not what we're going to choose today in 2022. So that is where it is very important to tackle various molecules at various stages. And of course, the cardiovascular disease continuum we know, and this is the current standard of care which can reduce, cater, and bring down the risk of any diabetic patients. It has to be glycemic control along with the management of dyslipidemia, blood pressure, platelet inhibition, and lifestyle modification. So it is a multifactorial 360-degree cardiometabolic approach, which has to be done at 2022, not the glucocentric approach. And again, this is a publication which I'm showing. You look at the second point, the treatment should be based on known pathogenic abnormalities, not simply a reduction of A1C. And this therapy has to be started early in the natural history of diabetes to prevent progression of beta cell failure. Essentially, eat early, eat hard, and that is what we need to look at the patient as a holistic approach. This is a very important slide because just a lifestyle intervention associated with a reduced CVD mortality. And that's what I want to show, which most of us do not emphasize to our patients about lifestyle modification. We'll only talk about drugs, but definitely this is also a therapy which most of us fail to impart to our patients in our busy routine clinical practice. So insulin intensification outcomes in long duration studies. And this is what Tejas was also talking about, ACCARD, PDT, and VDTF. And this analysis of ACCARD indicated intensive glucose lowering could also increase the CV mortality. He rightly pointed out that I'm going to talk about this. Let us dissect these studies and see. This is the study design and look at the median A1C at each study visits and the outcome, the standard therapy and death from any cause. Literally, the increased all-cause mortality was seen in the intensive glycemic control. Probably it was attributed to hypoglycemia, but it did not significantly reduce the major CV events. And that's what I want to emphasize, not about the all-cause mortality in the intensive arm, probably due to severe hypoglycemias. So it did not reduce the major cardiovascular events. And VADT, Veterans Affairs Diabetes Trial, again, change in the median A1C, primary outcome, time to first major CV event. You can see no improvement was seen in the rate of overall survival rates. These are the CVOTs available for all the molecules. We know that. And of course, and the effect of SGLT2s, DPP4s, and GLP1s, we are very well discussed, but the sulfonylureas are very potent reductions in the A1C, but we don't use much now because of these disadvantages, which the MACE or CV death effects are not there. And in fact, in some of the studies they showed, all-cause mortality has been increased. So incretin-based, the GLP-1s we know, and we'll skip these, which definitely acts at a pathogenic levels, that is the omnisactide, and that is where we need to look at the effect of GLP-1s to reduce hypertension, dyslipidemia, glucose, and of course, obesity. And that is what we look at, the pleiotropic benefits of various drugs, so the cardiometabolic risks come down. These are all the various randomized controlled trials which are supported to these molecules. The liraglutide had a leader trial, semaglutide had Sustain 6, which was one of the earliest, where the 3-point MACE. If you look at all these RCTs on the top, you can see the years at which these were published. Albuglutide, I was all part of all these trials, including Harmony, I was a part of it. And 2019 dulaglutide, I was not part of dulaglutide study, but Rewind again showed all these. I'll show you the gist of this. Oral Sema, Pioneer 6 also I was part of. And this is the Sustain 6 and Leader and Harmony, Rewind, Pioneer. If you look at all this forest plot, it is towards the left when it comes to the MACE events, because I showed you the burden of CV deaths secondary to diabetics. And that is where we need to interfere at day one instead of only looking at the glucocentric approach. And this is the exenidine-based, the ELIXA and Excel studies. And I was part of both these ELIXA and Excel again. And they showed either neutrality or no positive, negative effect on the CV outcomes. These are all the proposed mechanisms because we know now we need to tackle, including the inflammation. The pro-inflammatory markers are more, especially in Indians. And that is where we need to look at the molecules which talks about reduction in the inflammation, increase in the plaque stability, and prevent progression of atherosclerotic plaque. So the chain of events which originates from the CV risk factors as a primary prevention we need to look at, and all these, the cardiovascular continuum, what we call, has to be chosen the right molecule to reverse this. And in a nutshell, the GLP-1s can take care about blood pressure, inflammation, weight, and even lipid levels, and of course, reduce the risk of CV outcomes. And the therapy is associated with the lower incidences of severe hypoglycemia is again an important factor, and it can modify, interfere as a primary prevention level to the progression of atherosclerotic vascular diseases. And this is what the set of molecules, the class of molecules, which has changed our approach to the treatment. And that is where all the guidelines have changed following the CVOT trials. And look at this declarative meticos, which is, of course, does not increase the CV outcomes of DPP4s, the SGLT2s, Empareg, Canvas, and of course, they now should be considered in all patients with diabetes and elevated risk of cardiovascular disease, even in the absence of established disease, with only the risk factors they've been chosen. And this is another paper which talks about that they work better, the DPP-4s and SGLT2 in the Asian ethnicity. And that is again important for us as Indians because they have all become cost effectiveness. And the age-old metformin, which was discovered in 1957, approved by FDA only in 1994, definitely has got a positive role in the CVD. And I'm a strong proponent to use metformin in most of our patients. I think 99% of our patients should be there. These are all small studies, but definitely there is a positive effect on the CV morbidity and mortality with metformin always. And the other comorbid prescriptions, the co-prescriptions would be the aspirin, atorvastatin, ramipril in and such patients with a high risk of cardiovascular diseases. So conventionally, the stepped-up therapy, which was used, like say you can see there, ADA 2015 and then 2017 and ACE 2017. Look at the changes. And remember, all these guidelines are based on the meta-analysis or the RCTs, which has got highest statistical significance, and they've been changing for a period of time. And this is where you see from 2016 onwards, you can see there, Tejas is still in 2015 with the glycemic control alone. After that, the glycemic control definitely will be there, but you see the additions and how it has evolved, the paradigm shift, and that is what we've been talking about. They definitely recommend a cardiometabolic approach, and essentially we follow guidelines. It is a guideline, of course, it's not that every patient has to be done like this, but the guidelines strongly recommend the cardiometabolic approach in diabetics. And ADA 2020, which talks about the DPP-4 SGLT2, I think Tejas also showed this, so we will not get into that. But what is important is the consensus, which talks about the first-line therapy depends on the comorbidities, patient-centered treatment factors, including cost and access considerations and management needs, and generally include metformin and comprehensive lifestyle modification. This is where we need to stratify the risk stratification of each patient when they come in, not only the A1C, and then assess, and accordingly you proceed further. And that's where it's most important. So in established ASCVD, we know GLP-1s, SGLT2, and then the evidence on the right side, I'm showing the hierarchy as well, is the evidence-based. All these are evidence-based, RCTs-based, and that is where is most important, including our own RSSDI. You can see SGLT2s, established CVD. All these are included in our own guidelines as well. And look at this ACC decision path, which is very practical. I felt patients above 18 years, diabetes and established clinical ASCVD, no, that was the Dr. Tejas case. Insufficient evidence to recommend SGLT2 or GLP-1 for ASCVD risk reduction. And you need to do this. And without this, you cannot proceed further. If yes, ESRD or ongoing pregnancy or currently breastfeeding, the absolute contraindications. If there's no, then consider SGLT2, GLP-1s and you proceed further. And that's what we need to do today. So it's time for action to address this omnisacted, not the glucocentric approach. Again, I'm ending my humble submission that the glucocentric approach is not enough. This is what we should look at in a holistic manner. The 360-degree care, which is very, very important in this era of 2022, that the cardiometabolic approach will only prevent. And Ralph DiFranzo's statement, a paradigm shift in treatment is recommended because the treatment should be based upon reversal of known pathogenic abnormalities and not simply on reducing A1C. Thank you very much, sir.
Thank you so much. Both the experts put their points very, very effectively and with the evidence base. Yes, both the experts would agree that this is an era where we have to be not only glucocentric, not only vasculocentric, but we have to be glucovasculo-adipocentric, as well as we have to be proactive in our therapy. We need not to allow that A1C to raise and then intensify the therapy, but we have to be proactive in the therapy, as well as we have to be holistic in our therapy. That was considered Dr. Srinivasa sir as well. So, Dr. Anjuman, any comment from your side?
So I think rather than glucocentric or cardiocentric, we can have a patient-centric approach. That is what I think both Dr. Tejas as well as Dr. Srinivasa said. Glucocentric approach is important because that is where patient comes to us with that concept, because I think by now as a diabetes fraternity, we have created enough awareness that once your glucose goes up, you are at risk. But we have to take one step ahead and see that there are so many cardiocentric parameters that go bad even before the glucose goes up. So we don't really have to wait for glucose to go up to have our approach towards the patient. But at the same time, I think glucose also plays its very important part in management of these patients. That are parameters that are easily seen easily made into an evidence-based protocols. So I think both the approaches are important. Both the talks were very wonderful, clinically relevant as well as evidence-based. And I think it will be the patient-centric approach that wins, or do we have to rebuttal?
I think that is the best comment, Anjali. We need to be patient-centric, and then probably we'll do justice to the patient, seeing overall profile of the patient, whether that patient requires a glucocentric approach immediately or requires primarily an atherosclerotic cardiovascular disease-based approach. So I think that will be wonderful. So onus is on physician to use prudence in right and best interest of the patient. Very well said.
So no objection for glucocentric. It has to be plus. That is what I'm saying.
Both.
Glucocentric plus. Tejas is ending at plus. There is no plus for Tejas. Only glucocentric. That's what
one comment.
Ansari sir wants to say something.
Yes, sir.
Yeah. So my just comment is that it should be a comprehensive approach. Because the data which you showed from even any trial, there is no trial, in fact, which is really segregated glucose versus cardiometabolic risk factors. UKPDS, they treated everything. You showed a multiple risk factor intervention trial, they treated everything. Accord, VADT, advanced, all the risk factors were treated together, in fact. So it's a comprehensive control of glucose as well as the risk factors are required to control the. If you talk about the glucose as a cardiovascular risk factor, in fact, it is very poor. It is not so high risk factor as far as the vascular disease is concerned. It's a more hypertension, more oxidative stress, more dyslipidemia, smoking. They are really more important for that. That's why even in a UKPDS data, if you see that 1% reduction in hemoglobin A1C could reduce 37% microvascular. MI was 14%, which was not statistically significant. However, in the long run, it could show. So it is a comprehensive control of diabetes is required, and it should start early. It should start simultaneously, and it should start from a day one.
Thank you. Wonderful, sir.
Thank you.
Absolutely.
Two words of wisdom, pearls of wisdom. I think we'll have to conclude this session here only and then go on to the next session. Dr. Shalini.
Thank you so much, Dr. Murthy and Dr. Tejas, for that great debate.
Pleasure.
I'm sure we've all enjoyed it. And many thanks our chairs, Dr. Vipul and Dr. Anjali, for being such great moderators. Many thanks.
Thank you so much. Thank you.
Thank you.
Thank you, Vipul. Thank you.
So it's time now for our last symposium, a mixed bag with a lot of great faculties. So obviously, we're chairing this session, and I'll request Dr. Chawla to formally introduce Dr. Bhansali, sir. I'm sure his stature is too great. We all know him well, but formalities.
I think Dr. Bhansali needs no introduction, even on an international platform. Has been Professor Head, Department of Endocrinology, one of the longest serving professor in endocrinology at PGI Chandigarh, has outstanding investigator awards and has received Professor B.S. Raheja Memorialization, and best is also had B.C. Roy Award as a teacher. I think that is the best thing what can happen to a teacher. Let's go to Dr. Bhansali straight away.
Thank you. So should I? Yeah, visible?
Yes, sir.
Audible?
100%.
Yeah, thank you. So what I'm going to talk about today is an upstream approach in the management of diabetes. And what do I mean by upstream approach is that you target the most important risk factor for the development of a diabetes, which is likely to be an obesity. And if you target it from day one, or if you target it even from the beginning, you can prevent so many things: cardiovascular disease, even the emergence of diabetes, and even the associated comorbidities. So now the focus is going for the early and aggressive, rather a prevention of diabetes and prevention of diabetes-related complications. So my approach will be, burden of, I think I'll just leave it, yeah. So what is the burden of diabetes? So it's around 60, so this was the data by the Dr. Bhuraskar and Dr. Mohan et al. I think we also published the same in Lancet Diabetes and Endocrinology. The 67% of the people with type 2 diabetes in India have obesity. So it's a huge number. If you take the overweight and obese together, it makes around 87%. So it does mean that almost 90% of the people either are overweight or obese in patients with patients with type 2 diabetes. Then you have a 7-fold higher increased risk of all-cause mortality. And then the furthermore concept of a thin fat Indian, where the more visceral as well as the subacute fat is present and lean muscle mass is low. So that further predisposes for more beta cell dysfunction and insulin resistance. So now we say that there is a new term which has been recently coined as a sinister synergism. What do I mean by that? The physical factors or the physical environment currently, the social environment currently, and even the personal environment, including this, which includes your sleep disorders, inability to be active, stigma and impaired mental health, eventually leads to adiposity. And this adiposity contributes to both insulin resistance and beta cell decomposition, eventually lead to diabetes, and then the vicious circle starts, where the medication-induced weight gain, hypoglycemia, neuropathy, and further going into depression. So the vicious circle starts with adiposity, followed by diabetes, and eventually the circle moves and both perpetuates. The adiposity increases with worsening of diabetes. So complications due to increased body weight, I think everyone, there is no need to recapitalize. It's a cardiovascular and non-cardiovascular. And you can see that the non-cardiovascular are too many as opposed to cardiovascular. And now the approach is an upstream approach, means to target obesity, or now called as a adiposity or a adiposopathy. And then in a downstream, and you don't wait till the hyperglycemia develops. So you control the glucose, or you control even the emergence of hyperglycemia even prior to the onset of diabetes. The importance of upstream approaches such as weight-centric intervention would lead to it disrupt the underlying pathophysiology of type 2 diabetes. It may slow down the disease course, and concomitantly the because the pre-diabetes, we say it is called a ticking clock hypothesis, where the complication starts, where the cardiovascular risk factors and complications starts arising even before the emergence of hyperglycemia. So even if you control at that point of time, the risk for a cardiovascular disease may really go down well. So you see that after the emergence of a diabetes, the cardiovascular risk remains almost stable. It is a microvascular complications, they become much more, they rise progressively. While in a pre-diabetic phase, hardly there are microvascular complications, but the risk of macrovascular complications is at peak. So I think targeting obesity at a time when you are evoluting with the diabetes, that will be very, very important, and that will be very, very pivotal to prevent the complications. So this is the data shows that if you lose weight, and here there is a weight loss something around 5 kg, and you reduce the risk by 10%. So I think losing weight reduces the risk of diabetes, and similarly, the weight loss, if the diabetes is already emerged in, then the weight loss can lead to good diabetes control, and it is both hemoglobin A1C and fasting glucose, they correlate with change in hemoglobin A1C. Then the direct trial, I think, gave a lot of vision into that. You can have a remission of the disease. And it was not a 15%, it was a 15 kg weight loss led to reversal of the disease. And the 15 kg of weight loss was associated with loss of 1 gram of the ectopic fat in the pancreas. That was a very crucial, that you had such a meager amount of the fat in the pancreas that is ectopically in place. So when you lose 15 kg of your body weight, you lose 1 gram of the pancreatic fat, and that led to a reversal of diabetes. It means that ectopic fat could lead to, or elimination of the ectopic fat could lead to improvement in beta cell function and a reversal of the disease. So greater the loss of the weight you have, a greater is the outcome as far as the reversal of disease is concerned. So many pharmacotherapies, lifestyle diet, and even a metabolic surgery, everything is there. I'll be just talking about the semaglutide. We have already experienced the liraglutide in the past. So this is a new molecule orally taken, so more comfortable with the patients. So this is the unmet need in a weight loss therapy. That is mainly because of a molecule that can address the need gap. And you can see that This provides some multiple benefits. So that is not only weight, hypoglycemias, your sugar profile, your side effect profile, your cardiovascular benefits, and approved for a variety of patients. So how does the semaglutide it acts on? It acts on from a direct pathway as well as indirect pathway, and this is acting on area proxima and nucleus tractor solitarius pathway and increasing the satiety. And remember that it is a mainly satiety which is increased. There is no much change in resting energy expenditure. So it is basically a reduced food intake is responsible for a change in a weight. It is not the increased energy expenditure is responsible for the weight loss. So here is the data, the body weight and body composition change with oral semaglutide versus placebo. You lose a very, very modest amount of a lean muscle mass. That happens with any weight losing therapy, but mainly the body fat mass is remarkably reduced. If you go further, the data in a different pioneer studies, how many people, 8 out of 10 could achieve a hemoglobin A1C below 7. More than 50% of the people could have a weight loss of more than 5%. Up to 5 kg weight loss was seen in all pioneer clinical trials and showed a consistent weight loss which was sustained. It's very important that if you continue, then it is sustained. If you discontinue, there is almost 2 to 3 kg weight gain or say around that. So, but still you may remain 3 kg minus. But for this sustenance, you have to do effort after discontinuation. But if you continue with therapy, the weight loss will be maintained. And then the consistent weight loss regardless of age. So everyone loses the weight at any age. And lastly, the consistent weight loss regardless of background medications. Even someone has been on a diabetes earlier, they may still lose weight. And lastly, the 1.5% reduction in all clinical trials, but that is the baseline hemoglobin A1C was something around 9%. So ADA 2022 standard of care recommends this class of drug. And now I think the metformin is still there, no doubt, but the metformin has been shadowed down. And I think the more focus has been on ASCVD. And we just had a debate, the more focus on ASCVD and glucose, the more focus I will say on comprehensive control of diabetes. So this is just as a one case. And what I just wanted to stress with this case is that you target obesity as early as possible, because that is highly prevalent and that is one of the proposing and perpetuating factor for the worsening of hyperglycemia. So this is a gentleman who has got a hemoglobin A1C of 8.1 and who has got a body mass index of around 27, if I see correctly. And then we see that the diagnosis with he has been initiation on metformin and lifestyle modification and multifactorial treatment we usually start. Then we try to prevent complications. And here we see that this after the lifestyle intervention, current treatment is already on a glimepiride now also. But the patient concerns are he has got a symptoms of ASCVD, one, and secondly, his father died at the young age, 57 years, and he has also experiencing hypoglycemic episode from baby. In such scenario, so like 3 years you waited for giving the OHA lifestyles plus metformin and sulfonylurea. There was a progressive increase in BMI from 30 to 31. There was a change in the weight around 3 kg. The hemoglobin A1C worsened by 0.2%, and urinary albumin creatinine ratio increased from less than 30 to 40. So you find so much of change, and you see this journey of glycemic control eventually worsen. And later on, the other cardiovascular risk factors were targeted, and GLP-1 receptor agonist was added, and you see that. So after 3 years, the hemoglobin A1C is below 7. The weight is reduced by, you can see the 13 kg. So a 13 kg weight loss with that. Blood pressure is controlled, ACR is returned back, and EGFR is, yes, again there's a rise, and LDL cholesterol. So I think if you are targeting early this obesity component, which is an important risk factor for many other comorbidities, I think you can overcome this. You can overcome the emergence of complications. So we should be very, very aggressive in that. And yes. So to summarize, So global and national burden of diabetes is increasing and is complicated by inadequate treatment and emergence of comorbidities. High body weights is an emerging syndrome leading to adverse patient's outcome. An upstream approach, I think that we wanted to focus on that. If we focus on obesity to begin with, I think that should be this. And fortunately, the semaglutide has also been beneficial on cardiovascular outcome. So that gives a double advantage in that way. And they are overreaching benefits by not only beyond hemoglobin A1C control, and it's a valuable place in upstream approach to type 2 diabetes. Thank you.
Thank you very much.
Yeah.
I think we can straightway go to the next session. That is by none other than Professor Mohammed Hasnain. Yeah, he has already been introduced, but still I think some new delegates must have joined in. He's a very, very close friend, senior consultant in endocrinology and diabetes at Dubai Hospital. Dubai has now holding post of professor and has been a adjunct professor again at Cardiff University, UK. And he was also appointed to the post of consultant.
Chawla sir, can you mute yourself in the other hall, please?
Sorry. Yeah. So with that little brief introduction, can we have Professor Mohammed with us?
I'm here.
Dr. Mohammed, yeah.
Thank you very much, Rajiv, and the wonderful day as well today. I've attended and I was interested to tackle the debate, but I thought my debate is my session, actually my presentation itself, or my opinion about it is my presentation. So you can see from my title that I personally think that hyperglycemia is the forgotten enemy. So I have no confidence for this presentation. And obviously, I don't really need to repeat what you all know, that diabetes is a massive global problem. And India, similar to many other regions with high prevalence of diabetes, is one of the areas where diabetes is a true epidemic rather than the COVID. And you all know, you've been discussing this all the last 2 days, that hyperglycemia is a cause of cardiac, renal, and many other complications, not just the cardiac and the renal. The retinopathy, the foot, the neuropathy, have lots of complications. And these complications are indeed the major cost for the person for diabetes, or indeed for the organization that pays for the cost of diabetes, whether it's the individual or an organization that cover their expenses. Now, if you look into the data on retinopathy, you will see that this data shows a very significant prevalence of retinopathy across many countries. Some of it is vision threatening and some of it is not, but certainly it would affect the quality of life and the vision of the individual. And we know that retinopathy, similar to nephropathy and neuropathy, are all terribly related to glycemic control. That is something you all know, it's a given, it's sort of imprinted in our minds about the direct link of hyperglycemia and specifically microvascular complications. When you look again into renal aspect, the top point for risk factor for nephropathy is hyperglycemia, followed by many other important points. Now, we have the cardiovascular outcome trial, and no doubt they made a significant change in our attitude. But I feel personally that we kind of focused far too much on this and we forgot about the rest of the body. And what after I start my patient on an SGLT2 or a GLP-1? After all, I still have a person with hyperglycemia. And I'm delighted that during the ESD-ADA presentation, that medication for glycemic management were the first aspect of the discussion rather than the cardiovascular and renal aspects of management. Not that this was deliberate, maybe it was, I don't know, but it gave me a hint about the serious importance of not forgetting about hyperglycemia. So we need just to reflect, and I put this photo of one of the beautiful cities in Egypt called Aswan at the south of Egypt, the furthest southern city in Egypt, where the Nile is beautiful. And when you look into what is recommended for glycemic management, of course, as mentioned by my earlier speaker, that metformin is not necessarily the first choice, but certainly is very important to consider as a first choice. Whether it's metformin or anything else, glycemic control is very much stressed upon by the latest consensus of ADA, ASD together. You know this information from Diabetes UKPDS study, that every single 1% reduction in glycemic control would reduce diabetes-related death, microvascular complications, amputation, stroke, and possibly even myocardial infarction. Now, the interesting thing is, when you look into the last 20 years, or perhaps 17 years, you will realize that we have had much more increased number of lines of therapy that were not available to us in 17 years ago. Certainly at the time of the UKPDS, we only have sulfonylurea, metformin, and insulin, and even metformin was very new to the United States at the time. And we gradually got more and more medication. Most of them have less side effects for hypoglycemia and for weight in comparison to insulin, as well as to the older generation of sulfonylureas. Having said that, as you can see, there's been no change in the level of those achieving an HbA1c of less than 50%, which is really quite puzzling. With all the presence of these options that can give us a plethora of options, nevertheless, there's been no change in the glycemic control level. And if you to look into this particular set of data of 1.6 million persons, you will find that only 54% from data from the USA, which is obviously a very powerful economy and infrastructure for health, only 54% are achieving an HbA1c of less than 7. If I were to look into other data from Europe, and you can see it's more or less the same. Those achieving HbA1c of less than 7 are at best around 40-41%. So the majority of patients in Europe, as well as in USA, are not achieving this good glycemic control. We looked into data from my hospital in Dubai, and as you know, Dubai is a wealthy emirate and with very strong infrastructure. Where I work in the Dubai Health Authority, the infrastructure is pretty solid. Having said that, still only about 39 to 37% are achieving an HbA1c of less than 7. So it does not look like the presence of multiple therapy with all the nice profile of less hypos and less weight gain and all of these issues, or the presence of a strong infrastructure, that we have moved very much. I share with you here the data from a survey that looked into people from 12 different countries. This is a survey of 5,865 persons. So let's say nearly 6,000 persons. And again, when you look into this is from Morocco down to Malaysia, including India and Pakistan. So when you look into those with HbA1c of less than 7.5, or not even less than 7, it is only 36%. So the situation is not really very good. And the big question is why? Why, despite all this availability of therapy, as well as good infrastructure and systems in many cases, we are not achieving the level of control? My good friend from Bordeaux, from France, Gerard Reach, has looked into this, and he classified the factors into physicians-related, patient-related, and healthcare system-related. All of them are important points that make sense. And I guess we need to stop and look into all of these important points and reflect upon them. Again, the latest AAESD recommendations are asking us to think. And when we talk about weight management, it is interesting that this is also part of the center of the focus. But then you need to think of how much time do we spend with our patients. So India here is among the group of less than 5 minutes per consultation. If I were to go to UK, it's between 5 and 10. If I go to UAE, it's between 10 to 15 minutes. So whether it's UAE, UK, or India, we're spending less than 15 minutes per individual patient. And obviously, we have no facility to see our patients very frequently. In my hospital, I see them every 3 to 4 months, unless there's an emergency. So certainly, the aspects that we need to address, I want you to think when the ADA-ESD say we need to look into all of these aspects, how can you do them in 5 minutes or 10 minutes? This obviously is very important. Egypt here is less than 10 minutes. So it is really quite crucial that we start thinking. One of the crucial points is perhaps we need to remember again the efficacy of the therapy. And this is one of the major points that is stressed upon by the ADA-ESD consensus. Efficacy of the therapy that we choose, whether as monotherapy or combination therapy, and whether this combination is a combination of oral or a combination of injectable or both, is very important. And they specify which drugs are considered to be highly efficacious, which drugs are considered to be high in efficacy, and which drugs are considered to be moderate in efficacy. The other important point is us. It seems that we have a level of inertia. We do not move and to change or optimize treatment and intensify treatment until it's relatively too late. And the data from Cambridge County in UK and others in Europe is a stark example of this. We start to look into excuses for this. If someone has kept their mic open. So the time, the therapeutic inertia with delays in time to treatment for intensification is quite startling. When you look into moving from monotherapy to dual therapy for people on metformin only, how many will wait until they move or intensify their patients? How many are intensified? 48% only after 6 months. And if the HbA1c is above 8, it's not many either. And the same would apply for those who are on dual therapy as well. This is something that we need to change because it contributes to the comorbidity of our patients. The retinopathy, the retinopathy, the neuropathy, and indeed all the macrovascular problems are part of the inertia. So the intensification of treatment, as I mentioned, and been mentioned several times in several studies, if we intensify immediately rather than delay or never intensify, there's a clear-cut difference in HbA1c and in the level of those who are achieving the target HbA1c of less than 7. Over double the percentage, nearly triple the percentage of those who are intensified immediately versus those who are delayed in intensification. I think Dr. Anil mic is open, and perhaps he'd be kind enough to mute his mic. Again, I show this slide of the different lines of therapy and the fact that we're not achieving the treatment targets. Insulin, for example, there is loads of types of insulin. So the primary care physician or the non-specialist could well be confused with all of these options of oral therapy and injectable therapy, which one to choose and how to choose them and how safe it is. And this is really the point that was mentioned on many occasions during these 2 days, the role of education. This is a must because this is the area where we are all deficient in. We have not got many structured education programs that are delivered in our clinics and in our centers. And this self-management of diabetes is a crucial point. It helps to improve glycemic control, reduce hospital admission, improve person with diabetes knowledge, improve clinical and psychological outcomes, and it's certainly cost effective and could with all of this, reduce or cause mortality. So self-management of the diabetes with education and support should be embraced and should be given a level of importance as much as pharmacotherapy. We should identify and know how to access these resources, and we should make the person with diabetes aware of this and aware of these options, and do it at the time of initiation of treatment and again on an annual basis and whenever the social or clinical circumstances of the person change. So my take-home message is hyperglycemia is directly related to all diabetes-related complications. Perhaps for some it's much more evident, and for others it is less, but certainly it's a very crucial factor. We must try to start treatment as early as possible, and we must look into measures that will help adherence of treatment and reduce physicians' inertia. Structured education and multidisciplinary approach is very much required, certainly in MENA region, and I guess for all of us today listening, this is probably something important. Finally, I'll leave you with the photos of my beloved city, home city, Alexandria. Thank you.
Thank you so much, sir. I think that was very, very pertinent and important because all of us ultimately are there to treat our patients with diabetes. And the whole idea of treating them is to improve the quality of life. So I think this is something that we all need to understand. I request you to stay back for the question answer session.
Sure.
So we now move on to our next session. Again, a very, very important session, and we have a very prolific speaker again. I welcome Dr. Rakesh Sahai, sir, who's going to talk on statins plus ACE inhibitors plus a gliflozin and a glutide. Does that translate into immortality? He's a very well-known figure, President ESI, Vice President South Asian Federation of Endocrine Societies, a great academician, currently Professor and Head Department of Endocrinology at Osmania Medical College and Hospital, and endocrinologist at Sahai's Endocrine and Diabetes Center. We all see him all across, multiple awards, multiple orations, and a lot of hats that he wears. Welcome, sir.
Thank you, Dr. Shalini, for the kind words of introduction. I thank you and Dr. Rajiv Chawla for inviting me to this very interesting session, important session, and also I thank you for giving me an interesting topic to speak on. So I hope to. I'm in a session which has really great speakers who are here. So I hope I am able to live up to the expectation. So I will share my screen. Is my screen visible? Just a second. Is my screen visible?
Yes, sir. You just need to put it in slide share mode. Yes,
Yeah.
Perfect.
Yeah. So thank you, Dr. Rajiv Chawla, for giving me a very interesting topic, which states whether statin plus ACE inhibitor plus gliflozin plus glutide. We have seen benefits of all these classes of drugs, and whether combining all this would lead to immortality. So I'll try to discuss that by looking at briefly discussing about the global burden of type 2 diabetes, looking at the complications and how they impact the lifespan of a person, and then the various interventions that we discussed about the role of statins, the role of RAS blockade, and the SGLT2 inhibitors and GLP-1 RAs, which have really taken brought about a big impact in the management of type 2 diabetes, have changed the algorithm and also our approach to the pharmacotherapy of type 2 diabetes, and then briefly discuss about how this could have an impact on the lifespan of an individual, and can we really achieve immortality in diabetes. So that's what I'll try to do. So if you look at the issue of diabetes, we know that diabetes is a huge challenge. Dr. Hasnain has also just discussed about the various aspects of diabetes management. He has highlighted that about the glycemic control, how important the glycemic management is, and we have seen that this is something which is always a elusive goal. Glycemic control is very poor. Only 20% or 30% of our patients actually reach the glycemic goals that we're looking at, and there are many other issues that have to be looked into, and we find that if you look at our own patients in India, we're finding a significant problem in terms of the development of diabetes at a lower BMI, lower at a younger age, and the higher risk of cardiovascular complications in our patients, and all that leading to higher mortality. As you can see, with poorer glycemic control, the risk of complications is significantly increased. We have information about this right from the days of the UKPDS study, almost about 3 decades back. We have understood this issue, that higher HbA1c leads to higher risk of complications, and it is also more beyond the microvascular complications. What we are worried about is the macrovascular disease. Particularly, we are worried about the fact that the macrovascular disease or the cardiovascular disease is much more common in Asian Indians, with as high as 20 to 50% of our population of diabetics being affected by macrovascular disease, and this contributing towards the being the major cause of morbidity and mortality. And we have seen that if you look at the life expectation in patients with diabetes across different studies and different population based studies, we can see that the life expectation comes down by about 6 to 8 years in the absence of cardiovascular disease, and in the presence of cardiovascular disease probably it comes down by as much as 12 years also in people with diabetes with cardiovascular disease. So this is the extent of the problem of cardiovascular disease in people with diabetes, and then so how do we address this? And we have data from studies like the Mr. Fit trial, which has looked at the various risk factors and shown how multiple risk factors actually amplify the risk of mortality in patients with diabetes. So this is clearly seen. This is a very old study, and this is something which has been the basis for understanding of the cardiovascular risk factors in people with diabetes, and it's clearly showing us that as the number of risk factors increase, the mortality from cardiovascular disease increases, and it is therefore necessary that we should address these risk factors and these risk factors which have a multiplicative effect on the cardiovascular disease and cardiovascular mortality. And then there was a lot of confusion in the days, earlier days, when we had results from different trials showing that glycemic control probably does not have a significant benefit on cardiovascular disease. The Accord trial, the UKPD, the Adopt trial, not showing adequate results. The Accord study showing that there is increased mortality amongst patients who are intensively monitored. Then the rosiglitazone fiasco. All all these actually caused a lot of confusion in whether glycemic control is the one which we need to look at, or whether we need to look beyond glycemic control. And all these trials actually shown us that CV benefit does not come with the glycemic control, but the silver lining was the follow-up of the UKPDS study, which did show that early aggressive glycemic management did bring about an improvement had a long-term legacy effect in terms of improving even the cardiovascular outcomes. And that also heralded a new era where we understood that we need to look beyond glycemic control alone, look at a multifactorial intervention rather than just looking at the glycemic control. And towards this end, I'm actually discussing about the role of these various interventions on the lipid management, interventions towards blood pressure management, and interventions towards then looking at the newer therapies for management of hyperglycemia. So if you look at the lipid trials, we have data from the earliest trials like the 4S trial and the lipid study, the VA HIT study. All of them showed that management of the dyslipidemia, particularly with the statins, there is a significant benefit. Even with gemfibrocil, you could see some benefits which was shown in both in primary prevention and secondary prevention. But the major benefit was seen in the secondary prevention trials, which looked at the use of simvastatin or pravastatin, where you could clearly see that with reduction in cholesterol levels, there was a significant benefit in the cardiovascular morbidity and mortality. This was in all patients. And then you have got diabetes analysis of subgroup of patients with diabetes, clearly showing again that the benefits were as good, if not better, in patients with diabetes as compared to the entire population of who received these statins. And particularly if you look at the HPS trial with simvastatin, when you look at the analysis amongst the diabetes patients, you see that clearly the benefits in terms of were clearly in terms of reducing the risk of cardiovascular disease in patients with previous MI, and those without previous cardiovascular disease. Also, you could see that there was a clear benefit, a 24% reduction in the risk of cardiovascular events with the use of simvastatin. And the HPS trial also showed that there was benefits beyond the cardiovascular risk reduction, even in terms of the stroke reduction, and also you could see that there was a clear reduction in the mortality in patients in cardiovascular mortality. The ASCOT-LA trial also showed, when you look at the subgroup analysis amongst the among the diabetic patients, again you see the clear benefit in terms of reduction of cardiovascular events with the use of atorvastatin in this case. And the CARDS trial was actually a landmark trial which looked at using statins in people who were having LDL cholesterol levels of less than 130. That the 130 was considered the cutoff value at that point of time, and that study again clearly showed that lowering the cardiovascular, lowering the LDL levels below that did benefit even in patients without previous cardiovascular disease, and clearly showed the benefit of the use of atorvastatin in this group of patients. And the benefits were also shown by rosuvastatin in a primary prevention trial. Rosuvastatin was clearly showing the benefit of a 44% reduction in the risk of the cardiovascular endpoints. So this was, however, in this trial did not include diabetic patients, but did bring in the problem of new onset diabetes as a major challenge. The HOPE-T trial, which looked at rosuvastatin and candesartan, also again showed the benefit of the use of statins in terms of reducing the cardiovascular events by 24%. Then, if you look at a meta-analysis of all these studies with the risk of with reduction in the cardiovascular cardiovascular events, you find that there was a clear risk reduction per 40 milligram reduction of LDL cholesterol. You see that there was a clear 20 to 25% reduction in the risk of major cardiovascular events, coronary revascularization, stroke, and major vascular events. All these coming down by about 20 to 25%. So clearly, statin therapy reduces cardiovascular events in patients even without cardiovascular events, and clearly that has a benefit in terms of improving the survival of these patients. Role of RAS blockade is also again an important area to be looked at. And if you look at the HOPE study, probably that was one of the earlier studies that showed that that ramipril could bring down the cardiovascular events, and cardiovascular mortality would be brought down by 26% with the use of ACE inhibitor like ramipril. And the micro HOPE study, particularly which had patients with diabetes, you could clearly see the reduction in CV deaths brought down by to the tune of about 37% with the use of ramipril. And as compared to all the other, these effects were beyond the baseline therapy with all the other forms of other standards of care at that point of time. And if you look at the addition of aldosterone antagonists to the ACE inhibition, probably you have data to show the additional benefit that is there. And today we have agents like finerenone coming in. I have not discussed that aspect specifically, but that is again another agent which has clearly shown that there is a clear benefit in terms of the cardiovascular and renal events in patients with diabetes who are already on a ACE inhibitor. With the addition of this molecule, there is clear benefit. Now, if you look at the meta-analysis of all the ACE inhibitor trials, what we see is that there is a clear benefit in terms of the mortality, overall benefit with the ACE inhibitors, although the extent of benefit may be different with different types of ACE inhibitors. But on the other hand, if you look at the ARBs, although they may be very good in terms of reducing the renal outcomes in patients with diabetes, what we see is that in most of these studies, what we have seen is that there is a improvement in the renal outcomes in terms of progression of renal disease, but the cardiovascular benefits were not clearly standing out with the ACE inhibitor, with the ARBs. And when you look at a meta-analysis of the all-cause mortality amongst the ACE inhibitors and ARBs, you find that the benefits are more with the ACE inhibitors than the ARBs. So clearly you find that the ACE inhibitors stand out as compared to the ARBs in terms of the all-cause mortality benefits in patients with. Now, what we have also seen is that even amongst the glycemic agents that are used for glycemic control, we have positive results seen with the SGLT2 inhibitors and the GLP-1 analogs, putting them in the category where they clearly provide cardiovascular and renal benefits and reduce the 3-point MACE and cardiovascular deaths amongst patients with diabetes. So that has clearly changed our approach from being glucocentric towards being more of cardiovascular and renal. Looking at the entire holistic picture of looking at the individual as such, and not being just glucocentric. And so we could say that we have become vasculo-glucocentric towards with providing complete metabolic care with the use of the newer drugs like the SGLT2 inhibitors, which have benefits in terms of glucose lowering, having an insulin independent mechanism of action, having a effect on the blood pressure, having effect on and having the cardiovascular and renal benefits, and certainly effects on beyond this in terms of reducing inflammation and many other benefits that have been noted in the various studies. And there's a consistent reduction in HbA1c with a low risk of hypoglycemia, and clearly we have seen that these molecules are now becoming the first line therapy in most of our patients, particularly those with pre-existing cardiovascular disease, and also amongst the other patients also, where we are looking at weight being a major factor. Then we are looking at the use of these class of drugs, and there are several mechanisms which have been potentially proposed to explain the cardiovascular and renal benefits which have been shown in the CVOT trials, the renal outcome trials, which have clearly shown we have seen these benefits, and the mechanisms that have been proposed are many mechanisms have been proposed while we are looking at understanding their role further. But clearly we have seen these benefits, and if you look at just a glimpse of some of the trials, the EMPA-REG trial, which apart from the reduction in 3-point MACE, the 3-point MACE reduction was primarily driven by the reduction in the cardiovascular mortality, and the all-cause death was also came down significantly by 32%, clearly showing the benefits. And this is a illustration showing the outcomes and all the different cardiovascular outcome trials with empagliflozin, the canagliflozin, and also dapagliflozin, and clearly we have seen all of them having similar benefits in terms of the reduction of heart failure. And when you look at the reduction in 3-point MACE, we clearly see that there is the benefit in terms of secondary prevention is standing out with empagliflozin, canvas, and also in the canvas trial with canagliflozin. The dyslipidemia, however, had more of patients with the primary prevention cohort being significantly being present, and those being the heterogeneity being mainly because of the type of patients that were enrolled in these trials. But in terms of the heart failure prevention, we have seen that clearly all the three molecules stood out in terms of the heart failure benefits. And we have more details from the EMPA heart study. We have the Emperor study, the DAPA CKD study, and all these studies have clearly shown the effects beyond even in terms of the reduction of heart failure, and in terms of the renal disease, the reduction in the progression of renal disease, which was clearly shown in the DAPA CKD, and now with the EMPA CKD study also, the results being published just 2 days back, we clearly have seen the benefits with these agents. Now, coming to the role of GLP-1 RAs, as we have seen that these are another important class of drugs which have shown their benefits. We have seen their benefits in terms of all the benefits that we have seen. The fact that they address 6 out of the 8 core defects, and thereby have proved to be very good agents in terms of glycemic reduction, and also in terms of reducing improving satiety, reducing hunger, and having a significant effect on the weight reduction. And both liraglutide, semaglutide have shown these benefits in terms of, because of their effects on the hypothalamic centers, probably because of the being small molecules crossing the blood-brain barrier and having direct effects on the central appetite regulation. They have clearly shown in the phase 3 programs, they have shown clear benefits in terms of the weight reduction also, which probably is contributing significantly beyond the glycemic benefit towards the cardiovascular benefits that we have seen. And we have clear data from the cardiovascular outcome trials with leader trial showing a clear reduction in the cardiovascular deaths by 22%. Even the sustain 6 trial showing a improvement in the 3-point MACE, although the cardiovascular deaths and all-cause mortality did not change much, but the 3-point MACE did come down with the use of injectable semaglutide. And we are awaiting the long-term outcome trial with the oral semaglutide, the SOUL trial. While we await for that, we also have seen new excitement with the use of this dual agonism with with GLP-1 RA and the GIP-1 receptor agonism, which is coming in the form of this molecule called tirzepatide, which has clearly shown a very good glycemic benefit in terms of reducing the HbA1c by 2 to 2.6%, and so that almost 97% of patients reaching the glycemic target of less than 7%, and even almost 40 to 50% of patients reaching a target of less than 5.7%, indicating that they're going into a remission. And the major benefit is probably obtained because of the weight benefit that is seen with this molecule, in terms of almost a 15 to 20%, almost 12 to 18 kg weight reduction seen with different doses of tirzepatide, and with more than 90% of patients reaching a target of more than 5% weight loss, and more than 15% weight loss also happening in about 40% of patients. So having looked at these three agents, let us look at what actually, I mean, as you look at immortality, I mean, this has always been a quest for immortality, and we see that aging causes a lot of changes. There are a lot of changes which are happening beyond, I mean, in the sense that beyond the changes because of diabetes, there are changes happening because of various other factors, the stem cell decrease, decrease in telomere lengths. We have several therapies that have been tried. One of the important ones is calorie restriction has been important issue which has led to improving the lifespan, and exercise has been another important factor. Medications like the ones which you have spoken of. So can we become immortal? So we might be able to disguise some of the issues that come with the aging, but you know, we still are, this goal of being immortal is still elusive. We have various proven therapies, as we spoke about lifestyle, spoke about exercise, and even when you look at data from the STENO-2 trial, where we had a multifactorial intervention, not with the use of the newer glucose lowering therapies, but with statin, with good glycemic control, with the older therapies, and also with hypertension management, we could see that there was at least clear 12 years gain in life expectation with the use of with a multifactorial intervention. On the 21 year of follow-up, we find that there was a improvement in lifespan by almost 7.9 years gain in lifespan, and the first CV event was postponed by almost 8 years. So this clearly shows that, you know, although we don't have a intervention of this sort, looking at the addition of SGLT2 inhibitor and a GLP-1 analog to the existing therapies, but a study like the STENO-2 study gives us a clue that we can add years to life, and we should also, you know, be happy that we are able to add life to the years. So I think on that note, I would say that, you know, while immortality is still an elusive goal, we should focus on the fact that we are with the current therapies and with the combination that we're looking at, we have been able to add years to life, and also the most important part is that we have been able to add life to the years. Thank you all for the patient hearing. And
thank you, Dr. Rakesh. Dr. Shalini, may I introduce Professor Dandona?
Thank you, sir. I think perfect justice done to a topic that definitely couldn't have been elaborated better. We'll request you to stay back. So now we have our keynote address coming in, none other than Dr. Dandona, sir. We heard him yesterday also to a packed audience, if that is possible, on a virtual platform. And I'm sure he is somebody who does not really need an introduction anywhere across the world. So Dr. Paresh Dandona, Distinguished Professor of Medicine, Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo, founder, Diabetes and Endocrinology Center of Western New York. Recognized as one of the leading experts in the treatment of endocrine disorders, especially diabetes, obesity, and vascular disease. Multiple research, multiple hats that he wears, so many papers, original ideas, original research, so many publications, connections between inflammation, obesity, diabetes. He's done a lot of work in this field, and I would not like to stand before him and the great oration that he's going to deliver today on the hypogonadotrophic hypogonadism in obesity. Diabesity, actually. Welcome, sir.
Thank you. Dr. Dandona, sir, has been
Shalini. Can you take charge of my slides? Can you guys take charge of my slides so that you can move them? Yeah,
sure. So Mahima, do you have the slide set?
Yeah, she's done a great job yesterday.
So please.
So thank you, Mahima. So what I'm going to be talking about is something different from what has been the topic through the morning or my morning and your afternoon, evening, to talk about a new syndrome. a new syndrome of hypogonadotropic hypogonadism, which we discovered and described for the first time in 2004. And what I want to mention right straight away is that the frequency of hypogonadism in the male type 2 diabetic is 33% at any time that you measure it. So you don't have to wait for it to develop, it is there. And therefore, it is as frequent as hypertension, as frequent as hypercholesterolemia. So you've got to look into the testosterone status of all type 2 diabetics. Now, the other point that I just want to mention, and I shall show you as I go through the slides, is that neither HbA1c nor the duration of diabetes was related to hypogonadism. It was only BMI. So we then investigated the issue of obesity and found that 25% of non-diabetic obese are hypogonadal as well. So if you put that term of diabetes and obesity together, diabesity, it is the commonest cause of male hypogonadal state. So now, let me come back to how we discovered this syndrome. In 1997, 2 years after I started my center here in Buffalo, came Viagra, sildenafil. And in the New England Journal of Medicine paper that was published on sildenafil by Pfizer, 70 to 75% responded positively to their defects in erectile dysfunction. But in the JAMA paper that followed on diabetics with erectile dysfunction,
the next thing
you had
notice this syndrome was the fact
a prevalence
that the low
of
testosterone
only
were neither related to the duration of diabetes nor to HbA1c levels. The major correlation was with that with BMI. And
I don't know. There's a problem
Mahima,
now.
why is this echo coming? Is there a lag?
And this
you guys are recording my sound, so are you replaying it immediately?
No, Mahima, what's wrong?
Mahima, just check. It was not there earlier. Just check it.
Yeah, just go back to the first slide, please.
I think now
just go back. Just go back to the first. Yeah, that's it. Leave it there now.
It's okay now.
Yeah. Go back. Yeah, leave it here. Okay. So, as I was saying, that the way we discovered this was because a whole lot of diabetics who went to urologists who were prescribing sildenafil left, right, and center for erectile dysfunction, following the initial New England Journal of Medicine paper in non-diabetics, they found a whole lot of non-responders amongst the diabetics. And these patients were referred to me, fortunately, to look at what was wrong. And being a systematic endocrinologist, I measured their testosterone levels, I measured their prolactin levels, and looked at any other possibility that might be responsible for this non-response. It turned out that testosterone was low, both total and free were low in 33% of these patients. So that's how the syndrome was discovered. And the first paper appeared in Journal of Clinical Endocrinology and Metabolism in 2004. And you can see the data here, the differences in total and free testosterone between controls, eugonadals, and the hypogonadals. Now, the other interesting thing that happened was that LH and FSH were not elevated in spite of the low testosterone. So clearly, it was not a primary testicular defect. It was a hypothalamic, hypophyseal testicular defect. So clearly, it was a case of secondary hypogonadism, and therefore, we've given it the name hypogonadotropic hypogonadism. Next slide. And here you can see the beautiful inverse correlation with body weight and testosterone concentrations. The higher the body weight, the lower the testosterone concentrations. Next. And here, then we did another study just to see whether type 1s also had that syndrome. And these were younger patients with type 1 and comparable age type 2s. And you can see it's only in the type 2 diabetics that you have the hypogonadal state. Next slide. Next slide. Go back. Yeah. And here is the study published in 2010, where we showed that the obese without diabetes had hypogonadal state on the left, and on the right, if you had diabetes in addition, you had an increase in the frequency of hypogonadism. So 25% roughly versus 33%, 1/4 versus 1/3. Next slide. Next slide, please. And here, we then went to ask the question whether younger obese males also had this problem. And this was the first study published in the obese children between the ages of 14 and 20 years. And you can see the differences in the total and the free testosterone, significantly lower levels in the obese children. So remember this, that the syndrome is right across the ages. Now, this is an interesting cartoon which was published a year before we published our paper in 2004. So we downloaded it from the internet, and you can see here the beautiful male form of Michelangelo, of David by Michelangelo, standing in the Uffizi Gallery in Florence. And if you go to Florence, you must visit that gallery because it has amazing works of Renaissance artists, and Michelangelo is one of them. And then the cartoonist, in view of the obesity levels in the United States, just made this cartoon. Just go back. Please go back. Please go back. And you can see that on the right, after David had been to a trip to the United States for a few years, how his format changed. And you can see the tummy coming out. You can see the breasts coming out with extra fat. And you can see the deltoids melting away. And you can see the pectorals also melting away. And you can see obesity even in the thigh and in the legs. But what is most important in this one is his genitals. You can see his genitals have shrunk, almost disappeared. So this cartoonist obviously knew of the syndrome in obesity before we published it. So I just want you to remember this, because this image will stick in your mind and will remind you every time you see an obese patient, and you've been talking about obesity all evening. Please remember this, that hypogonadism is a part of being obese. Next slide. And here, the next question was, why does this syndrome occur? What is it in the obese that causes them to, or the diabetics, which causes them to have a low testosterone? And during one of my trips to the Middle East, actually in Dubai, I was giving a talk on this syndrome, and somebody got up and asked me as to why this occurs. And he said it could be due to increased obesity and the adipose tissue generating more aromatase, which is the enzyme that converts testosterone to estradiol. That may be responsible. So we came back home and did work on that, and I'll show you the data on that in a while. But in fact, that did not turn out to be the answer. The answer lay in this paper in mice who had a knockout of their insulin receptor, in the general knockout of the insulin receptor, and in the brain. And as a result, these mice developed hypogonadotropic hypogonadism. As you can see, the histology of the, please go back, don't rush, please go back, yeah. So you can see the seminiferous tubules shrunken on the right panel, and the and the seminiferous tubules perfectly normal in the left panel because of the knockout of the insulin receptor in the brain. So clearly, the whole syndrome starts in the brain. Next slide. And here is the next issue that we knew, and this is from our own work that we described for the first time, that in obesity and in type 2 diabetes, you have increased levels of inflammation and increased CRP. And here, again, in the hypogonadals, you had a high CRP. So that may have contributed to the insulin resistance in the brain. Next slide. Now, the next thing is to look into what is happening in the adipose tissue in these hypogonadal patients. And this is a very important part of my talk. So please pay attention. Although it is molecular biology, I'll try to make it as simple as possible. So if you take fat biopsies from these type 2 diabetics with hypogonadism, you find that at 4 levels of insulin signal transduction, there are deficits in the mediators. So insulin receptor beta subunit, insulin receptor substrate number 1, AKT2, which is an enzyme, and GLUT4. GLUT4 is the molecule that carries glucose into the cell from the surface once it's stimulated by insulin. So at all 4 levels of insulin signal transduction, there was a defect. Keep this in mind because we'll come back to this in a couple of minutes. Next slide. And here, another very important mediator, which is the AMP kinase alpha, also diminished both in adipose tissue and in the muscle. And what is important about this? AMP kinase is the one that mediates glucose uptake under the influence of metformin and exercise. So you were talking about exercise, lifestyle, and metformin a few minutes ago. So AMP kinase is the key enzyme that mediates the transport of glucose under the influence of exercise and metformin. Next slide. And that was diminished in these patients too. So now we come on to treating these patients. So we had these patients, and we had a large NIH grant to investigate the effect of testosterone in these patients over a period of 6 months. So this is what we did. So when we gave them testosterone over a period of 6 months, the patients who got the testosterone, you can see, had steadily higher levels of testosterone, whereas those who did not stayed at the bottom and did not change. Next slide. And with it, there was a change in weight in the testosterone group. A1C had come down slightly in the testosterone group, but did not change significantly. I'm sorry, A1C did not change significantly in the testosterone group here. HDL cholesterol, no change. LDL cholesterol, slight but insignificant fall. No other significant change. Next slide. And here is the key element in terms of body composition. So here you see that although the overall body weight did not change, total lean mass increased significantly in the testosterone arm from 70 to 73 kilograms. Total fat mass, on the other side, diminished. So this is a very important thing to remember when you're talking about adiposity, as you were earlier on in the various talks. Remember that hypogonadism will lead to further adiposity, and administration of testosterone will lead to a loss of fat, and this loss of fat is in the visceral and in the hepatic level. Next slide. And with it, we showed that there was an improvement in insulin sensitivity. So glucose infusion rates under hyperinsulinemic clamps showed an increase, and therefore, clearly, testosterone is clearly an insulin sensitizer. Keep that in mind as well. So all of these interesting properties of testosterone emerged out of our studies over the last decade. Next slide. And then I've shown you, I've already told you that testosterone increases insulin sensitivity. And then free fatty acids, which inhibit the action of insulin, fell, and leptin concentrations fell because adipose tissue fell. Next slide. And with it, you remember the false signaling points that I mentioned to you in insulin signal transduction, all of those four elements increased with testosterone. So clearly, testosterone at a cellular and molecular level and at a ghost level is an insulin sensitizer, causes a fall in adiposity and an increase in muscle mass. Next slide. And here AMP kinase also showed an increase. So the other element of glucose uptake was also improved by testosterone. Next slide. And then, in addition, we were able to show that testosterone is also anti-inflammatory. So you can see on the left, 3 pro-inflammatory elements, SOX3, which inhibits insulin action, IKK beta, which also inhibits insulin action, P10 also inhibits insulin action, was suppressed. And then on the right, you see CRP levels fell, and TNF-alpha, which is a pro-inflammatory cytokine, also fell. Next slide. And then the other interesting thing was that we had thought that with the hypogonadal state, perhaps there would be a compensatory increase in the expression of the androgen receptor. But in fact, it was the other way around. In fact, these patients have a double whammy. On the one hand, testosterone falls. On the other, testosterone receptor, androgen receptor, also falls. With it, there is a fall in estrogen receptor, and there is a fall in aromatase. And following, as you can see on the right panel, the following testosterone administration, they all reverse mathematically. Next slide. And here, again, we looked at, those were the expressions of androgen receptor, etc., and the fat cell. Even in the circulating mononuclear cells, you see similar changes. Next slide. And again, diminished androgen receptors in the muscle tissue of these people and reversal with testosterone. Next slide. And then the important part, and these two also are original discoveries because these elements were not associated with muscle growth before. So fibroblast growth factor 2 increased with testosterone, and in parallel, IGF-1, which has been associated with muscle growth previously, also increased. Next slide. Next slide, please. And then you see here FGF2 expression at the mRNA level in the muscle also increased with testosterone therapy. The receptor to FGF2 also increased with testosterone therapy. And then the factor that suppresses muscle growth called myostatin was suppressed, and another element called MRF4, which is also suppressive of muscle growth, was also suppressed. So clearly a very comprehensive action of testosterone at various levels to promote muscle growth that you saw in growth terms earlier on. Next slide. And then we come to the other issue. As you know, in the hypogonadal people, hemoglobin levels fall. They get anemia. And so we investigated that. And here we show very nicely that with testosterone treatment, erythropoietin levels increase, and the expression of something called hepcidin, or the concentration of something called hepcidin, falls. And hepcidin is the protein that inhibits the the release of iron from cells, which is done through a molecule called ferroportin, and ferroportin is inhibited from transporting iron from inside the cell to outside. So although you may not have overall iron deficiency, in functional terms, you do get iron deficiency because the iron that is circulating within the body from dead red cells and into the macrophages cannot be released and cannot be made available. Next slide. Now, having shown you all these effects of testosterone from our study, I next go on to a very interesting study which we carried out with Dr. Farid Saad, who's actually working with Bayer, who are producers of testosterone, but he has set up a center, a very nice center near Hamburg, working with two doctors, father and son, Haider and Haider urologists. And these data, just pay attention here now. So these are the longest treated patients with testosterone, up to 11 years with a mean of 8 years. And what you see here is the change in total testosterone. Of course, if you give testosterone, testosterone will increase, as I've shown you previously. So that happens. Next slide. And with it, look at the weight change. Steady weight change in the testosterone group versus a steady but slower weight gain in the non-treated group. So in this study, they had patients who were given testosterone and those patients who refused testosterone. And so they've served as controls, and that's what happened. And then with it, you can see now here, HOMA-IR is an index, a crude index, but it works. HOMA-IR as an index of insulin resistance. And you can see that in the testosterone-treated patients, the HOMA-IR steadily falls through this period of 11 years, whereas the HOMA-IR steadily increases in the group not treated. So clearly, another very beautiful piece of evidence that testosterone is an insulin sensitizer. Next slide. And here you see A1C. A1C steadily falls in the diabetics given testosterone, whereas it steadily rises in those not given testosterone over a period of 11 years. Next slide. And if you then analyze the data at the end of the treatment period, what you find is that 91% of these patients who were not given any additional anti-diabetic drugs got their A1C less than 7%. 83% got an A1C less than 6.5%. And 34% of the patients got total remission. They did not need any drugs at all. This is remarkable. Obviously, this study will have to be reproduced elsewhere because this is really sounds like science fiction, that you can actually cause a remission of hypogonadal diabetic patients with the administration of testosterone, but it's true. Next slide. And with it, you see survival curve, Kaplan-Meier curve for survival. And you can see the rate of mortality in the non-treated group in red is down to around 60% or less at 11 years, whereas it is around 80% or more in the treated group. And within that, if you analyze the cause of death, which is significantly greater in the control group, you see that it is due to myocardial infarction, stroke, myocardial infarction and stroke. And of course, the diabetic complications are also higher in the untreated patients. So clearly, testosterone has a very important role in terms of treatment in type 2 diabetes, and therefore it must be measured in every patient that you see with type 2 diabetes. Next slide. And here is a study on pre-diabetics, and you can see that in the testosterone-treated group, prediabetes remits within a few years, within 8 years. Next slide. Now, the latest study in this, well, one of the latest studies in this group is on bariatric surgery in adolescents. So this study called the Teen Lab study, teen for teens, they were 14 to 20 years old, and these patients were subjected to bariatric surgery, so they lost weight. So let's see what happened to them over a period of 5 years. Next slide. You can see weight fell and then flattened out at around 20 months, or 10 to 20 months it flattened and steadily continued that way. Testosterone levels steadily increased with weight loss. So clearly, obesity is the enemy of testosterone, just as testosterone is the enemy of obesity, as I showed you. So here is testosterone peaking at 24 months, and then some steady fall. Sex hormone binding globulin increases after, because as you know, sex hormone binding globulin is low in insulin-resistant patients. So it increases following weight loss and increase in insulin sensitivity. Next slide. And free testosterone also increased, peaking at 24 months. Next slide. And you can see that the increase in testosterone is directly related to change in body weight. Next slide. And here is a very interesting slide where we show the reversal of the increase in testosterone in those who got weight regain. So you can see in yellow, the patients who maintained their weight loss to the end. In red, you see the patients that regained, and those that regained, you can see in the blue line, also had a fall in testosterone again. So you can't really have a better evidence of the relationship of body weight with testosterone. So you start off with obesity, you start off with low testosterone, you reverse obesity, you increase your testosterone, you regain weight, you lose your testosterone again. Next slide. So having shown you this, I just want to show you 2 or 3 final slides. And these are very interesting as well. So this was a study done by Witter et al., who is based in Adelaide in Australia. This is an Australian study where they looked at the effect of lifestyle plus versus lifestyle plus testosterone in patients with sort of early type 2 diabetes and pre-diabetes. And let's see what they found. Now, why I'm sort of emphasizing this study a little is because the threshold at which they started treating with testosterone were not in the hypogonadal range. They were in the low normal range. And this is the first study ever to be done in the low normal range testosterone people where significant metabolic changes were seen again. Next slide. And here you can see that in these patients with early diabetes, after 2 years of treatment, you had only 12% who remained with diabetes versus 21% who remained with diabetes with lifestyle alone. Next slide. And blood glucose concentrations, fasting ones, fell by 1.7 millimoles per liter in the testosterone arm and only by less than 1 millimole per liter in the placebo arm. Next slide. And here is the group with pre-diabetes, and again, pre-diabetes was reversed, occurred, stayed only in 32% of the testosterone arm, and 45% of the placebo arm. So clearly, testosterone has profound metabolic effects. Next slides. And this sort of brings me to the end of the slideshow. But let me conclude then. Number one, that type 2 diabetes is associated with male hypogonadism, with the testosterone levels being low in 33%. Obesity is associated with hypogonadism, with testosterone levels being low in 25%. These observations have profound metabolic effects, and the major one, I've shown you a whole series of metabolic effects. The major one is that of insulin sensitization. So if you have obesity and male hypogonadal state, you will be insulin resistant and you will progress to diabetes. And similarly, as I've shown you through the data done with the Farid Saad, that over a long period of time, you might even reverse diabetes when you treat with testosterone. So the main take-home message here is, please measure testosterone in every type 2 diabetic patient and in every obese patient, because you will be rewarded with gratitude from your patients. Thank you very much.
Thank you very much, sir, for a wonderful oration. Like always, I mean, it was so gratifying seeing you after a long time, at least virtually, and listening to you for last 2 consecutive days. Yesterday also we troubled you towards the end because this is the only time which suits you also, and this way we probably have the largest number of logins glued to the screen till last. So I think this is what we have been using, always trying to have you towards the end of the session because that time suits you also. Mohammed, you want to interact something with him?
Yes, certainly, because
Dr. Saha is also there, all learned people around. So
2002, when I started my consultant job and went to my clinical director after the availability of PDE5 inhibitors to ask him that as a diabetologist, I will do men's and diabetes clinic. And with great resistance, they agreed. And as an endocrinologist, I started to test some of the hormones of these men and started to find the hypogonadism, which wasn't that 2002, before the papers in 2004. In fact, I even spoke to my gastroenterologist to say, I guess this anemia is nothing to do with ulcers or anything, is to do with erythropoiesis. And I wonder whether we can look into those that you screen for diabetics with endoscopies and to test their testosterone levels. So I'm delighted that afterwards, I didn't feel that I was a mad endocrinologist with all the data from Professor Dandurna and others to prove that, yes, hypogonadism in people with diabetes, specifically the obese ones, is a true entity, and it was right to treat them and to investigate them. We did further study on this prevalence here in Dubai, and I'm not surprised that the levels was quite high. So certainly the match of diabetes and obesity needs a proper screening for the testosterone level of many of these people, especially that certainly with their vascular problems, many of them are already complaining of ED. And Professor Dandurna, I believe that a lot of the work on PDE5 inhibitors on those who are non-responders, they also started to look into their testosterone level. And then when they started to supplement the testosterone level, they became responders to the PDE5 inhibitors as well.
You're spot on. I see this all the time. Yeah. So often patients with ED who have not been investigated for their hypogonadal state will not be responding to sildenafil. And then when they come to us and we measure their testosterone, treat them with testosterone, they then begin to respond to sildenafil. So, yeah, this is really in our unit a very commonplace observation.
Dr. Sahai?
Yeah. Thank you, sir, for the excellent presentation, and which actually gives us a better understanding of our patients with diabetes and obesity. So my question was whether we have looked at treating with testosterone. Is there any role for treating with HCG, because many of them have a defect, hypogonadotropic hypogonadism. So is there any role for using HCG in these patients?
Using what, sorry?
HCG injections,
Oh, yes, you can use HCG. HCG acts directly on the testicles.
Yeah.
So you can, but HCG is an injection. It's expensive. And testosterone also as an injection, but it's once every 2 weeks, 200 milligrams per 200 milligrams dose of testosterone cypionate works very nicely.
Yeah.
But there is another element here now.
Yeah.
Which is, and it's good you asked me that question, and maybe you can do something collaborative with us on that one. Because since the defect is in the hypothalamus and not in the testicle, and you're giving testosterone, and of course, most of our patients are middle-aged, and they've had their families, but when it comes to youngsters, and you give testosterone, you're basically blocking their upper axis, right? So what I have been doing recently, over the last couple of years, is to give these youngsters clomiphene. Clomiphene, which is the drug we use for women to ovulate, works through the hypothalamus. And it's remarkable that clomiphene, 50 milligrams daily, will give you testosterone levels which are adequate and in good range.
But is it better than giving testosterone, or you want to combine both together?
No, don't combine. One thing at a time. You don't need to combine, because clomiphene works and it's inexpensive. And the other thing is clomiphene is also, of course, in US, every time I prescribe testosterone, I have to sign another bloody form, and signing forms is a pain for a doctor, as you know. So because it's a restricted drug, whereas clomiphene, there is no restriction.
Yeah, just continuing that forward, taking that a little forward, is with the same men who desire fertility. Is there any role for this aromatase inhibitors?
Now, aromatase, since I showed you that aromatase inhibitors, in any case, in this case, are low. Aromatase enzyme is low. So why would you use aromatase inhibitors?
Oh, okay. So
it would make the situation worse as far as estradiol is concerned. But of course, I respect the fact that even males need estradiol to some extent. And
no, sir. What we are speaking about is blocking the estradiol conversion. So thereby,
so what is happening is, what we've shown is the original discovery that androgen receptor, estrogen receptor, and aromatase are all three suppressed in the hypogonadal state. When you give testosterone, all of them are restored to normal.
So what would be your preferred treatment, clomiphene or testosterone injection? Because if the choice is given to the patient to have a daily tablet, is better than a painful injection.
So I agree. But having said that, I need to also mention the fact that now oral preparations of testosterone are also available. It's called Jatenzo. I don't know whether it's available there.
It's available in India, yeah.
India also.
40 milligram capsules.
You have to give it twice a day. And of course, it works. I have several patients on it who don't want injections and who want oral alternative. And it works very nicely. But as far as clomiphene is concerned, I reserve it for the youngsters, because they still want to be fertile. They want to have, children eventually. So not only do they want to be males in terms of potency, they also want to be fertile. So clomiphene does that job nicely for them as well.
Perhaps we need some guidelines for not just the screening and the diagnosis, but certainly the management, since there are several options. And nowadays we're seeing lots of obesity and diabetes in young people, specifically in the eastern side of the globe, where certainly the issue of fertility would be an issue as well. So the options between injectable testosterone, oral testosterone, or clomiphene, or any other therapy, perhaps this is a call for some heads to get together and write some consensus and recommendations and even further research into.
So Mohammed, there is one thing I must tell you about myself. There is one gene that I don't have, and that is the political gene.
Yes.
And therefore, I'm never on any committees. Nobody invites me because I speak my mind all the time.
Well, we do invite you as the four of us, the three of us do invite you to join us, and perhaps we can put together some sort of...
we could certainly do so. And actually, we recently, 2 years ago, started a journal called Androgens.
Yep.
And we were all believers in testosterone, whereas there is a whole group in the United States, unfortunately, who are anti-testosterone, led by Shailendra Bhasin. Unfortunately, I am ashamed to say, he's a product of my medical school, All India Institute of Medical Sciences. He was 5 years junior to me. And he has led this whole stupid thing, which is blaming testosterone for cardiovascular complications and so on and so forth. So anyway, but the point is that I could also invite a couple of members from there. And it might interest you to know that the editor of the Androgens journal was a guy called Abdul Majid Tresh. He's from Libya, but he's worked in Boston for a long time. And we are all very close friends. We are all believers of testosterone. So certainly, I think we could create a group that could work out a guideline. Certainly.
Well,
so I'll keep that in mind. So you have sown a political seed in my non-political body.
we have cloned a gene in your blood.
only gene which you didn't have.
You see, the thing is, if you speak your mind, you become unpopular.
True, very true. we people make more enemies than friends here also. Same thing. I always speak truth, and that is how you people become so unpopular amongst lobbies, because no one wants to hear what is odd.
You see, one of the things, this is one of the things I tell my fellows: don't ever be shy of thinking something new. Come out with it, discuss it, talk about it, because who knows, you may have found something really remarkable. So don't put it under the carpet. Just, make it grow.
So, Rajiv, since yes, you are the father of this meeting,
I must conclude now. Every good thing comes to an end. So is CMRE ASD 9th International Symposium in Diabetes. It's my pleasant duty to extend vote of thanks, starting from our partners in this international symposium, ASD, Professor Inaz, Professor Mohammed, Professor Colin, our organizing committee, our international faculty, starting from Professor Dandona, Professor Devjit, Professor Wasim, Professor Atul Kalan, Partha, Professor Adi Mata was kind enough to have agreed at a last moment, Professor Hashem and Professor Naguib. They've all been, we had 11 international faculties, and it was great interacting with every international faculty, because we tried to pick up the best people, and with their expertise, we tried to have their sessions based on their own interest. We had more than 50 national faculties, again, all who's whom from India. Professor Das, Professor Mohan, Anup Mishra, Professor Rakesh Sai is there, Professor Shashank Joshi, and lot of them, they were part of this. I think we had almost 65 sessions neck to neck, and it has been a long virtual conference of almost 34 hours scientific deliberations coming from most of national and international faculties. our industry partners, especially, I may not be able to name everyone, but USV, Novo, BI, Lupin, Cipla, Sun, Sanofi, Biocon, they were very, very supportive in bringing out this conference to this level. And our event manager, Dr. Hardik, Neelam, Ria, Darshan, Rishabh, Nirav. Rishabh has been our artist who designs our brochure, has been doing a wonderful job. And towards the end, to all the delegates who stood with us, I think we started yesterday at 1:30 p.m. India time, and it is already 9:30 p.m. India time, except 10 or 12 hours in the night when we were not connected. We were connected with most of the delegates. To share with you, we registered close to 5,200 delegates, and throughout the day we had a lot of logins, people coming, joining, of course, in between, leaving, then again coming for different sessions. So it has been a great experience virtually. And I always remember when I talked to Mohammed, who is a very, very dear friend, has been our core strength in organizing all these shows. He says, let's pick up the best out of new norms, which we have learned from COVID. Let's go virtually to reach to entire globe. And this is what we have learned over the last 3 years through these partnerships. We have been able to reach to UAE, Egypt, Middle East, part of UK, and a lot of delegates we had from US also. A lot of international delegates, although we couldn't interact with them because they were on different platforms, but we could get their logins, and I'm sure everyone must have benefited from our entire faculty, both national as well as international. If I am not been able to remember someone or have forgotten someone, I think I'll be excused. And toward the end, my partner, my co-director in CMRE, Dr. Shalini, who has always been on the right side, like working like a very, very close friend, like right hand to me. Otherwise, I think such a conference of this magnitude may not been possible. DIPSI has been our regular partner over the last 5 years, and we are very, very thankful to Professor Sheshai, Professor Balaji, Dr. Sunil Gupta, and many more people. Dr. Hema was there, Dr. Usha Shriram was there, those who have been our partners in DIPSI also. And they not only shared their expertise with us, and they have been throughout our strength whenever we organize a joint symposium with them, either in through CMRE as DIPSI conference or joint symposium, or even our task force members in RSSDI and across India, that women group led by Dr. Usha Shriram and Dr. Benny, Dr. Lily, Dr. Shalini, many more, Dr. Purvi, all of them, they have been part of that. Dr. Anjali, I may not be able to remember everyone, but I think it has been a wonderful team effort. All these things have been possible only through a teamwork. I don't want to take away the credit from any of our colleagues who have partnered with us in making this conference a great success. Thanks a lot, Professor Dandona, Professor Muhammad, Professor Sahai, and Dr. Shalini, everyone. Good night, everyone. Stay happy, healthy, and blessed always. Hopefully next time we may keep it in month of September, on 24th September, Sunday.
Next time is our landmark decade. We're finishing a decade of this scientific fiesta. So next time is our 10th conference, and I'm sure we'll have a grand event and we'll all meet in person for all our interactions.
We'll try
and
to
take
host
this forward.
all of you physically here in Delhi. Thank you.
Okay.
Thank you
very much.
Thank you.
Thank you,
Bye-bye.
sir.
Thank you so much. Thank
Good
you.
night. Good night, Mohammed. Good night.
Thank you. Good night.
Good night.
Bye-bye. Good night.
Good night.
Thank you, sir.
Good night.